हेलो 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 खोलू क्या? हेलो चेक। हेलो हेलो ठीक है। और खोलू क्या? चेक।
लैपटॉप कनेक्ट करना Thank you for coming.
The plants are still alive in your
Alive,
presence.
very much alive.
And you are taking care of the plants also.
That's a reflection on me.
Because you told me, आप मैडम से पूछे थे तो then you have to bring the plants. And you told me.
No, that fellow was very nice.
Yeah.
You're starting? Oh, hi. Great to see you. Long time. Excimer laser. It's already 12.
They're not muscles, they're muscles.
Who's motivating? No, son. Am I right? No. We've seen him like this.
Hello sir, he is there.
Start from fun. It's the hope small. I normally enjoy it.
Then we can wait.
Just
After 2 minutes we can announce.
आपने कॉल किया आपको को पता होगा हाँ हिंदी में बात करें इंग्लिश अच्छे से नहीं आती
ఆర్కే జరిగిందా కరెక్టే బస్ నువ్వు చెప్పింది కరెక్టే బస్ తలైవాగానే ఉందండి నేను అదే
हिंदी डिपार्टमेंट
కరెక్టే బస్ నేను అంత అబ్జర్వ్ రైట్ ఈ పేషెంట్ అదే యమని ఆయన నొక్కకుండా మీ దగ్గర మన దగ్గర యమని
I got DHL
సేమ్ డిఫికల్టీ కానీ లాస్ట్ ఇయర్ ఇక్కడైతే క్యాల్షియం
आपकी तरफ से कॉल आई है मेरे
రజని
तरफ से कॉल है हाँ जी
రజని రజని ఇన్వైట్ చేయండి
मेरे पास कोई कॉल
హ్యాండ్ ఓవర్ టు
मेरे को पता नहीं कौन भेज रहा है क्या भेज रहा है
తెలుసు రజని స్టార్ట్ చేయండి ప్లీజ్
लास्ट नेम CHD
రజని మూవ్ టు స్టార్ట్
Good afternoon, sir. We will be starting the proceedings in B2.
हेलो
This is an industrial symposium. I invite the chairpersons, Dr. Ravi Kumar Alluri, Dr. Shailendra Singh, Dr. R.K. Jain, and Dr. N.K. Mukesh as chairpersons, and Dr. Ashwin Tumkur, Pankaj, Dr. N.K. Mahesh, I've told. Discussants are Ashwin Tumkur and Pankaj Jariwala. Now I hand over to the industry. I invite Dr. Barua sir also as a chairperson to accompany this. Please, sir.
So let's start the first case by Dr. Deepak Davidson about XML laser, uncrossable and undilated ablation.
Well, good afternoon to all of you. At the outset, I thank the organizers as well as Team Viva for the opportunity given. Well, this is how the laser console would look like. It's a pretty large console, more than 200 kgs, and the catheter is a very user-friendly catheter. It goes through a 6 French system, and it's a monorail system. And we all know how it works. We have many mechanisms and how it works. Like you could manage 2 parameters. You could modify the energy. You could modify the repetition rate. You know that it's a jackhammering effect. You increase the frequency, you tend to hit faster, and when you increase the energy, you tend to hit with much more of energy at the hard lesion. So these are the 2 parameters that you could modify so that it works harder at your difficult lesions. Now this is how the laser jet would work inside the saline. You could see that the bubbles that's produced inside the saline is much smaller. However, in the second panel, you could see that this is how the laser jet would work inside the contrast. You could see that the cavitation bubbles are much bigger, so that you tend to have a better breakage of the difficult harder tissues. Well, it's actually very useful in situations like this, the uncrossable as well as undilated lesions. Take you through a few cases. Well, this was a patient who presented with effort angina. He also had an acute coronary syndrome. You could see that there's a calcified right coronary artery lesion. You could see in the lower frame that it's a rugged lesion. It was difficult for us to wire that lesion. So our plan was to go ahead with rotablation. We wanted to get the rota floppy distally. So we tried wiring with a run-through floppy. It wouldn't go through. Then we had to switch over to a Fielder XT wire because of that corrugated appearance of the lesion. Fielder XT could go through, but then the caravel catheter wouldn't go distally. So then at that point of time, we tried also with guide extension catheter, the guide plus catheter. With the support from the guide plus catheter, we were not able to get the micro catheter across, the caravel catheter across. So we decided that we go ahead with lacing. So again over the same wire, the Fielder XT wire, we tried to get a laser catheter across. That was a 0.9 catheter. You could see that initially it wouldn't go through. Then we tried with the help of guide extension catheter, the guide plus catheter. It could go partially in. Then we tried lacing with the contrast. So with the help of contrast lacing, we were able to get across that particular difficult lesion. Then we were able to, you could see that there is some amount of slow flow after the lacing. Usually we do not come across this sort of slow flow after the lacing. But then finally we were able to get across the caravel catheter. And once the caravel went across, we did rotablation with a 1.25 millimeter, 1.5 millimeter, 1.75 millimeter burr at 180,000 and 200,000 RPM. And finally, we were able to dilate it, and that was an angiosculpt used to dilate it. And with the help of guide plus catheter, we were able to get a long stent across, and it was deployed there. And we were at no point of time we were able to get a imaging catheter across that particular lesion. It was so difficult. So the entire procedure was done without an imaging, and finally we were able to get across with a good result. Now this is another patient, a very similar situation, a failed angioplasty, bit anomalous looking RCA, and anterior origin of the right coronary artery. A failed angioplasty was referred to us. We again, you could see that the wiring also was difficult in this particular situation. Again, we were able to get across with the Fielder XT wire. The microcatheter wouldn't go across, but then this time the laser catheter, 0.9 millimeter laser catheter, high energy, high frequency, it could go in very easily. The second attempt, it went in easily across. Once it was across, we were able to get the microcatheter across the rota floppy and then the rotablation, and then finally we were able to deploy long stent with the help of guide plus catheter, and then that was the final result that we could achieve. These were 2 situations wherein it was an uncrossable lesions wherein we were able to get across and get good results. There's another doctor who had undergone a bypass surgery, had an acute coronary syndrome. He went to a nearby hospital. They planned for rota. They were not able to get the microcatheter across and was referred to a possible laser evaluation, laser management to cross into the distal vessel. Again, we started off, we wired the lesion with a regular wire, that is a Fielder FC wire, and then we did that was the imaging that was done in our hospital. You could see that there is a significant amount of calcification in the distal vessel. We wired with a Fielder FC, then started lacing with a 0.9 millimeter catheter. We laced with saline, we laced with contrast, and we also pushed with the help of guide plus catheter. So again, with all these maneuvers, we were not still we are not able to get across. But then this time the fine cross went across, and then it was exchanged for a rota floppy, 1.25 millimeter bar, followed by an 1.5 millimeter bar at 200,000 RPM. And then again, we had to do a lot of things. Imaging revealed huge amount of calcification. There we had to use OPN balloons, we have to use IVL balloons, couple of stents were deployed, and finally with IVL 80 pulses and all, that was the sort of result that we could achieve. TME3 flow, but then still you could see that there is some amount of under expansion in the mid portion of the right coronary artery. Well, this is another case, osteal RCA calcified stenosis, where we wanted to get across the lesion. It was a bit anomalous. We were not able to position the guide properly. In the lower frame, you could see that it was Judkins catheter initially. It was sitting there. Then we switched over to a short Amplatz left catheter. Again, that was difficult to cannulate there. Then finally, we went back to the Judkins catheter. With the help of a guide plus catheter, we tried to push a balloon across. The balloon wouldn't go through, and none of the balloons would go through. Even a 1 millimeter balloon wouldn't go through because the backup support was very bad. But at this point of time, lacing was done with saline as well as contrast. We were able to get across, and then balloon would easily could be navigated, stented, post dilated, and finally we were able to achieve good results. Well, there are situations wherein you have undilatable lesions wherein the lace is going to be useful. This is a patient who had undergone a metal jacket to the right coronary artery long ago. He had a restenosis. Again, he had a second stent implanted in the mid-right coronary artery. Both the stents were under-expanded there. So again, he came back with a restenosis there. That was a point where you see that there is significant amount of under-expansion. Exactly at that particular area, you could see that there is again restenosis there. In the first image, you could see that the stent is under-expanded there in the mid portion. So here again, we went ahead with lacing. We went ahead with lacing was done with 0.9 as well as 1.4 millimeter laser catheter. We used contrast as well as saline to do the lacing, and then again that was an OCT run which shows that inside the stent as well as outside the stent there was significant amount of calcification. That was 1.4 millimeter laser catheter. Finally, we ended up having a drug-eluting balloon over there, and that was the final result. OCT-wise, the minimal luminal area that we could achieve was more than 5 millimeter square, and these were the images. You could see that prior to lacing, you can see that there's an under-expanded stent, and now you could see that following the procedure, you could see that it's a fully expanded stent, and OCT revealed a area of more than 5 millimeters square. This is a patient who had a stent implanted to the vein graft present with a restenosis in the stent boost. You could see that it's an under-expanded stent. Again, we went ahead with the laser catheter, non-compliant balloons, and finally we were able to achieve good results with a drug-eluting balloon in that particular vessel. This is another patient who had a stenting to the vein graft done long ago, almost 10 years ago. Restenosis, heavy calcification, undilatable lesion in the distal portion of the vein graft. It was difficult for us to get across that particular lesion. We used a guide plus catheter, delivered the laser catheter there. The laser catheter wouldn't go through. With the help of saline lacing, we had to use contrast lacing. With the help of contrast lacing, we were able to get across. Here you could see that the contrast amount was low. The ratio was not 25-75, it was 50-50. You could see that there were small bubbles going down the vessel. We'd hardly see it during lacing because these bubbles, the cavitation bubbles, are usually not really dangerous because it explodes and implodes. So you could see that despite that small bubbles being formed there, you could see that the flow is good. There is no slow flow. After lacing, we went ahead with balloon dilatation, angiosculpt was used, and then finally we settled down with a drug-eluting balloon. We were able to achieve a good result in that particular restenotic segment. Well, this was the last case, an elderly gentleman who presented with an anterior MI, underwent primary angioplasty to the right coronary artery, and he also had a simple looking lesion in the right coronary artery. We decided that we'll stent that particular vessel also and stop the procedure. So went ahead with a balloon dilatation, 2.5 millimeter balloon dilatation. It opened up. We stented it with a 3.5 millimeter balloon. Once the stent was deployed, you could see that it's not well opened up. You could see that there is a significant amount of under expansion over there. We tried to get in with multiple balloons. None of the balloons would cross that particular area, probably because it was a shelf-like projection over there with calcification there. So we tried multiple balloons. It wouldn't go through. Then we went ahead with the lacing, and it was again a saline lacing followed by a contrast lacing. And once lacing was done, we were able to get the balloon across, and finally we were able to achieve a good flow inside the vessel. This was the pre and post procedure images. I have 2 more minutes left, so I'll go ahead with one more case and stop. This was a patient who had a stent implanted to the proximal left-handed descending artery many years ago. Now he presented with effort angina. You could see that there is a very critical stenosis in the proximal left-handed descending artery. He was presented to a nearby hospital. They tried to dilate it. It was not a dilatable lesion and was referred to our hospital with a sheath in the radial artery. So we went ahead with a 6 French guide catheter through the radial approach itself. So our options were probably we could have easily got away with a rotablator in this particular situation because it looked like a calcification. They were not able to dilate it. So however, because it was a 6 French guide catheter radial approach, we thought that we'll try with laser and then if not possible, we'll go ahead with rotablator. So that was a lesion there you could see in the caudal as well as cranial images. We went ahead with the 0.9 millimeter laser catheter, saline lacing followed by contrast lacing, and you can see the amount of gain that we could achieve, luminal gain. You could see that these are the pre and post lacing images. These are the pre and post lacing images in the cranial view. You could see that we could achieve a significant luminal gain following the lacing. You could see that it was almost 3.2 millimeter with the OCT following the lacing. We made out that there was multiple, a huge amount of calcification there. You could see that calcified nodules were there, eruptive nodules were there. So all these things were there. That was the reason why it became underexpandable. Then we went ahead with Wolverine. Wolverine couldn't open up the lesion. That was the Wolverine at 18 atmosphere, did not open up the lesion. Followed by IVL, and following IVL, 80 pulses there, we were able to open up the lesion. You could see in OCT there were multiple areas of cracks. You can also see that in the first image it's a calcified nodule and that was deformed and that was fractured with IVL. And then finally we went ahead with stent implantation and that was the final result that we could achieve. Dear friends, the idea of presenting these cases were to highlight the usefulness of laser, the 0.9 millimeter catheter in most of the situations, to highlight the usefulness of laser in undilatable and uncrossable lesions, especially with the case, especially by using contrast lacing in these particular situations. Thank you so much for your patience.
Excellent cases, Deepak. So there's something concept called half lacing. So he showed that doctor where he couldn't cross the laser fully. So even if you like half rota is there. So if he can pass half of it, it makes a benefit. That's what he did in the doctor's case.
Yes.
So that's also a very important concept. Anything, Dr. Mesh?
Sir, even in CTOs many times it doesn't go through, but then following lacing the balloon goes in.
So he need not cross the entire lesion, the total occlusion, whatever the way uncrossable. Even if he cross half, it's the job is done there.
Yes.
It's just that in calcified lesions, laser has not been proved to be of significant benefit. But I guess from whatever you showed us, the takeaway message for me is that the area around the calcified lesion must be getting modified because of lacing. So it's not an absolute no. One can always give it a try and see if it works out. I think that's one of the takeaway messages for me. It's not an absolute contraindication or not absolutely useless in calcified lesions. It is useful, probably by modifying the surrounding area.
Yes, sir. With contrast lacing, what happens is the cavitation bubbles, the size of the cavitation bubbles, it's almost 3 times the catheter. So if you use a 0.9 millimeter laser catheter, with contrast lacing, it becomes almost 3 millimeter in size. So much of plaque modification could be achieved with the help of contrast lacing. However, it's associated with slow flow as well as perforations.
Yeah, I mean, it will be good for instant where the perforation chances are less.
True, sir. True.
And the previously underdeployed stents, how much ever you use cutting balloon or high pressure balloon, we want to modify the plaque behind the stent.
Yes, sir.
So the concept of laser is the energy is thermal, light, and sonic. A combination of these 3 energies actually breaks the material behind the stent, and then the stent will expand. So there's a lot of data of use of laser for in-stent restenosis, especially in those areas where you showed such cases where it is like dog boning and not expanding.
True.
So laser, there's a lot of data where it's not only calcium, there's so many things behind where you want to expand the stent well. So it works very well in this situation.
Just one small doubt. Whenever you are lasing, you are using other devices also. Actually, I have seen razor and all these things. In your experience, is it mandatory to use the device energy in laser, or just a laser is sufficient followed by balloon dilatation?
Almost all these cases are difficult ones. So then you cannot settle down with a single device. Many times you would need multiple devices.
Excellent case as usual. In the first case, actually you used 3 rota, 1.25, 1.5, 1.7, right? Still the last image 20 to 30% residue.
Yeah.
So I was wondering, use the 1.5 rota first, then use an IVL below. Then could it have been a better choice?
Yeah, again the economics, laser, no,
I will answer
rota,
that.
all the second and third ones are all reuse ones.
I will answer that
so
question.
you just take
I'll-
one rota.
Yeah, I'll
advanced-
show in my this thing where I've used laser, I've used IVL, I've used rota, and I've used cutting balloon. Still there is residual. So I mean, sometimes
The post CBG case that I showed, it's all the devices use two rota bus.
Dr. Deepak, it's a great case. Just as Kabadi was asking one question, that how frequently you have to use the multiple tools, or you can get away with only laser?
Almost always.
Almost.
Almost all.
Okay. Then do you have any coronary perforation or anything in which laser? Do you have?
Yes, sir. We had one case, a patient, because we had laser in our hospital, they somehow wanted to have a laser done for an ostial LED lesion. Probably we shouldn't have done that. It was a calcified lesion. It was an ostial LED lesion and it was an angle, 90-degree angle. We started off with a 0.9 millimeter laser. It perforated. We're very fortunate that we were able to deploy a covered stent right at the ostium LED. And
Now, why I was asking the question, because you have seen after laser, you're not able to pass many tools after that also. So in that point of view, if you get a perforation, I think this really is a very difficult situation to handle.
True, sir.
That's another presentation by itself.
Yeah.
Thank you, Dr. Deepak.
Thank you so much, sir.
I called Dr. Anuj Kapadia for his sharing his experience of laser.
Dr. Anuj Kapadia to come on stage and deliver their presentation.
Good. Yeah.
Yeah, hi. I think Dr. Deepak has almost covered
Shown everything what you want to show.
So I'll go case wise again. This is our first case. This is a 58-year-old female with a background of hypertension, diabetes, came in with an inferior wall MI. This is the angio. It's a grade 5 thrombus. Passed in a wire. After we passed in the wire, actually it was again closing. It was closing continuously, so we used a laser. Lased it very gradually. So the secret of this is, I think we need to advance it very, very gradually, very, very slowly. You have to have the patience of actually letting it pass on its own, give it its own time. Got a distal TIMI3 flow after the lacing. This is the OCT run post. You see a lot of red thrombus there. And after that, we stented this with a 2.548. Did a OCT again. Distally, it was a little malopposed, post-dilated it, and got this result. Had little distal diffuse disease. So basically, in thrombotic lesions, laser actually vaporizes the thrombus and causes a little decrease in the distal embolization. It decreases the slow flow and the no reflow, and it has to be actually planned upfront and not after a balloon dilatation or after any mechanical pre-treatment. And we can start with lower settings of 40-40 and gradually step it up to 80-80 because of the thrombotic burden. And we can begin, too much of thrombus, we can still start with the 80-80, but generally, safety-wise, better to go ahead with a 40-40 initially. Second case is a 75-year-old man, hypertensive diabetic, classical angina, showed an ostial discrete RCA lesion. Left was not important. We thought we'll just take in a JR 3.5, pass a workhorse wire, exchange it with a rota wire, and then do a rotablation and go ahead with a regular angioplasty. This was the vessel. Distal vessel was pretty clean. It was more, the lesion was more ostial. Tried to pass a regular workhorse wire, nothing went through. Tried for quite some time. Took a Gaia went in. Microcatheter doesn't go in. This is after a lot of struggle. And after that, we thought we'll just lace it. As Dr. Jain was actually talking about, we did a half lacing here. Catheter didn't go in completely, but we actually could pass the catheter only partially there. But then after we laced for quite some time, we actually could pass the microcatheter across, exchange it, and then it was a run-of-the-mill rotablation, cutting balloon, and angioplasty. Osteal stenting we did with a CPAL wire in place, a CPAL technique, so that we position it properly, the ostium. And this was the final result, had a good expansion of through the IVUS. So basically half lacing is very useful in a lot of cases. It actually helps in modifying the plaque, softens the calcium, and helps in actually allowing the other equipment to pass through. And this along with laser is actually called a razor. Third case, this is a 70-year-old hypertensive diabetic, multiple procedures, multiple in-stent restenosis, had a CABG in 2019, SVG closed, had a stent from left main to LCX. The most notorious area I think that we all need to deal with, the left main LCX ostium, restenosed, had a POBA done, again resurfaced to us this time with a repeat ISR. I think this area actually requires more work. I don't know, whatever we do, it still comes back to us. So did a regular wire, dilated it, and ran the OCT, which showed significant neointimal hyperplasia at the re-narrowing. Took in a laser, went in very gradually, took a lot of time in lacing it. After that, this was the post laser result. Ran an OCT there, a lot of under expansion, prepared the bed very well with a 315, 3.5 and a scoring balloon as well. And this was the final OCT in this patient. Stent expanded well, got a good lumen gain, and finally ended up with a DEB, which actually showed a good result, expanded very well. It's 6 months now, he's not come back to us yet. I don't know what's going on. Once he comes back, we'll know how things are, because that area is actually, I think, troubled everybody, and it's a problem. This is another long segment ISR, PCI to RCA. I had a very tough disease. We dealt with this, had a rotablation, IVL, stented it with a 3.348 and a 3.3 into 28 RCA. Came back with restenosis in multiple areas, osteal disease and distal vessel. This was the OCT with significant neointimal hyperplasia. Again took in a laser. It was very tough to actually go in. Here we did a laser along with contrast as well for better lacing. This took almost half an hour to 45 minutes to lace. It was pretty tough to actually push the laser catheter in, even with a guide liner. Post the laser, this was the lesion. We further, after this, we dilated this with multiple balloons, cutting balloons. And this was, after all the predilation at high pressure, this is what we achieved. And this is the DEB with 2 DEBs actually. And this was the final result. There was still a little bit of under expansion, though it was much better than before. So long segment diseases require guides with good support. Laser is a bulky device, so it's important to have a good support, and in a lot of places we need a guideliner as well, which actually helps us. And lasing with contrast also actually gives a good efficient thing in ISR, where it can help in lacing well. This is our 5th case. This is basically a 70-year-old female, hypertensive diabetic with came in with an acute non-ST elevation MI. SVG to OM actually closed. Wired it. Significant thrombotic burden there. Did a lot of lacing again. Significant amount of. It was done with a lot of patients. Long post the laser, this was the result. There was still quite a lot of thrombotic burden. Dilated the lesion over there. Put in a stent. Took a little longer stent so that it can trap the thrombus there. Dilated it, and then this is the final result. There is still a little thrombus distal to the stent. So SVG grafts are prone to distal embolization. Laser actually helps in vaporizing the thrombus and helps in avoiding distal protection devices. And I think these are the scenarios that way I wanted to show. Thank you.
A great case. Just the fourth cases I wanted to ask you, because you had a restenosis after doing standing. Again, you had done laser, and I could see there around 40% residuals were
Yes.
there. Did you try open and balloon? Because in this
Yes,
kind of
we
situation,
did open as well, sir. We did
you could not do that.
all the things that we could.
And in a because laser, we know the good indication for thrombus, high thrombus burden.
Yes.
So in a given cases, which are the actual cases we'll select for laser in acute MI? Because what you have shown, maybe we can manage without laser also.
Yes.
But actually speaking, laser probably may work in a very high
There are
thrombotic.
these cases where large RCAs, which are actually full of thrombus, where how much ever you do, there's not
Exactly.
enough flow. Or there are certain cases where even though it's a normal sized artery, it recurrently keeps closing. Those are cases where I think
maybe.
laser will help.
Yes. Thank you.
I mean, I'll show a couple of cases where young person of 25 years of age with large burden of thrombus in the left main, and we used a 1.4 laser, and we avoided putting a stent. I mean, it completely evaporated the. So that's one good indication. Other is the vein graft that you showed.
Yeah.
We have 8 cases where we didn't use a single case where distal embolization protection was used. And if Praveen Chandra from Delhi has more than 24 cases, he showed, and no distal embolization protection, and he could manage to vaporize without any complication.
One thing I've realized, sir, is basically once we use laser, it's better to go upfront.
Yeah,
Than actually balloon dilating it, because you've already pushed across a lot of thrombus.
Especially vein grafts,
Yes.
I mean, 20 years old vein grafts, we used to be so scared to touch them, and the beautiful results.
Is there any learning curve for the new?
No, not much. The only thing is, I think we need to be extremely patient and lace it very.
Speed
it has to go very, very gently and gradually.
Because it is a bulky device
Not
and
only bulky
perforation.
device, the effectivity of the lacing happens only when you give it time at the particular point and let it pass on its own over a period.
Do you worry when there's a tortuous lesion? Like
Yes, that's one
That
thing.
is the one thing. Tortuous lesion
that's-
better to avoid
yes, that's-
lacing. That's the one where the chance of perforation is very high.
And it's
because
very
it stops at the vessel wall, and then you start burying the vessel rather than the lumen. So a tortuous artery is better to avoid.
In regular cases also, it's always important to actually have a guideline in place, because it centralizes the lacing and it helps in lacing it.
It should not be eccentric lacing. It should be like in the lumen. That's very important. Otherwise, you land up with perforation.
One place where laser works wonderful is, in our country, people come late. They have an attack, they don't come. They come after, 5 days. Those thrombosis, those, clotting, they don't respond to anything. They respond only to.
Yeah, exactly. I think post-MI angina, late, they come in
late
with high
presentation.
thrombus. I think that is
They're
ideal.
sticky thrombus. They just don't go away.
Yes.
Now with Dugal sir also here, lot of people who have experience. So the foreign and the abroad people, they have this unparliamentary and parliamentary, you can say. These things cannot be used because it's not class 1 indication, class 2. We have no classes, no indications. So where all have you tried which has not been mentioned by you so far?
So these are, I think, the scenarios.
standard,
standard. These are the scenarios you've used.
Off the book, where have you tried?
Not yet.
So let's say, I'll ask specifically, anything in pulmonary embolism, anything in DVT, any experiences, anybody on this?
I haven't.
Nobody has tried. Somewhere to try, Chadda.
So thank you,
Thanks.
Anuj. I request Dr. Ganesh Kumar to share his experience, how he uses laser.
Dr. D.S. Chadha to come on stage and deliver their presentation.
No.
AI didn't work.
AI is not working.
Yeah, going by time maybe. Yeah.
It's correct time.
So I have few cases, and I'll try to skip some of the cases because Deepak showed some cases, Anu showed some cases. So to avoid duplication, I'll let me see whether this has any merit. So in this, I'll avoid the circumflex. Let me go back, go to the. So look at this case. It presented as an acute coronary syndrome. Now we don't know, there is a lesion in the proximal RCA. The ability to reach the mid RCA is difficult, even with a guide like an AL1, 7 French, and we don't know it's a thrombus or it's calcium. So there is a doubt whether it's thrombus or a calcium. So in these cases, if you take a laser, to start the case upfront with a laser in these cases, the complications will be lesser. So after working on the proximal lesion, we took the laser. I somehow, after this, there is one more image where that white thing which was there disappeared. Okay, so most likely it was the thrombus, and we were able to finish the case without any slow flows or no flow. So this is one subset where patients come with acute coronary syndrome, triple vessel situations, I mean non-ST elevation MI, and one of the lesion is critical. It looks, sometimes we get confused whether it's calcium or thrombus. It's a good case to take the laser upfront. This is an interesting case which we had done a live case last year's ijcto. Those who have not seen this live case last year, it will be good to see this one. Primary PCI with a 4 mm stent that was put in 2014 or 13, and then the patient is symptomatic for last few years, and the angio showed that there is a diffuse in-stent restenosis. Now, the primary intention was not to use the laser in this. I mean, it was a live case. We had the modality with us, and when we were trying to wire this vessel, what we realized is, beyond a point, after reaching the mid segment of the stent, the wire won't go I mean, we couldn't advance the microcatheter. Now, if we are not able to advance the microcatheter at the point of entry, it was difficult for us to exchange the wire. So we got stuck. So this is one case where the wire is still in the mid portion of the stent, and we are not into the true lumen yet, but we are sure that it is in different views. We are sure that the wire is within the stent, and then we took a laser at this stage because the microcatheter won't advance. So we used a laser, and with that we created a good point of entry, and then we could take the laser down. We used the laser itself as a microcatheter, yeah, and then we could manipulate the wire. Of course, during the manipulation, we did enter into a false passage at the exit, and then we had to come back with the microcatheter, did a parallel wire, and finally we went into the true lumen, and we finished the case. So take-home message in this case is sometimes in CTOs, especially the hard entry point, provided you're sure that the point of entry is good. I mean, I'm not talking about the regular CTOs. I'm talking about the in-stent restenosis, and you're not able to exchange your wires because your microcatheter is not going in. The laser worked well for us. So that was one indication where we, I mean, sort of innovated on table and said that we'll use a laser even though our wire was not into the distal true lumen. This is a case, let me see what this case is. Yeah, I mean, I think I'll quit this case. I mean, I'll go to the next case because it's a typical in-stent restenosis. Deepak showed a lot of such cases, so I'll go to the next case. What is this case? This is one of the cases where we thought it looked like a simple lesion, but nothing would go. And then even laser couldn't cross, and then there was a calcific spicule there, and we used a combination of rotablation and then laser. You see, the laser is not going, and then don't force it and sit on that at that point and keep on lasing it. You will get a perforation at a softer point. So at some point of time, you have to pull it out and then go with a rotablator and then finish the case. I mean, these are the cases where to avoid perforation, if the laser is not going, and Deepak also showed that he moves from the saline flush to contrast flush. It's dangerous. I mean, sometimes you use a contrast flush. I mean, for those who have not used laser, when we're actually lasing it, we continuously flush with a saline while doing a laser. And if it is still not going through, some of the operators, like how Deepak showed, they switched over to contrast injection. So contrast injection will create that much more energy, and it will go through, but it's a risk of perforation. This was a very tough case. Dr. Prashant Jagtap from Nagpur had got this case, and together we did it in the live case last year in NIC. One of the case where I told you we used everything. Look at that lesion in the circumflex, extremely calcified, 90% lesion, left main disease, LAD disease, and here we had to use all modalities, and still in the end, the angiographically it was not a great result, but patient is doing well. So post-IVUS, nothing would go through. So just to make a passage, we used a small profile balloon in the circumflex, and then we used a laser. And laser did advance a bit of into the lesion, and then we used a shock wave there. And post shock wave, we were able to take the IVUS and study. There was a ring calcium all around, and then we left it there. We went and fixed the LAD because the plan was to do a DK crush. So we finished the LAD, and post the LAD, we came back to the circumflex and again took the laser back and did multiple runs there. And this time, if you see, the laser advances and has done some more work than before. This was after use of laser, followed by shock wave, followed by laser again. Then we came back with a cutting balloon and tried to make some cuts there. We used once more IVL there, and then came back to the LAD, deployed a stent there, and then of course we deployed stents in circumflex and finished the case with a DK crush. So let me take you to the final result and see the final result. It's good. I mean, it's expanded, but this is one of the cases that you can do this much and not beyond, right? I mean, everything has been used. So this is one of the. I think I missed the rotablation pictures in this. So we used all modalities, and we could not still get angiographically complete 0% stenosis there. But nevertheless, we believe that laser can be an additional tool in these type of cases. Though, as you are saying, the Western world versus our world, it is not a class 1 indication in such cases. Now, we spoke about thrombus burden. So in some of the cases, like very young people who come, we don't know how much is the thrombus and how much is the actual atherosclerotic burden there. So 21 years old, early presentation. Such cases, we in the past we used to use an aspiration device and then see how things go. But now, since we have the laser, we try to initially run through with the laser. But in young people like this, where we are expecting a lot of thrombus, we are using 1.4 mm catheter. But the catheter is these catheters are not available anymore in India. So we had a few catheters, we used it, and now I've asked for some more, but we're not getting it. But in our very limited experience of 1.4, it's able to actually remove a lot of clot burden. I mean, lies a lot of clot burden there. And the concept here is it will cover a bigger surface area. So there, in this case, we thought after using even a 1.4 laser, there is a significant amount of atherosclerotic burden there. So we ended up putting a stent, but not so in the next case that I will show you. This guy is again the 23 years old person who presented with ST elevation MI, and look at the amount of thrombus that is sitting in the ostium up to the left main. And I mean, sometimes in the past, we have left these cases if the patient has become stable on table, come back and we see that there is no need to put a stent. Sometimes we end up doing an aspiration, it gives no result, and we end up putting a stent with no flows. So we said, why not do a laser and see how it looks in this person. Again, we used a 1.4 mm laser. See the RAO view, there's a significant amount of thrombus burden is what we felt. And after we did an IVUS run using a Guide Plus, and then we used a 1.4 laser here, very gradual. I think it was a 1.4, not 0.9. It was a 1.4, and then you see this. I mean, it's almost gone. We didn't have to put a stent in this case. So there is some amount of distal embolization. I think that is because of the catheter manipulation, but the actual target site did not require a stent there. I think I should stop it here. Just all of them are instant. Let me take you to one of the case, the last case, which I want to show a thrombus burden in the. Look at the left side. There is a vein graft given to the LAD with a lot of thrombus there. There is a lesion in the proximal part. There is a big thrombus chunk in the mid part. No filter, take a laser. And interestingly, before we put a stent, you see the entire thrombus is completely lysed with the laser. And then proximal part we treated with a stent. So that's it. I mean, so I've added a few cases where we modified our techniques because we had laser with us, and I thought we'll add some more cases to what the previous presenter showed. Thank you.
There was a case in which you did laser, followed by rota, followed by IVL, followed by a non-compliant balloon, and then you went back to laser. What was that for?
So in the beginning, if you see, that laser did not cross fully. Okay, so we still wanted to modify the plaque. So after doing IVL, when it opened, still the IVUS showed a lot of calcium around. So we said we'll again go with laser and try to break some more substances there. We opened the laser. It's an expensive device. Okay, a single run did not give a satisfactory result. So we just said we'll run.
You could not cross it, rota, in that case? Rota, you could not cross it?
Yeah, we crossed it, but it's not giving an optimal result here. Yeah, so there are some modalities where you use everything and still it looks like that, right? Yeah.
So in that case, you have used laser as an additional tool.
Yeah.
So how much additional burden the patient has?
Cost.
Cost.
I mean, cost can go very high. But sometimes, I mean, if your cath lab allows you to use a reuse material, you can use it for free, as long as you have a laser with you. Yeah. Unlike the IVL, you'll have to open a new IVL, you have to open a new rotablator. Or laser, you can reuse it. So it becomes free.
That's the advantage of laser. You can use 4 to 5 times.
Yeah, and maybe more.
More, yeah.
Maybe more. I've known operators who use 10 times.
Yeah.
Yeah.
So thank you, Dr. Ganesh.
Thank
I request Dr. D.S. Chadda sir to talk about his experience and how to use the new modality, IVUS and NIS, in planning a PCI. He has extensive experience on this catheter, and I think it'll be an interesting talk.
Thank you for putting me under pressure. I enjoy it. All right. I think the verdict is just about to come. Yes, imaging is definitely better than doing angio-guided PCI. So this is a paper which came in Lancet, which was a meta-analysis of 22 trials with more than 15,000 patients. And what it showed that if you do image-guided PCI, you bring down target vessel failure, you bring down stent thrombosis, MI, and all-cause death. So, I mean, the outcomes have been uniformly same with both IVUS and OCT. So what it tells you is that imaging is around, and imaging should be used if you want to get your results right. Well, does imaging predict the future coronary events? We really don't know. We know for a fact that all the acute events which happen, they happen because of the lipid burden in the plaque, and it's the lipid core which causes the fresh events. So it's important to know the plaque composition, and if you get to know the plaque composition, you'll be able to stratify these patients in terms of the prescription which you need to give for them. I will come to this a little later in my talk. So whatever we are doing in the lab till now, we are not getting to know the composition of the plaque. You will see there is considerable positive remodeling of the vessel. Then you'll see considerable plaque burden. But whether it is the lipid core in this plaque burden, you really don't know. And neither IVUS nor OCT is going to tell you the composition of the plaque. So there is a need felt for a modality which tells you what exactly this plaque is made of. Well, we have it now. This is the Mercato system, which is IVUS NIS dual modality catheter. You have the IVUS for telling you about the plaque morphology, and you have NIS, which tells you about the composition of the plaque. So with one run, you get to know what this vessel is made of, what are the dimensions, what the morphology of the plaque is, and you also get to know what constitutes the plaque here. Well, it is no different from the catheters which we are using in terms of dimensions, I mean in the size, etc. But it has 3 variable speeds, 0.5 and 2. and it's got dual mobility. That means the lens moves in bi-direction. That means you acquire the image and then the lens on its own comes back to its original position. You don't, unlike the currently available IVUS systems in the country, you don't have to manually do anything. So it's both FDA and PMDA approved. The catheter dimensions as given. So as I was telling you, this is 3.2 French, and it's not very different from the existing IVUS and OCT systems which we are using here. The catheter is very sturdy, and I can vouch for that, and those who have used it, they will kind of second me on that. The catheter is really strong and it works very well. Now, what exactly is NIRS? NIRS is nothing but you are emitting near infrared light at a certain speed, and you are acquiring the reflected NIRS back, and this is analyzed on a scale of 0 to 1. That means on a probability score, you are analyzing it as to what the reflected rays tell you. And you kind of create a color map, which is both in red and yellow. If the probability of a lipid plaque is around 1, you get yellow. Anything in between is orange, and if there is no lipid behind, then it's all red. So as it shows here, if you see a lipid core inside the vessel, it will appear as a very dark yellow thing. Now, has it been validated? Yes, it's been validated. They did about 2,500 cross sections, and on that there was nearly 95% sensitivity specificity of NIRS to pick up the lipid cores. Now, this is how it goes, and this is what is called a chemogram. So along with the IVUS images, you will get a chemical composition representation of the vessel, and it will give you a score which is called the lipid core burden index. So you get a score in yellow and you get a score in blue. Blue is the score for the entire vessel, and for the maximum lipid core burden index, which is called max LCBI, it is the lipid core which is maximum over a length of about 4 millimeters, and hence it's called LCBI max. So how does one calculate? The score is from 0 to 1000. I won't go into the details. And your score, any score above 400 is considered to be significant. This has been validated in studies because it tells you that at this core, you have very high probability of having MACE events at a future date. So this is a case from one of the studies where they had noticed a lipid core, high lipid core burden index, and it translated into an event at the end of 7 months. So it is a tool which helps you predict coronary events at a future date. Now, the evidence comes from a couple of studies. I'll just run through them. This LRP was one of the first studies which looked into nearly 1,500 patients, and with a 2-year follow-up, they noticed that the modality predicts not only the vulnerable patient, it also predicts the vulnerable plaque. That means the vulnerable patient will have 89% risk of having an event, and there is a 4-fold rate of event in a given vessel where the plaque burden is there. So it showed that it identifies both the patient as well as the plaque, and this modality is safe, and max LCBI4 is a very strong predictor of future events. Now, this is what got this modality in FDA clearance based on this study. It has also been studied in acute coronary syndrome patients, where we studied the non-culprit vessels, and in Pacman-AMI trial, it showed that if we reduce the atheroma volume by altering our prescriptions, we'll be able to reduce the coronary events, and this is what came out of this study. I in my practice have had this practice, I know about others. We kind of put our patients on 40 and 80 milligrams of statins, and when they come back, it depends how busy you are. If you're very busy, you'll say continue all. If you're not so busy, you'll say, okay, we'll reduce the statin dosage. Because even 20 milligrams gets down the cholesterol in the Indian patients to a very high level. But if you notice in the cath lab that this patient has a very high LCBI score, you will definitely like to continue statins for a longer period of time. This tool also, in a small study of nearly 200 patients, showed that there are chances of target vessel failures post-stenting. When we stent and the patient comes back with the target vessel failure, NIRS showed that if you leave behind a residual score of LCBI more than 200, there are 1.6-fold higher chances of this particular stent failing over a period of time. Now, this is a small study. The final verdict is still not on. So it's the retained lipid contents behind the stent which can lead to process of in-stent restenosis. Well, can it peep behind the calcium? And this is what I have been seeing over the past 5-6 months which I have used this. Yes, it can. So this is the only modality which tells you we had some wonderful cases, but I think you can stratify these cases well and choose your tools well to kind of get optimal results. You know, in calcium, while you're treating calcium, it's very important that you need multi-adjunctive tools. No single tool is good enough, but this is one modality which tells you what you need to treat this particular case, because it peeps behind the calcific plate and tells you what this calcium is sitting on. Well, the first study in this direction was 2017. There's not too much published literature in this, which showed that they looked at 20 asymptomatic patients with calcium score of more than 300. What they noticed was that this calcium score kind of positively correlated with the atherosclerotic burden, but it was only 40% of these patients who had lipid-rich plaque. And if you look at the LCBI score of 400, only 5 patients, that is 25%, had a high LCBI score. So mere presence of a calcific atheroma does not mean that there is a lipid behind this plaque. And we know in our practice that calcific lesions are very stable and they don't lead to too many events. So this is one modality which can be utilized, and there was absolutely no correlation of calcium score with the lipid burden behind the plaque. So you need a tool which tells you whether there is lipid behind this plaque or not. Well, if I have to say how is it different, this is a dual modality. This is the first dual modality imaging catheter we have in our country, which talks about the plaque composition as well as the morphology. Catheter is very sturdy. It's got a bigger range. Most of the imaging tools interrogate about 100. It interrogates about 150 millimeters. It has higher pullback speeds. It's got bidirectional movement, so the catheter camera goes back to its original position. What advantages? It kind of detects, quantifies the lipid content, and which is probably not possible with the existing imaging modalities. It characterizes the plaque composition, so helps prevent future events. It rationalizes the lipid management outside the cath lab, which is very, very important. And it also detects the lipid pool behind the calcific plaque, so that you can really pick and choose your tools which you need to treat these patients. I'll just run through a couple of cases. This was a 73-year-old gentleman, a diabetic hypertensive with class 3 angina with a normal LV function. This was done as a live case, and I thought it's a straightforward case because I thought we just go in, dilate and stent and do a crossover stenting. This was for ICC Con last year, but the lesion was really, really tight, so we had to use rota, and it took quite some time, and we had to use a step burr approach, 1.5, 1.25, and we finally crossed, and then we did the nurse imaging. So this is what the distal vessel looked like. I will try and see if I can run it a little faster so that we save time. So whenever you see, this is the calcific arc, and you see in the axial plane a yellow and an orange color, which tells you that there is some amount of lipid behind the plaque, and this is what this lesion had. So we had a max LCBI score of 764. So we knew that there is a lot of lipid behind this calcific plate. So apart from rotablation and creating passage, we didn't use any other tool. We just used NC balloons, and we cracked this calcium plate. This was a calcium which was sitting on a lipid plaque. We knew that we'll be able to push it behind. We didn't have to use IVL or cutting balloons or anything that sort. So you see this arc. This is the calcium behind the arc. And we stented, and this was the final run. And since bell is ringing multiple times, I'll just show you the final result. Good result. Second case was a 56-year-old male, diabetic hypertensive, old anterior wall MI. He had come with LVEF of 20%, and he was basically surviving on a sole vessel, which was the circumflex, giving collaterals. I just take 5 minutes.
No, I think you have time. We have time.
Yeah.
No, probably AI.
Yeah. All right. So this was the sole vessel which was working in this individual. The RCA was kind of CTO with 20% ejection fraction. This was a real high-risk case. And obviously, if you have the LAD territory, which is gone and not working, and EF of 20%, angioplasty remains one of the options. The challenge was the severe LV dysfunction. So we had to do it under impella guidance. We went ahead and put the impella in place. Getting into the circ was not a problem. We dilated the circ. The basic idea was to do a circ to left main. And we did the IVUS run and the proximal segment. Again, behind the calcium, we could see a lot of lipid burden, and this is not kind of visible with the other modalities. And the max LCBI score here was also around 545. So we went ahead, we stented. We used 2 stents, 2.5, because the vessel circumflex was very small. So 2.5, into that we put a 3. The left main diameter was 4, so we blew up that 3 to 4. The scoring was done here. This was the post-angioplasty nurse run. There's still considerable amount of calcium in the distal vessel. The stented segment. LCX stenting. Post-IVUS runs. So the image resolution, since I've been using the other existing modalities in the country, but I feel the image resolution of this is very, very good, and it shows you the plaque composition, character, the stent apposition, everything in a very nice manner, and you have a lot of controls to change the picture quality both while performing or during analysis at a later date. This was the final shoot. Then we went ahead and looked at the RCA. We crossed the RCA lesion with the Gaia wire, and we went ahead and put 2 stents, I think 2.548 followed by a 323, this was again guide catheter assisted. I think everybody's spoken of Guide Plus 2, and it's a hot favorite of everyone doing complex work. So we put 2 stents. This was the run post. We were a little selective in stenting. We thought it's a chronically occluded vessel. You had to do a spot stenting. You can't have a full metal jacket. This was the distal vessel, which appeared to be nearly about 2.5, chronically underfilled vessel. So the stents were a little underexpanded. As you can see here, they're sitting on the plaque. We post this run, we did some optimization. Proximal part of the vessel stent diameters grow up, where we planted a 3. Still a lot of job was left, so we post dilated, and the impella was taken out on the table, and this was the final result. This patient is doing remarkably well. His EF is now around 38%, and it's been more than 6 months after the angioplasty. The last case was done in my acquired hometown, which is Nagpur. This was a case done in Avanti Hospital, and this was a distal left main tight, more of osteal LAD disease. So I must show you these runs, because this is a very nice quality image, which I think all those who are using IVUS will appreciate, that the quality of image is really, really good. And if you see them, we have a concentric calcium and a complete lipid arc behind this calcium plate. So this was the other run is from the circumflex. Circumflex appeared pretty okay. Even the ostium of the circumflex appeared okay. So we were kind of sure that we need to do a provisional stenting.
Can you pause us and show how it looks behind the calcium?
Okay. I was running through the presentation because I thought.
No, you have a couple of minutes.
Okay, fine. So this is, as you see here, there's a considerable plaque burden from, say, about 3 o'clock to nearly 12 o'clock position. But you see everything is red. So that means there is no lipid plaque behind this segment. Now there is a calcific plate which starts. So if you see now this arc, it tells you that behind the calcium there is considerable lipid which is sitting.
So the yellow ring.
Yellow ring. So you also get a parallelly, you'll get a chemogram. That means it comes directly there. I'm not putting it here. So that gives you that quantifies and also localizes as to where in which part of the, so you have an axial as well as longitudinal lipid pool distribution which is available to you.
Does that also mean that the calcium is thinner?
No. So NERS was first tried in the brain. I did a lot of reading on that. So they used it in the brain, where they would put the near infrared light through the skull and study the animal brains. So that is where it first showed that it is capable of picking up lipid pools behind the bones. But there's not much published literature on this. I've done close to about 30 odd cases where I've kind of looked at these pools behind the calcium plate.
So how does it help to change the modality of treatment?
Oh, it's like, you have pebble sitting on a pillow, pebble sitting on a rock.
Okay.
Your case was essentially calcium, which was horrendous.
Yeah.
You need all modalities. And I showed you the live case which I did. Moment I saw there is considerable lipid plaque behind.
Easy to break.
Easy to break. NC balloons. That's all. That's all. So you can easily push it back.
So the
You can.
thickness is less.
Absolutely. It's pebbles on a rock, So that means there's lots of calcium or lots of this thing, and it's thick plate calcium or nodular calcium which is sitting behind. So this is how it looks, complete arc, and behind this arc, if it's all yellow, that means it's a lipid pool which is behind that. So the post-PCI result, if you can appreciate here, there was a lot of calcium there and stent under expansion. Now these are segments where you just can't go very aggressive because you can cause a lot of damage. So the stent also hasn't expanded that well here. That was the circumflex which went, and there's considerable under expansion there. We worked on it. The left main segment appears to be pretty well opposed and well expanded. It's about 1 or 2 struts coming out into the left main. We optimized it further, but the apposition on one particular valve was good. There was positive remodeling, so we didn't chase, because if you chase under such circumstances, you can cause perforations. And this probably was the final result of the angioplasty. Well, to conclude, I would say that in Dual Pro, we have a catheter with us which kind of tells us about the morphology and the plaque composition. The chemograms which you get help you stratify the patient on the table and outside the cath lab, because you can rationalize your prescriptions. We need more work in this front. We need more trials to substantiate what I have shown. But this is a modality which has considerable advantages over the existing modalities which we are using, and it certainly helps in improving the patient care. Thank you for your patient care.
Just one small question. Can you find out I believe NIRS is a very useful tool to find out the vulnerable plaque. So at what level you can say LCBI index or maybe chemogram? What point of time you can say it is a vulnerable plaque?
So the definition classically of a vulnerable plaque is based on the fibrous cap thickness, which is about 65 micron. Now this cannot be measured on any of the IVUS modalities. So this is essentially based on the OCT definition. What has been used in Prospect 2 trial, which I skipped, they used a couple of things to define a vulnerable plaque where they went ahead and stent. They looked at the plaque burden of more than 70%, they looked at the fibrous cap thickness of less than 65, and they looked at LCBI score of more than 400 and a diameter stenosis of less than 4 millimeters square. They used these 4 things. Any of 3 out of 4 present, they would stent. Now, classically, vulnerable plaques are picked up on OCT, not on IVUS-based modalities. You can use as surrogate markers the plaque volume or the lipid core in that plaque. Now, I have done this in ectatic vessels. I was excited, there's a lot of ectasia. Not even a drop of lipid in there. So we mentally form an image that if you see a gross ectasia where you are going to cut and deb, NERS shows nothing. No lipid at all, where you feel that, okay, if I put on lipid lowering therapy, you'll benefit.
So just 2 points to add. I'm predominantly an OCT person, never liked IVUS because I thought it was a black and white movie. And I'm changing because I found this system is extremely good. It's got a variation from 35 to 61 megahertz. 65 in the same catheter. That's phenomenal. You just need to flush in between with saline. You'll get the images clarified and absolutely clear, much lesser thinking application required. And I did, as usual, go out of the book and retry it in my peripheral vessels also. It works very well in the peripheral vessels of 8 millimeter diameter, 9 millimeter, 10 iliac vessel side, right? Because I
Dr.
need to
Mahesh,
see.
that is true for all IVUS modalities because the depth of IVUS is about 10 millimeters, so you can use IVUS in all. It's just that it will show you what the peripheral.
The clarity was much more
No,
superior.
So
with,
that I've been saying that the clarity of this tool, and in fact, I've gone to multiple centers, and people end up saying that it looks like black and white OCT. Just wait, the same company will give you black and white OCT at the end of the year also. So it.
Stick to color.
Actually, why I asked this question, because latest PREVENT study, the PART group, they presented and published in a vulnerable plaque, angioplasty in a vulnerable plaque. So they have done a good amount of NIRS and IVUS in that particular study. That's the reason I thought.
No, I mean, there's work already done, sir, on that front. And I told you these are the cutoffs, definitions, 3 out of 4. And Prospect 2 sub-study is one of the most quoted study, but it is still controversial. You just can't go about stenting vulnerable plaques because you don't know what the natural history is.
Thank you very much.
Thank you, everybody.
Thank you.
Thanks for the excellent discussion. Thank you. I think we should close this session. Thank you.
To Industry Symposium 2. The chairpersons for this session are H.K. Bali, Karunakar Rapolu, and Sudhir Koganti. The discussants for this session are Athuluri Ravikant and Sudham Jani.
Good morning, everyone, or good afternoon, I guess, everyone now. I think I'll get started right away, given that we're a little bit behind schedule. I see lots of colleagues and friends both here and in the crowd, and so it's a privilege to be here to talk to you a little bit about MCS-supported PCI. And I'm going to start by saying that there's no such thing as MCS-supported PCI. Okay, that's not the idea. That's not the point. The purpose is to make our procedures safer. And the way we do that is by hemodynamically tailoring CTO PCI. We recognize that this is not about one device. It's not about one support technology. It's about making procedures safer by understanding what's going on inside the heart as we work on it. This is something that the surgeons have been doing for a long time, so we really ought to be able to do this better. These are my disclosures. Let's consider this case. 63-year-old, usual cardiac risk factors, ischemic cardiomyopathy, EF 15%, with recurrent episodes of chest discomfort, palpitations, and syncope, non-sustained VT on a cath, and a big area of viability in the inferior, mid-apical and inferior walls with an area of ischemia identified to match. Here's this picture. So you can see the RCA filling retrogradely there. There isn't a whole lot from an LED septal perspective. Most of the collaterals, unfortunately, are ipsilateral, right to right. He has chronic kidney disease, his creatinine's in the mid-2s, and this does not look like a particularly easy case. So given his EF limitation, our standard practice for this type of a case is to start with a hemodynamic assessment to understand where along the functional continuum, and we'll talk about that in a minute, where along the functional continuum this patient is, where along the compensation-decompensation paradigm he's going to live, because that's going to affect whether or not we're going to go ahead, whether or not we're going to put in a support device, whether or not we're going to stop. So these are the initial hemodynamics, right atrial pressure of 3, PA 27/5, mean 13, wedge 7, index 1.65, cardiac output 3.97, cardiac power output, so MAP times cardiac output over 451, which is a measure of watts, measured in watts, is 0.69. 1 is normal, below 0.6 you're in shock, below 0.4 your outcome of mortality starts to rise rapidly. So the question for this patient, who is clearly not a well heart, right? This is a very, very poor cardiac index, but he's sitting there in front of you with reasonably good pressures, is do you use mechanical circulatory support for this very complex case, right? The constant bet that we're trying to make is a patient going to decline or decompensate during our procedure, where we're going to be, by necessity, reducing blood flow to perhaps segments the patient's living on while we try to get flow back antegrade? And if everything goes right, can something still go wrong? Right? It's very hard to prove the counterfactual. That's the bet we're trying to make. And if we decide to use it, what is it that we're trying to accomplish? Why are poor LV function patients so high risk, right? If we compare these two hearts, the sick heart on the left versus the good heart on the right, what do we see? We see a narrow pulse pressure on the poor heart versus a larger one. You see baseline higher pressures in the poor heart. You see baseline left-sided higher pressures and poorer cardiac indices. And so what this tells us is that these two patient groups are fundamentally different, right? They start at fundamentally different baselines, and as a result, we're dealing with a fundamentally different substrate when we take them to the table than the patient who has an EF of 50%. And I'm not advocating for a moment that we ought to be frightened of doing the cases. Our patients need what they need, we do what they need. The question is, how do we risk assess every one of the cases we put on the table so that we are best prepared to deal with trouble, right? So why are patients with LV dysfunction at high risk of hemodynamic decompensation? What is it that we do? Well, this is a different case. It's a retrograde CTO that I did with this right had been occluded for a long time, ambiguous proximal cap. Again, this EF was south of 20 with tons of calcium here. And for what it's worth, I ended up using a 2O burr in the subintimal space proximally in this right because nothing else would open the vessel. And the reality is big guides in both coronary ostia obstruct flow, right? Where we create a fixed stenosis of 64% with an 8 French guide. So it's understandable then that if we're living on every last red blood cell going through the artery, this is a problem. What about here? You get obstruction to major coronary flow and major collateral compartments as we put gear in. And sometimes because these procedures will last several hours, that's a long period of ischemia. Why do you think the surgeons say no? It's not because they can't get the graft on. It's because they can't get them off pump when they're done because of the recurrent ischemic hits. How about when you have to rotablate? So this was that patient. So putting a very large burr into an artery, maybe through the subintimal space where there's a ton of calcium on either side, and getting a period of no reflow could be very costly in this type of an individual if they're living on the antegrade flow through this vessel, particularly now that some of your pressure heads will have changed and your collaterals won't be filling as well. What about this? What about donor vessel thrombosis or donor vessel dissection? I had one of these about 3 weeks ago in a 48-year-old dental surgeon who had been totally disastered at another hospital. And I was very happy to say I got his RCA opened in about 15 minutes, and it was a beautiful result. And I said, I'll go after the Circ CTO too. And of course, greed begets trouble. And that's when I had this left main dissection. Thankfully, I had wires in and we were able to stent it quickly. But this happens, right? And even in the best of hands, it happens. And so recurrent flow interruptions from things like dissections, and even these, secondary to long balloon inflations, can result in worsening LV function. How about the loss of side branches behind dissection planes that sometimes we don't see? We've all had that scenario where you re-enter somewhere and you lose a branch that you didn't expect to lose, or you have a dissection plane that flops in the wrong direction. And then, of course, in long cases with recurrent blood flow interruptions, large fluid shifts and contrast volumes, big sedation swings in MAP, the patient's moving around, you start to get inflammatory vasodilation. These are all problems. So how do we mitigate this risk? Right? These are all problems that can happen. So the idea is to try to set ourselves up so that we are reducing hemodynamic load. And that starts by recognizing the problem, right? So where are all of the places that there is a hemodynamic load, this concept that we'd like to introduce, the places where the hemodynamics are going south or can potentially go south? Where are they in this case? Well, you've got a post-CABG patient. And so those individuals with poor LV function, generally speaking, have poor hemodynamics because they don't have normal pericardial hemodynamics. We're going retrograde through a major collateral, so that's going to block off flow. What about the severe calcification? We're going to have to atherectomize, potentially use lithotripsy, potentially both. Lots of long balloon inflations. What about the big guides and big guide extensions, right? We talked about how we're inducing stenoses for periods of time during the case, right? We're blocking off flow. And then there's the potential loss of big RV branches that matter. And then there is the underlying severe LV dysfunction, right? So these are the hemodynamic loads in this case. Now, how do we mitigate these? Well, we can mitigate them in all cases. We just have to be willing to look for them. Post-CABG piece is not modifiable, but we can certainly move our guides out and sit them in the aorta, especially when we have wires down, to be able to reduce flow interruptions. The both guides can be disengaged if we're not in use, particularly when we're checking ACTs or when we're getting IVUS ready or doing these things that don't actually require a guide catheter to be sitting in the coronary. It's just active management. Slow, steady atherectomy, gold standard techniques to minimize likelihood of trouble, and avoid dissecting across large branches. So this means the obligatory use of intravascular imaging for any complex cases that we do. And then it comes to considering percutaneous mechanical circulatory support. So let's think about this for a second. This is the functional continuum. Put this concept in your heads to represent your case. Okay, this is your patient and this is their broken, cracked heart. And when they start hemodynamically decompensated, they're near here, where the rocks are very close to the bottom of the boat. And so even the slightest push in the wrong direction and their boat will run ashore and hit the rocks. So instead, we diurese them, right? We help them compensate. We bring them back to a place where water is deeper and we've got a better likelihood of getting through a case safely. But now what about all this stuff? What about all of the unseen hazards in the case that we talked about? The dissection plane that goes the wrong way, the thrombosis that occurs that you don't expect, the no reflow from the rotablation. Now some of these hearts, the weakest ones, actually need help to get across these unseen hazards. These are the ones that we need to try to identify and find, because those are the patients that are actually likely to benefit from MCS without the harm of large bore access and potential bleeding, because these things aren't free, right? They're costly, both biologically as well as financially. And so the goals of MCS-supported PCI then, hemodynamically tailored PCI with mechanical circulatory support, are to maintain hemodynamics during your case, to facilitate safe, complete, and optimal revascularization, and to do so within an acceptable safety profile. So there are three primary options here in India that are available for this type of work. And I won't belabor these concepts too much because I think everybody in the room is reasonably familiar with them. But this is a PV loop after a balloon pump is started. And what you see on the side are your numbers, right? You see that your mean PA pressure comes down very modestly. Your wedge pressure comes down by 2 points with the balloon pump on. Your coronary blood flow increases ever so slightly. Now let's put a major left main stenosis in, right? Now this is what happens when you've actually reduced coronary blood flow. So now you see your contractility, the ESPVR, starting to drop. And what's happening to your cardiac output? It's getting worse and worse and worse and worse, despite the balloon pump being on. And so this is probably not the right device for a patient who has very little reserve, because a balloon pump that counterpulsates need pulsation to work. And back in like the ages ago, the guy's name is escaping me now. There's a variety of these different hemodynamicists that have shown that actually until you relieve the stenosis ahead of a balloon pump, you don't really get augmentations in coronary flow. What about an Impella? So now we'll start the Impella, and you've got a reduction in hemodynamic demand because you've reduced the amount of fluid within the ventricle, right? Your end diastolic volume has come down. Your represented by your wedge pressure. The amount of work that the heart's doing with each beat has come down because the area under your curve is lower. And your cardiac output is maintained despite this left main stenosis. It's not perfect. You obviously do get a reduction in cardiac output. But thankfully, you don't get it reduced to the point where you can't support a mean arterial pressure. And what this does is buy you time over the course of those unseen hazards to ferry you across them to deeper water so that you can actually help your patient recompensate. That's what makes these types of procedures accessible for those of us who do them. There are some of these procedures you just can't do without some sort of support in place. And if you think of the sick heart, this is ECMO now being put on. If you think of the sick heart, you do a great job of increasing body flow with retroaortic flow through the ECMO cannula, right? Your body's going to survive. But look at your cardiac output. Your cardiac output is in fact dropped, right? And your myocardial oxygen consumption's gone up because your afterload has gone up with retroaortic flow from ECMO. And so in an injured heart then that already can't pump, you put yourself into big trouble if you're now forcing this thing to pump against this left main stenosis that is going to reduce the ability of the heart to do much work and overcome that afterload. And so here's an interesting hemodynamic approach to selecting a device, recognizing that ECMO is probably not appropriate for this given the nature of what it does. And so you're picking between balloon pump and Impella. Balloon pumps don't augment cardiac output very much, but I don't think that it makes any sense to put a big 14 French device into somebody with a normal EF. In my practice, that's just not a thing. I analyzed all of our hospital's data. Our median EF of implantation for an Impella is 21%. Our median syntax score in all of those cases is 42. Our delta syntax score is 36. So we are going in there to win. And we don't use it in everybody. But the people that we do use it, we think about how much cardiac output they're missing. And the way you do that is by thinking about their body surface area, right? So if your target cardiac index, your cardiac output over your body surface area is 2.4, that's what perfusionists typically use, a 2.4 or 2.6 cardiac index to decide on full flow. Then what you require in order to achieve that is 3.84 liters per minute. And an Impella CP with Smart Assist can achieve 4.3 liters per minute. So that makes this a really good device for this type of an individual. And perhaps also for an individual that's got a bigger body surface area, recognizing that it's not going to give you full flow in the setting of total collapse. But you may not have total collapse, right? You may have only partial collapse. It's not like your heart's going to completely stop. And if it does, yeah, you may end up having to go onto VA ECMO in those scenarios. But it's a rare problem to have. What does the real world experience say? So this is from Progress CTO, right? This is 7,170 odd CTOs that were studied, where the individuals who ended up requiring prophylactic MCS in this study were typically a little older. They had more common history of heart failure, duh. Their EFs were lower, so 31.5% was their mean EFs, much higher than ours in Canada and arguably here in India as well because we have a slightly more rationalized paradigm. There was a lot of calcification. The JCTO score was a full 1.5 points higher. So these are more complex, more difficult cases. And the retrograde approach was in 45% of these patients versus only 30 in those without MCS. So people were thinking that this might cause risk. And our own retrograde paper from Open showed that one of the most common complications of the retrograde approach was hemodynamic collapse. So typically in this study, which was US-based, the most common device used was an Impella CP. But we need a more rationalized approach than to be putting big devices into everybody, right? And so this was a paradigm that we wrote here in India for the Indian paradigm, which is a lot more conservative than what they use in the US. And for what it's worth, this is the protocol that we use in my institution in Canada. And my administration is very happy about this. We have no reimbursement either for this device right now. So this is actually a codified approach that is a little bit more conservative about who gets the device, but it's an approach that works. And so far it has not steered me wrong once. What we need is our colleagues like you to help us validate it, which is what we're working on now. But urgent MCS use is really what we're looking at, right? These are the ones that we missed. Those are then the predictors of the people who should have had it in the first place. So the types of urgent MCS use in the Progress CTO registry were IABP in 48% and Impella CP in 40%. And urgent MCS resulted in lower technical success, lower procedure success, and a MACE rate of 31% versus 2%. So this is the group of patients we need to figure out, right? Who are these people? These are the ones that ought to be getting percutaneous MCS to facilitate their CTO PCI. And so this is where the Progress CTO score came from, where there are 3 simple factors. Retrograde use, yes or no? Your LVEF, is it high or low, yes or no? And how long is your lesion? Okay, and what you get is a number of points on this. Your total points then gives you a logarithmic risk of needing urgent MCS, i.e. being one of the patients that we identified as trouble. And so at 155 points, your risk of urgent MCS is 50%. What was ours? Ours was 160. And so not surprisingly, we stuck an Impella in. We went ipsilateral right to right. So I wired that little tiny collateral, took a couple of microcatheter pictures. We couldn't use much contrast because of his kidneys. Managed to identify where the connection was. Got retrograde with this at the time was a Xi'an wire. This was before we had access to a Shuo 3. This was some years ago now. And there's the retrograde access that finally got through. It was a pain. Okay? And then ultimately completed reverse cart with a standard balloon wired out into the aorta with the Fielder XT, which is not the wire I use for that purpose now, and here's our final result. So this guy did pretty well, but it was a hairy case for the whole thing. So these are patients that are going to need our help, but there is a component of them that are really at risk for a terrible event. And so it's our job to mitigate risk where we can mitigate risk and then recognize that group that's likely to go on to urgent MCS and perhaps need the support of a mechanical support device. And the way we can choose which device is to recognize which patients are really at risk for serious collapse, and then choose the device that's going to give us as much cardiac output as we need. Thanks very much for your time and attention.
Excellent talk as always.
Thank you.
A couple of points. One is that when we're doing a CT or PCI in a severe left ventricle dysfunction, we're talking about a stable severe left ventricle dysfunction. The data to support that would be limited.
Yeah,
we would need
is.
patients
Yep.
who would have angina or demonstrable ischemia at least than one part. Second thing is hemodynamics only tells us part of the story. We look at the RA pressure, PA pressure, and cardiac output in this particular patient. We would need ABG also to tell us what are the lactate level.
Yeah, sure.
So that would also guide us how to go about.
I mean, if your lactate level is up, frankly, you should not be starting the case unless it's an emergency case, because then you're in shock.
That's what I'm saying.
Then you're in shock, right? That's different.
That's why we need to identify the entire clinical situation of that person, not only severe left ventricle dysfunction and compensatory alpha. So how much is acute decompensated part of that part as well?
That's good comment. We can't, hemodynamics are not the isolated phenomenon. These are assuming all other variables are stable. So you still have appropriate urine output. You don't have liver disease with ASTs in the thousands. You're not in shock.
I think that algorithm is covering all other patient
That's the
features.
purpose of using that algorithm.
Yes.
So we just
that helps us
reproducibly make
not only the
decisions.
hemodynamics but the patient profile, entire patient profile we can see and we can decide.
Yeah, you know, Jamie McCabe's old spitball algorithm, right? That had things like lactate in it, the amount of valvular regurgitation, these things. And it wasn't, when they analyzed the data, they actually wasn't all that predictive in a lot of the facets that were on there, but it did seem to predict their decisions, right? It seemed to fit with the rationale that they were using. But the rationale that we use in environments where you can't necessarily implant a pump at, you know, in a reimbursed environment is a little different, because let's be honest, I think there is a big component of patients that do just fine on a balloon pump, right? It's only for your really sickest patients, the ones that are really at risk of decompensation, where you can identify the people that are really going to tank, that you need an Impella, and that's plenty of patients. The problem is we actually just don't do those cases out of that concern, right? The risk is too high, so we won't do the case. That's the problem. That's the group of patients where we actually need to grow our interventional volume, because it's, you know, it's, nobody's saying you take an Impella and you put it into everybody. That's crazy, because there's a risk to those things. What it is recognize those patients that are actually being said no to, who could benefit from the therapy, and then use the pump to help those people get their cases done. That's where this is going to make its biggest mark.
How frequently you use prophylactical this Impella or means mechanical circulatory support device, sir?
So my practice is a weird practice, right? I don't do a whole lot of normal stuff anymore. We do between 150 and 170 CTOs a year. Our average Impella volume on a year-to-year basis is somewhere between 25 and 35 pumps. But if you look at my total PCI volume, it's less than 5%. Probably less than 2% is my guess.
So any role of Impella 2.5 in this?
So in my humble
scenario?
opinion, that's a Kelowna. It's like, it doesn't, no.
I think, Sanjoy, you made a very good point that, you know, we have a guide catheter there and we're including the vessel, and we should not be keeping guide catheter too long. And I think it's absolutely important. Even when we're keeping the guide catheter there, it's good to remove it and let the artery breathe.
Yep.
So that is important, because that is what salvage is.
These are, I think, those are the things that actually differentiate people who are doing PCI from interventional cardiologists, right? Interventional cardiologists are cardiologists first, where we're thinking about these things.
And internist even before that.
True, right? True. So we're thinking about these things, as opposed to wire, balloons, tentractaferi. Nobody really thinks when they're doing it. You know, that's the, I think that's the real key.
I think your volume and your caseload will help to decide what to do in
No doubt.
high-risk cases and all.
No doubt, no doubt. Alrighty, thank you.
Excellent presentation.
I now request
Sharad.
Dr. A. Sharad ready to come on stage and deliver their presentation.
Thank you, Dr. Sanjog, I think, for such an extensive and illustrative presentation on protected PCI in multivessel disease and more importantly in CTO interventions. Now I'll show you a case in which we have done a protected PCI with in a multivessel coronary artery disease with a CTO. So my patient is a 46-year-old male, hypertensive diabetic, who was diagnosed to have cardiomyopathy and was on treatment for heart failure. Came 8 months later with acute decompensation, with acute SOB to emergency department. So patient was immediately assessed, his heart rate was 120 and blood pressure was 90/50, and they started dobutamine quickly and went for further assessment. So you can also see patient has S3 gallop. And this was his ECG at the time of presentation. There were no apparent signs of ST elevation MI except for mild ST changes in V2, V3, V4, but there was no evolution of these changes even in subsequent ECGs. And this was his echo. So echo where already the diagnosis of cardiomyopathy was made before. So there is hypokinesia, I think differential hypokinesia. Interval is slightly less mobile, no doubt, but there is no mitral regurgitation and overall significant LV dysfunction, severe LV dysfunction. And this was his RV function assessment. I'll come to it subsequently. So this patient lands in a shock stage, stage C. As this patient, creatinine was elevated and urine output was also very borderline. So there are signs of hypoperfusion, which made us, put this patient into stage C. So the next step is, we started inotropes and we kept a close watch on this patient. That's what we have to do. We have to keep reassessing these patients, shock stage once in 6 hours. And see, he came back to stage B in next to 6 to 12 hours and remained so in 12 to 24 hours. And we could also pull down his inotropes to almost 50% from the time of admission. So he is more or less on improving trend of shock, and with the inotropes coming down. As ECG changes were not so malignant, so we thought we'll take patient after hemodynamic stabilization. So his troponin I was hugely elevated. And then we planned the coronary angiogram once patient became slightly better after 24 hours. So this was the angiogram. You can see, sorry, it is kind of fast and furious. So there is LCX disease and there is an LAD, total occlusion. You can also see RCA is filling from. So where is laser? Yeah, sorry, yeah. So, yeah. So you can see RCA is filling kind of retrograde, and there is a total occlusion even in right coronary artery. So, and the LAD is also totally occluded, and which is filling from the conus branch of right coronary artery, and there is also OM total occlusion. So this was the anatomy. So, and this was the final diagnosis, kind of ischemic cardiomyopathy, with a decompensated heart failure, reason for decompensation being non-QMI, and he was in SCOI shock C, and with inotropes, he was improving and came back to kind of B or A in next 12 to 24 hours, more or less maintaining the same, and renal failure output improved after starting inotropes, and these are the scores. You can see high Euro score, high STI score, mainly because patient was in shock. That completely changes, surgical risk of these patients as well. And CHIP score was 7. So we had a heart team discussion. So, and one of the question for surgeon was graftability of LAD, because there was also diffuse disease in this LAD. So surgeon literally turned down this patient, and another reason why he turned down his patient clinical status, that is a cardiogenic shock, which obviously increased the surgical risk. So finally we ended up in a decision of protected PCI. So, and yeah, the reasons for protected PCI is this. So there is an hemodynamic.
Sharad, before you go further,
Yeah.
do you think there's an acute and chronic occlusion of LC of RCA?
No.
Well, there's
So,
some dye sticking there at the retrograde dye which you injecting.
Yeah, and I mean, in retrospect, so in
even
retrospect,
looking at the overall clinical scenario.
yeah,
with STC,
I
the
can
change is
tell you
something.
in retrospect,
If you go to the angiogram,
it was a very tough lesion. It was a very tough lesion. I had
it might be
a lot
acute
of
on chronic.
time,
It might be an acute
cross.
on chronic, but that looks to be the culprit lesion.
Possibly, but retrospect, I mean, in hindsight, I can say it is a CTO of RCA because I had a lot of struggle in crossing the lesion and, opening it. LED was much easier. LED, there is a microchannel. In fact, I'll show you with microcatheter injections. So yeah, there was severe LV dysfunction, and patient was already on inotropes, and there are CTOs both in RCA, LED, and we might end up in using calcium modification or guide extension. So what is key here is every heart failure you have to understand, is it biventricular or univentricular, because most of the heart failures are biventricular. Only 24% is univentricular. So in this kind of patient setting, it is very important for us to understand how the RV function is. So why we are so obsessed? The moment you keep impella and start sucking from LV, your septum is shifted, and your RV dysfunction also becomes more clear. So after putting an impella, so that's why understanding RV function is key in such patients, especially before you take them into lab. So, and the best marker which was well studied is PAPI, and if it is less than 0.9 in acute MI scenario, I think those are the patients where the chance of RV failure setting in after putting VAD device is much more likely. So this is our RV function assessments of the patient. You can see the TAPSE, nice TAPSE, and TDIF, tricuspid valve, and these are the right heart catheterization parameters. PAPI was 1.7. We want it to be more than 0.9, and PCWP by CVP is 0.2. It should be less than 0.8. It shouldn't be more than 0.8. So that clearly says mostly his RV function is pretty good. RV may not be an issue, after support. We can go ahead with an LV support. So which support? So I mean, if you look at IABP, the kind of support it gives in this kind of patients who is already severe LV dysfunction, though I have not done cardiac output measurement in this patient, so he is already having a severe LV dysfunction. If this patient deteriorates in the course of procedure, it is very tough for IABP, to really give a support. That's the reason we didn't consider that. And as RV function is normal, I think these two, Centrimag device or ECMO, is need not be an option. So we went ahead only with the LV support, that is Impella CP. One issue, once the Impella is in, the problem with using your AL catheters, all that stuff becomes very tough. So the combination of CTO with Impella, that is one issue. So using AL guide is very, very difficult. That was my experience. So, and you can see I tried engaging from femoral, but I couldn't able to cannulate right coronary artery from femoral. So then I have to switch my guide to radial. So with the radial, I was able to cannulate, and you can see I'm only giving microcatheter injections because RCA is diseased from beginning, and patient was on renal failure. So this is a channel tracking wire, and to reach this place it took us almost like 3 hours. So I escalated wire and then de-escalated back to filter XTR, and then we could reach this stage. After that, nothing went in. So I had to do 3 granuloplasties in this total occlusion segment. So one 1 mm balloon we ruptured, one 1.25 and one 1.5. So after 3 gonadoplasties, I could able to take my microcatheter down. So, and once microcatheter is done, and also you can see, there is an anchor balloon which is sitting in RV branch to send the balloon down. So anchors and also increases ischemia can cause, further drop in hemodynamics in these patients. So yeah, so finally, we could able to cross into PDA, and then you can see this is a kind of hydrodissection which we caused by, injection into RV. At this stage, actually the reason why I injected is patient's map suddenly dropped despite, impeller flow is on. And we checked CVP. CVP was fine, more than 10. So despite more than 10 CVP, his pressure was low. That clearly indicates, it's related to LV. And that's when I injected. So entire RCA was completely dissected. So we quickly stunted proximal RCA just to stabilize, hemodynamics, and then did a drug-eluting balloon to P dissolution and came out. I think this is a final RCA result which we could achieve in this patient. And then we went to LAD. This is LAD. I'm giving dual injection with a microcatheter in conus and direct injection into left system. This is mainly to reduce the contrast load as the patient has already renal function. So you can see here there is a microchannel, clear microchannel, but the only problem is there is a side branch, and the microchannel was coming very acutely angulated. So we had a tough time even to send wire into LAD. So okay, so first I wired diagonal, and then so we kept a balloon and occluded diagonal and tried wiring LAD. So we couldn't able to do that. And then I took a double lumen catheter, and then we tried crossing into LAD. So at this stage, actually, we could cross into LAD, and you can see, with a double lumen catheter inside diagonal. And then we went ahead and did a cutting balloon and scoring balloon to diagonal, and then finally an I was followed by, stunting. So these are the post-stunting, result. So this is a post-stunting result. So what happens, after this? We had achieved good lumen areas, and we couldn't able to treat OM because it's already more than 5.5 hours, So we left OM, but the residual syntax score is less than 4. I think it's okay to accept it. But what happened is we wanted to continue Impella after procedure for at least 6 to 12 hours since the LV is very bad. But when we changed, sheath, removed PLAVA sheath and, pushed the inline sheath, and that's when we started seeing, a lot of hematoma. So we were not able to control, the bleeding and hematoma size expansion. We had to put a continuous pressure on the groin. So that's when we decided, okay, we have to wean off. And we tried tying this pre-closure, everything, but nothing worked. So, and then we came back to reduced impella flow, and we checked the map, and then we restarted inotropes, which we stopped at the beginning of the procedure, and we could able to maintain this map, but his PA pressure was increased, and which was one alarm, and which we wanted to support because as a PA pressure is more. We switched to IABP. One problem with this impella is once you switch off, one option is you can bring it to right femoral artery, you can put it again and close entire left femoral artery. But once you switch off, you can't switch on. I think that's how the software was built. So you can't use it again. So we had to put an IABP from right groin. And you can see these are the, we were with the dobutamine at the beginning, and at the end of procedure, we started NORET to maintain his, as we were weaning off impella along with dobutamine. And slowly we weaned off in next 2 days. And these are the lactates and this the peer pressure which I said at the end of the procedure actually increased, and that's the reason why we wanted to support him with IABP, and these were the CVP and urine output and all the stuff. So in next 2 days we weaned off IABP, and this was the LV after 48 hours, and we discharged patient after 2 days. So in multivessel CAD with CTO in poor LV function is a very precarious situation to treat, and often there are high surgical risk as well as high intervention risk. And RV function assessment plays a key role in deciding MCS choice, especially when patient has a long-standing heart failure. And Impella CP provides a good hemodynamic support for a prolonged procedure to achieve a adequate minimal residual syntax score. And right heart catheterization also is useful, mainly to have a wean-off strategy. And in cases like this case particularly, where you had a vascular complication with an Impella, you can use IABP if you're not comfortable with some parameters. Thank you.
Very nice case presentation, sir. Upfront, using MCS is a very good in like complex PCI patients. So you have nicely demonstrated use of Impella, then hematoma formation, and then use of IABP. Very good presentation, sir.
Thank you.
Sir, Impella, we can reuse it also. If you restart it, turning it off, turning it on, it works. And secondly, with the groin, so once you remove the Impella completely...
This I'm not sure about it, probably,
So I'll show you a video. I've used it outside my lab. It was throwing water.
Okay. Okay.
So, and secondly, you remove the Impella and close the groin completely after that?
Yes. I mean, it's a pre-closed. There are two sutures, we closed it. Yeah, that's not an issue. But as long as the sheath is inside, he kept on bleeding and, hematoma kept on expanding. Have you ever used, Impella restarted? No, I haven't. Okay. I mean, we have to find out. So.
I mean, I can turn it off inside the body and you can turn it
Go
on.
down to the lowest flows. Pull it out. Pull it in a one.
Oh, keep it at P2. Yeah.
Lowest one. And then
You have to continue that P2 flow.
And have everything ready on the right side.
Okay. But see, how do you wire it? Because see, if it is at P2, right, your motor is, rotating, right, revolving. You can't again send it over the wire because the wire comes exactly at the motor. Motor.
Turn it off also and then you can again turn it on. Is what I'm saying.
Okay. I'll just talk. I mean, we have to.
Dr. Sanjog Kalra explained earlier. Yeah, sometimes whenever it accidentally comes out, then they'll removing and they are cleaning in a bucket of water, saline and all. They are inserting again.
Yeah.
I remember.
But
Yeah.
The wire is the only issue. But
Yeah.
if you open it up and do it with the hard end of the wire and take it in, then it is tedious, but it is good.
And he told, even if we can rewire also. If you have to keep that wire and that what is the inserting thing ready at the patient bedside.
No, but
we
easiest
usually
thing is,
throw it away immediately, but better to keep it.
easiest thing is, I mean, if you can stop it and restart it, that is the easiest thing. So if you have to do it with
Sharath,
P2 flow,
coming to your case again, I think excellent case. But we have a patient who has two CTOs, and I feel one is an acute and chronic CTO, and one CTO you're committed to Impella, you're committed to complete revascularization. But along the way, you find that while doing the right coronary, it's taking a lot of time. You have an extensive dissection, which has brought down your cardiac output, despite an Impella, raise your lactate, raise your PA pressure. Would it be a good idea to stop there and come this another day for the left CTO? Because we don't know how much we would be gaining from the left CTO with a lot of collaterals going on there.
yeah, I mean, see, once you keep Impella on, I think it's wise to achieve residual syntax score as minimal as possible. In my practice, I'll target it should be less than 4. So
And Impella helps in complete revascularization. That is the main target for Impella usage.
And if you
as
if
much
you
as
see
possible,
the-
you have to finish it.
See,
it's improving. It has.
it's improved. And now his LV is, I have not showed, I think this patient we did almost a year back. His LV is almost like near normal now. Yeah.
Okay, we are running late, so yeah. So we'll conclude the session. Very good discussion. So now Impella has become the integral part of complex PCAs and complex CTOs. So thanks Abiomed for sponsoring the session and bringing this device and promoting this type of academic activities. Thank you very much. Thank you.
Thank you, chairpersons and audience, for the excellent session. We thank you, Bali sir, Karnakar sir, Sudim Jare sir, and was an excellent session for Sanjay Kaulri sir and Sharad Reddy sir. Always it's nice to hear from the Sanjay Kaulri and the Sharad Reddy sir regarding MCS. Always one thing you should be think about, always RV function plays a critical role whenever using an LVAD or whatever the things an MCS should. Next, coming to the session, we will welcome Vijay Teheran sir for the next session. It's an orbital atherectomy as the chairperson. And the discussion we call Ravikant sir, Mukesh Rao sir, and Vinod sir. Please come on to the dais, sir. Suti Prakash sir. First session is by orbital atherectomy. My experience by D.K. Baru sir.
Thank you very much for this opportunity, chairpersons. As you know, calcified lesions are very difficult subset to treat, and very important steps in doing PCI in calcified lesion is the first, the adequate lesion preparation. Second, imaging. Imaging is very important tool in assessing the calcified lesions. And we should know that one particular tool is not enough for a calcified lesions. Sometimes, many times we need multiple tools. Begin with a case. You can see this particular lady, 84-year-old lady. She had a non-ST elevation MI, and she was treated elsewhere. And because of the diffuse nature of the lesion, she was advised medical treatment. But in spite of adequate medical therapy, she continues to have angina. You can see obviously she didn't have a ST elevation MI. LV was around 46. So naturally she used to have a frequent angina. You can see there's a diffuse lesion here in this LAD. And we actually, because of the continuous angina, we took her for angioplasty. You can see this is an NC balloon. And this could not crack the lesions. Of course, we did the OCT before that. And we had to do rotablation, and followed by proximal part is very big, so we do IVL, and followed by multiple stents. She did well. The reason I showed this is that one particular tool may not be enough in a calcified lesions, and imaging is very useful. She had a good result, and down the line now, in 1.5 years, she is doing very well. And with this, I should say that, as I told, no particular tool is enough for a calcified lesions. That's the reason probably we need more and more tool. We have NC balloon, we have cutting balloon, we have IVL, we have rotablations, and we have a laser. We have a good session in the morning. And finally, we need another device. There's a new addition in this calcified lesion orbital atherectomy system. So why do we need orbital atherectomy? Because this particular device does a elliptical movement. It's unlike a rotational movement of rotational atherectomy. It moves in a centrifugal way. That is the principle. And same kind of burr or whatever you say, you can treat different levels. Suppose a small diameter is a bigger diameter. So we don't have to change the bar. And that depends on the three things. One, the speed of the movement. Second is the crown rotation, and number of passes. You can see that if you reduce the speed, and you can get a better lumen. If you increase the speed, lumen will be less. At the same time, more passes, you get a more lumen. So based on this, you can play with this particular crown. You can see we should be familiar with that. This is the actually pump. This is the device. You can see the switch on, switch off. It is here. You can increase the speed in this particular this point. And this is the crown. This particular crown will move in different speed, and the same crown will give different diameter. And the indications, all of us know that this is as is well known for the rotational and retrograde. Same indications can be used for a particular device. And we should know the certain contraindication when there is instant restenosis. I think this device is not indicated. If there is angiographic presence of thrombus, I think this is not indicated. We're very careful. High thrombus loaded cases. Multivessel disease with only single functional artery, you will have to be very careful. It's relatively contraindicated. Evidence of coronary dissection and uncrossable lesions. So these are the contraindications we should remember. And the procedure is very simple. 6 pence guide is enough. You can either radial or femoral, whichever you're comfortable, you can take. Always better to do imaging. Usually, in a calcified lesion, for not only for device, other device also, we should do the imaging, and you understand what is the type of calcification or the score of calcifications. And set up the device first, then there is a fluid and device setup. And cross the lesion. You can cross if you feel that it can be crossed with the same wire, or you can exchange the microcatheter as is well rotational attack, what we do. And prior testing is very important. Crown advancement and rotation, you should check it and ensure that it works properly. And always park the crown at least 10 millimeter proximal to the lesions. Most of the time you go anterogrately, you can advance the crown. And that's why if you 10 millimeter proximal to the lesion, you park the lesion, then you can advance slowly. Start with the 80 RPM slowly, then gradually, if you want, you can increase it. And stay away from the distal tip of this, because there's a coil will be there in the distal tip of the catheter, wire. So always you never go near to the wire, so it will get stuck there. So away from that distal tip of the wire. This is a case I just want to show this 73-year-old man, post PTCA in the mid RCA and circumflex. It presented acute unstable angina. You can see there is a heavily calcified lesion here, and this is a stent just nearer to the kind of lesions. So you can see the osteal lesion here. There is a stent sitting there. Is a heavily calcified lesions. So we can think of doing rotational atherectomy in this case, but I think because osteal lesion, sometimes rotational atherectomy is difficult because of the guide may not support you. And what about the IVL? IVL again, I feel it's sometimes difficult to cross these lesions with heavily calcified osteal as well as proximal lesions. Sometimes balloon may not cross. So I think this is the case, probably orbital atherectomy I choose. I think that will be more advantageous. But here, important thing is that stent is very nearer. So we have to be very careful. We do not have a lot of data on the osteal the orbital atherectomy in osteal lesions. Not many data are available. Even Orbit 1 and 2, they didn't have a lot of these osteal lesions in those trials. So here, only one important thing is that, this park the catheter very snugly and cross the lesions. Of course, what I did, put a regular wire. So that wire will guide you, the Viper wire will go, because that as a guidance to that Viper wire that you can go. Otherwise, you can put a microcatheter and exchange the wire. Whichever way you're comfortable can be done. So snug the catheter properly, and you should not allow the catheter to back, and cross the lesions distally. So if you can cross distally, then you can do retrogradely. So this is more safer because stent is very nearer. So antegrally, if you go, you can go to the stent and work and get stuck. So always it is it is advisable to, if possible, cross it and come back and do that. So that's why retrogradely we did this particular case. You can see that it's coming back. And we had a good result with this. You can see that there is a good opening, and whole osteal lesions were nicely open. So if you see the OCT here, this is a kind of typical picture. You'll get a scoop out, kind of the picture. You can get that because it is a revolution sling. What Earth is rotating around the sun, that kind of thing, is a centrifugal force. So it will scoop out the calcified lesion all places. And this is the typical picture in OCT after atherectomy. And finally, with a stent, you can have you can see that nicely open, osteal lesions open nicely, and you can assess what we have done with the OCT. We have a good results. Complications can happen after orbital atherectomy. Slow flow reflow is relatively less than this rotational atherectomy, but it can happen because the reason is very simple. It is particles are very small than rotational atherectomy. So this slow flow microvessel clogging will be less in this particular device. Dissection coronary dissection can happen, coronary perforation can happen, but less, these complications are less, but we need to remember that. Pseudoaneurysm, bradycardia, device malfunction, and micro tip dislodge, these are the complications can happen. This is one case, a 69-year-old male, hypertensive diabetic, came with aport angina class 3. You can see there's a heavily calcified lesions. Why? This is again one indication for orbital atherectomy, that we can see there's a lesion in the proximal LAD, which is a bigger segment, and the lesion is the almost mid to distal LAD is a smaller segment. There is little tortuosity here, need to be careful in that case. So these particular situations, if you want to use the rotational atherectomy, probably in that case, we'll have to use another bigger burr, or you'll have to use the IVL in proximity. So here, in this particular case, same kind of crown, we can treat the distal as well as proximal. This is the advantage of this orbital atherectomy. So we have done you have to go very slowly. You cannot jump like that. Orbital atherectomy problem is they take a lot of patience, a lot of time. So you have to go gradually. With the device, how it is moving, you can have a sensation, this tactile feeling as well as sound is coming from the device. So we can make out how it is working. So you can see that gradually we have crossed the lesions, but here you can see there is no reflow. So this is very unusual for orbital atherectomy. No reflow is supposed to be very, very less, unlike in a rotational atherectomy. So in this particular case, we are a little worried. At this point of time, obviously patient will have angina, they can have a drop of blood pressure, but we have to be, we need to keep a patience. We need to find out what is happening. So you can see that I put a balloon there because I was not believing that slow flow is because of this distal embolization. You can see that I put a balloon there in the segment. After injection, you can see that distal is flowing. So this is something like a balloon test. You know that what has happened there, because there is a tortuosity, there is a heavy calcification, or there is a significant dissection which has closed the artery. So this is not the kind of microembolization to the microvessels. It is rather than it's a dissection, which you can see that once you keep the balloon, give an injection, you can see the flow. So that gives us an idea of what exactly happening. So in that case, probably we can put a stent, you can just protect the branch vessel, then put a stent. Finally, we had a good result after putting a stent. So this is one case example where dissection with no reflow or slow flow can happen. But there are examples of even no reflow because of the microvessel embolization also, which is less and rare in an orbital atherectomy. With this, take home is a start with a case with a bigger vessel, because 2.5 millimeter or smaller vessel is not advisable. Go with a bigger vessels. Our arteries will be around 2.75 to 3.25, 3.5 most of the time. So we choose a vessels more than 2.75, preferably shorter calcific lesions in proximal and mid arterial segment is always advisable. Avoid ostial and left main cases in the beginning, and ensure availability of cover stent, microcoils, or snares, which are always important to have in the cath lab. And biggest advantage of this system is that the same crown for different diameter. Thank you very much.
I think very nicely covered. But one of the important reasons for slow flow, other than the smaller number of particles, is that you go very, very slow. If you try to go a little faster, you get the same kind of.
Yes.
And the point that if you get a so-called this kind of a slow flow, which we generally don't expect, so one should always quickly confirm it's a slow flow or something else, whether a thrombus is found or it's a dissection, and you already have a wire in and your system is out. Simple balloon is something which can sort out both the issues.
Yes.
If it's a thrombus, you balloon it up, you'll get some improvement. Yes. And if it is a dissection, the moment your balloon shaft goes, or even before inflating the balloon, it tries to temporarily kind of stent the vessel, and you start getting a flow. And at times you might send a couple of wires more, which is not very difficult. And sending an additional 1 or 2 wires will quickly kind of take the flap to one side and improve the flow. The moment you find that the flow is improving with your hardware inside, it tells you that it's a dissection. If the flow is not improving with the hardware inside, it could be the other two differential diagrams. And the moment you find that it is possibly a dissection, there is a tremendous difference between the management, because if it's a dissection, you have to cover it with a stent as soon as possible. On the contrary, if it's a thrombus or a slow flow because of particles, if you put a stent there, you'll be in a better of Waterloo. I think the last point is very, very important, that just in case you get into something which is like a slow flow with two other differential diagnoses, one is dissection, the other is thrombus, never hesitate to quickly take a balloon there. And merely a balloon walking into the vessel at times will make things clear. Nicely said, yeah.
Thank you. Yeah, you can do
Good
the
in
rotablation.
all of the cases for that matter.
Yeah.
But there is no doubt that orbital atherectomy, wherever you're doing orbital atherectomy, you can do rota, and vice versa is probably not possible, because if there is an uncausable lesion, you can't send your orbital.
Yeah, your point. Yeah, your point is well taken. We have done actually adenosine OCT in this particular case. Distal diameter is 2.75, this ILAD, and proximally almost 3.8, 3.9, almost 4. So that's the reason probably rota, if you take a proximal area, it's very difficult to bird it. Because I don't have two bird, 1.75 bird. 1.75 bird is not enough for that. So I think then in that case probably we will take a rota followed by IVL, which cost will be more. That's the reason this particular single device you can manage the entire thing. That is one reason why we have selected this.
For that matter, in that RCA with the stand proximally, one is that it would have been preferable to send an imaging first, because we straight off went with the orbital. Imaging would have told us whether is it imperative to modify the lesion, because whatever looks fluoroscopically is not always the truth. All of us who was here must have seen, especially those who are not doing rotational atherectomy, they must have seen many of the lesions which look ghastly on fluoroscopically. They will easily land to a balloon. And I, as a structural interventionist, with lot of experience on mitral balloon, I have had sufficient experience. Some valves will look heavily calcified, but they will just with a simple balloon will. So once you have imaging, it is better to do imaging, and it is possible that the same case would have been done by either straight off simple balloon, or sometime you send a guide extension, and through the guide extension on your way back you can send a IVL. But I think that more than one way to skin a cat, and here the issue was the important issue was to tell you that if there is an orbital lesion, we are not on a very good wicket with a guide to send the rota from up to down. And it is, even for orbital, it is worse to come from outside to inside, because the ellipse will be very big. If your guide is outside the RC ostium and you start rotating in aorta, the ellipse will be very big and can lead to dissection. And the point which you want to convey was that you just get past the lesion in case you can get, and then do ablation on your way back. That's what the point is.
Thank you.
Compared to rota, why is it contraindicated in the presence of a stent?
Yeah. Yeah, already chairperson has told, because it's an elliptical movement, it slings. It's a sling movement. You take a end of the, suppose one rope, and there is something metal loaded on the end of the wire. So it is like a sling. So it is not a controlled revolution like a rotor. So when sling, if it moves like that, it might get stuck in the stent.
As far as thrombus and dissection, I think even rotation atherectomy. So out of the 3, 2 are even for rota. Third one, as far as stent is concerned, I say should have a caution. And the other thing is that within the stent to have lot of calcium, unless it's a stent which is 5-10 years old, that's not a usual story. What looks like calcium fluoroscopically, maybe some residual calcium behind the stent and a stent there. So fluoroscopically, stented segments, they often will give you an appearance as if there's a lot of calcium. And if you travel inside the vessel with an imaging, then it tells you that probably the story, whatever is there, is outside the stent. Actually, we have had now experience of sending rotational atherectomy device even in dissections and even in thrombus. And
with the old DCA, we could cut dissection flaps.
Yeah.
So those are also done. But a recently deployed stent is a contraindication even for rotation.
Yeah. Yes. The recently deployed stent for both of them.
For both. Yeah. And in an old stent, it works actually by heating up that area. So once you pass the rotational atherectomy, then your balloon will work. More than rotational atherectomy shaving off some metal. It won't shave off any metal. It will just heat up the stent.
What?
The other
the PLV and you were not able to take your balloon which was not dilating in the PDA, so you had stent ablated a new
Yeah. So I think in the interest of time, the organizer is saying late. Thank you very much, Dr. Barua. Not Dr. Baru, because somebody was introducing, he said Dr. Tehran, and then he said Baru. Then I said, let me just correct him. Thank you so very much.
For correcting. Thanks. Thank you. Unless you're planning to occupy the chair of the president of Iran, so it becomes Tehran.
Yeah.
Baru, wah.
So as the name goes, Surya, which gives Prakash, and then he become Rao. So let's have him here.
Good afternoon, everybody. Dr. Vijay Trahan means Gurus of Guru. Anil yesterday just vibrated the hall like anything. So the youngsters doing good job. That's what the chair is. I have only experience of 10 cases of orbital hysterectomy. I don't know, I have done around, when they introduced
any organizers from the orbital side? Nobody. You are aware about how many people in the country have gone to the double digits with orbital?
I don't know.
Not too many.
Because I still have a doubt orbital is there in US many years back. It is very lately introduced with us. And the progression there also, same here also, the ups and downs. I don't think the regions. But I have done 5 cases on the first day. After that, in 1 year, maybe I have done 5 cases. That's what happened. 10 cases done. And this is one patient, unstable angina. In acute coronary syndrome, actually, he came. And that day, we pulled up some cases. So we also took him. Some time back, they have done outside a CT also for him. But actually, his top eye also elevated. And he has hypertension, diabetes. So he had a tight LAD lesion, circumflex mild disease, with 2 lesions in the LAD, long segment, with fluoroscopic calcium is there. Distal size is good, left main is good. So here the problem is it looks very tight lesion. That day this involution company technical person, and that lady is there, she's telling don't do any ballooning before the orbital. I said even the OCT catheter going also will become tough in this case. So I have to do with a 2 millimeter because the OCT catheter did not go. So I have done, I think imaging is must before, in most of the cases, before debulking by IVL or the rota or the orbital. So I have done a 2 millimeter dilatation, no other way. Then is also some lesion, but that's not for now discussion. So in this case, after doing that, we have done a OCT also, I will show you. And while doing this orbital in this case, I expected a slow flow or is symptomatic patient. Maybe it's not a right choice to do as a first case. So we went ahead as per the instructions of running it with patients. And I just preferred the procedure because any dedicated radial center, this is one of the best device. I advise if you need some time, they say there is no need for a pacing lead, but I have seen out of the 10, I have to go for 3 cases, a temporary lead is needed in out of 10. And when it is crossing, he had a slow flow. Is very, you can see the heart rate change. He had a very symptomatic angina, and little we have to rush up the thing. Then the OCT after 2 millimeter balloon, it's a very densely calcific vessel. Even on fluoroscopic also calcium from 1 o'clock to 5 o'clock almost. There's a heavy calcium is there. And after that we dilated with the balloon and the routine, but he also needed the temporary lead. I remember he had a bradycardia and he's symptomatic. We have to go for a TPA. Then we put a long stent. There's some osteal disease also, we did not cover that. And we have dilated with high pressure post-stent dilatation done with 3 millimeter and 3.5 NC balloons. After the OCT finding showed we need a 3.5 balloon. This is the good opposition of the stent, and luminal gain also good. So this is the first case what we have done, and in a symptomatic patient, final result is good. I will remove that pacing lead later. So the osteal disease, this patient is doing good now. It is almost more than 2 years now, I think. He's doing good. So this is the one case we had. So this case, patient had a
So the message from this case?
Please.
Message from this case?
A learning message.
Learning message.
This is the learning case for me, first case.
So
I think they say you don't do any ballooning in the lesions, but some of the lesions, once you put the orbital, it may close off. That's what I observation. And temporary lead is not needed, but in 3 cases out of 10, I needed a temporary lead. So slow flow
also
is
slow
expected.
flow, yes.
Slow flow is expected in these cases. And I think until you get a good learning curve experience, you have to be cautious, because we are doing a radial procedure, 6 French, and we don't usually keep the femorals. So temporary need may be there, and the slow flow is expected. That's what I.
So for a beginner to start with, suppose I have to do the case, do I try with a simple balloon once, it doesn't go, I go for a rota, or still balloon and crossable lesion, still we try with orbital once, and if you fail, then switching over to rota will be a difficult option. So is that a way to do it?
No,
just try with an N balloon, try to cross. If it doesn't cross, go with a rota. If it cross,
Correct.
try an orbital.
But what I have seen in this case is, I don't know, rota could have gone, because we have done many rotas by this time. The same lesion, I could have crossed with the rota, what I feel.
So how do you decide?
That's what the discussion,
So
indications
but I
are
don't think you had a
same.
problem in crossing with even the orbital, because you had already pre-dilated, so that situation didn't arise whether it would cross or it wouldn't cross. It did cross.
Because the OCT catheter itself.
See,
crossing
one of
is
the
fine,
indications
that's
if your imaging catheter does not cross is that you need a plaque modification. I mean, that's normally in my limited practice. If somebody does have imaging catheter which does not go, my first reaction is to pick up a rotational atherectomy and do a rotational atherectomy.
And don't be with the ox imaging catheter, because if the ox catheter doesn't go, that doesn't mean the same thing.
No, we don't use.
And
at least my setup, I never use any ox material in my lab so far in my life. I got a fully shelf filled with donated material from me or some organization. Never used.
You need to make sure that your balloon, 1 millimeter balloon, is able to cross, because the difference between
Don't dilate and just cross.
No, difference between rotation and orbital is rotation is going to ablate at the tip. Orbital atherectomy is going to ablate in the middle. So for that, you need to engage your burr with the calcium.
Yeah, that's what exactly
if
my
your balloon
question
is not going to cross, then you cannot do it, because it will never engage. In that
actually, there is 6 millimeter distance between the tip of your orbital and your crown. So that nose cone has to walk into the lesion for 6 millimeters. But many times, like all of this, even in this case, because if you, rather than state of first pre-dilating, if you start walk, because the nose cone can easily engage in such a case. And if you, the only thing is that you have to wait. And sometimes the moment it engages, you get into slow flow and you stop. So if that kind of a fear is there, you try to make some way. But it's about 6 millimeters. So I think there are advantages and disadvantages of both. And even though the IFU says that do not pre-dilate, but pre-dilating with a very small balloon, just letting your life be a little comfortable, so that while the time you're doing this procedure, particles will be small, is all right, but your device will totally occlude, so the operator will become suddenly uncomfortable. So I think dilating with a very small balloon probably will not take away the real, because if it has to go in the orbit is never made so small by a small balloon. It still has a lot of way to cover. So I'll say that Dilating with a small balloon probably is not a big problem. If it adds to the comfort of the operator, I think it's okay.
How did you feel about this wiper wire in your experience? Wiring in tortuous vessels.
Certainly better than rotawire, there's no doubt about it. Certainly better than that. And Viper, with some of us who have been using this wire in peripheral, I think it's not like your workhorse wire. So it is somewhere in between your rotawire and your workhorse wire. And yeah, I'm saying it's in between them. And all of us know that if you have a problem, then you have a microcaptures there to exchange, so you can always do that.
So this is another patient, had a class 2 angina, treadmill is positive, diabetic, hypertensive, some stent done to circumflex long back, and he has a angiogram in February 23rd. There is a ISR in the circumflex stent and a bad lesion in the LAD mid-calcific with a diagonal coming from that lesion, and RCA also some disease. So this lesion, a calcific fibrocalcific lesion in the LAD is attempted, I think this case we have done, this case we could do the OCT without any balloon. So you can see the calcium from 5 to 8 o'clock, dense calcium and a very tight lesion as expected looking at the angiogram. And this case also we had slow flow happened in this case, and even the diagonal we have to give some nitro and nicorandil, and then the diagonal opened one after doing the orbital. Then the routine is we have done the balloon dilatation and stenting. And result is good, but this case also we had the same thing in the diagonal slow flow.
I think whereas in rotational atherectomy we have some idea about the speed at which we can cross with the burr, and we understand that if you want to do a lot of atherectomy, then you probably need to go slow. But if you want to cross, you might need to go a little fast with the challenge that there are no diamonds on the back of the burr. In orbital, we have to make sure that we really go slow. That I think is, to my mind, and that is one of the simplest things. And if you can cross, and probably the best way is to do the atherectomy on the way back, because that gives you a lot of comfort.
So this is the final result. The third case, this is a diabetic, and actually he's my classmate. I don't want to reveal the ID, but he's my classmate. So he's an RCA, LAD borderline lesion, but the RCA is a very calcific, tight lesion. So we have done the orbital on the same day when we took this device into our cath lab. And it went on smoothly. Only thing is RV branch has issue. Same thing, you have to infuse some nicorandil NTC, and then it again RV branch issue here. They say don't dilate with high pressure dilatation and all. I don't know, because stent deployment after that you have to do, whether it is a rotational or orbital. Post stent under expansion of the stent is not happy, so I dilated with high pressure dilatation. This is the end result. But the RV improved over a period and did not create any bradycardia, but some uneasiness which cleared. So these are the three cases.
In general question, anybody has any experience regarding that fluid allergy that contains soya, egg yolk? So some people are allergic to soya. So does anybody has any experience?
So far I never had this. They say that it is more lubricant and allergic chances is less. They modify it.
But you know, even rotational atherectomy used to have rotaglide, which was actually egg yolk. So we understand that to lubricate, one trick which he taught us many years ago was to give some propofol, and that actually works.
Why I asked this question is I have a severe soya
Many
allergy.
times.
I'm very much allergic to soya. I realized when I consumed it. I never know before.
So
I had
make
severe
sure
vomiting.
you have.
Yeah.
Under,
So I just like to know if somebody.
undergo a CT for calcium. That'll tell you whether you really need these things or not. I think any question from the learned audience? If there is none, then I think we are here to close the session.
Thank you.
And thank Dr. Surya Prakash Rao and others.
We start the CD session.
Thank you, Triran sir, Anil sir, Mukesh Rao sir, Vinod sir for an excellent session. We thanks D.K. Barua sir and Surya Prakash sir for their insightful experience in orbital atherectomy. Always when you're starting for an orbital or rotational atherectomy, in initial cases, you can go ahead with a temporary pacemaker backup. When a slow flow is there on table, if you are doing a radial choice, femoral should be always be prepared. Coming on to the next session. Complications in CTO PCI. From now onwards, the CD session starts. We say good luck to all of your participants. There is a exciting prizes waiting for the best 3 winners.
I think we all know the order.
You all know the order of your presentation. It's always, it's an 8 plus 2 minutes. Please stick on to the time, 8 minutes, because the time also matters. The judges are also looking into the matter, and 2 minutes is for discussion. Once the 10 minutes or slot is over, the bell will be rang. You should be the caution. At the 6 minutes or any other 7 minute, bell will be rang. Please stick on to the time. Already we are 15 minutes delay. We welcome Anil sir, Vijay Teran sir, Narayan Swami sir, Narsaras sir, Rajesh sir and Badani sir for the guest part, and the chairperson will be dealing the session, and the discussion Premchand sir, Ganesh sir, Chandramukhi sir and Chandramukhi madam and Suraj. We welcome to the Saurabh to take on to this.
Good afternoon, everyone, and thank you, organizers, for giving me the opportunity. And I'm going to present a complication that I encountered while doing an RCA CTO PCI. So the patient in question is a 61-year-old female who is a diabetic, hypertension, and has hypothyroidism. She presented with anterior wall MI with an ejection fraction of 35% and a BMI of 27.8 with an active lifestyle. Her hemoglobin was 14, the troponin was positive, being an anterior wall MI, and an eGFR was 87. We subjected her to a coronary angiogram which showed some plaque in the LCX with a distal LCX about 99% stenosed with a plaque in the ramus. As you can see, the LED has a tight stenosis in the middle part, and there's retrograde filling of the RCA from the left injection. And the right coronary artery was occluded in the mid segment, and there was no filling from the antegrade RV branch. So being an acute anterior wall MI, the syntax score was calculated and it was around 20. The perioperative mortality with CABG was also low in this case, and the ACR HBR criteria were not met. So the patient was counseled for PCI/CABG and was told that complete revascularization is possible with PCI. And but then one has to consider that there were certain predictors of poor outcomes with CTO PCI, like the occlusion seemed to be old. The length was more than 15 mm with a side branch present there, and there was an abrupt cutoff. However, the patient's family was willing for a percutaneous intervention, and we went on and stented the LED with a drug-eluting stent, being the culprit vessel. And 2 weeks later, we decided to take up the patient for an RCA CTO PCI. The dual injection was taken with the femoral route. A diagnostic catheter was hooked into the JL, and an XP RCA was used to hook the RCA. The microcatheter fine cross was taken, and initially the lesion was palpated with a Fielder XTA wire. However, the wire kept buckling, and we knew that the lesion was hard, and the next wire that was taken was Gaia second. And we made some progress with Gaia second with a microcatheter. However, as can be seen from the left injection, the wire was going into the subintima and was not actually into true lumen, and it was a long segment CTO. So we still kept taking the wire a bit back, pushing the microcatheter, trying to realign it into the true lumen. But at this point of time, we again kept manipulating the wire and rechecking, and the wire was still in the subintima. At this point of time, I felt that my wire was getting stuck, and and when I was manipulating the Gaia second to and fro, I kind of realized that I might just snap it off. And it was at this point of time I pushed the microcatheter a bit ahead and removed the Gaia second. And since it is a tapered tip, and I felt if I was repeatedly going into the subintima, it might perforate it, I decided to go in with a blunt tip Miracle 6. So I already had the microcatheter in situ, and then I manipulated the Miracle 6, and I was able to get it into the true lumen, into the distal vessel. And this is a shot, and in this shot, it is important to see that there was a big PD branch that was coming there, and we decided to freeze this shot for future reference. So we had this wire into the main vessel, and we were kind of pretty happy with it. And it was in one of the side branches distally. However, in the subsequent injections, you can see we have manipulated it into the true lumen, into the main lumen. So after which we pre-dilated it with a 1/5 and a 2/10 sequential pre-dilatations were done. And then finally a 2.5 20 mm balloon was taken into the PLB, and the lesion was dilated. But then to our surprise, when the subsequent shot was taken, the PD, this was again, the vessel was pre-dilated all through.
That should not be a surprise, because you were already subintimal at the crux, and you re-entered into the AV groove beyond the crux. So the moment you balloon it up, you will put a flap in front of the PD. PD will close.
Yeah, so the PD closed, and there was a big so we saw that the PD had closed, and there was a dissection that extended into the PLB. So we felt that all the efforts have gone down the drain, because now we don't have a functional outflow lumen. However, as I told you that in the previous shot, we had seen a PD that was running down. We froze that shot, and we decided to rewire that PD, though we did not have a channel through which we can actually negotiate. But the only hint that we had was that shot wherein the PD was coming, and we tried, and we were luckily able to manipulate the wire into the PD. Thereafter, the whole tract was again pre-dilated, and with a 2.5 into 20 mm balloon, and you can see a bad dissection that has gone all the way into the PLB with the flap being raised there. However, since we were able to get the wire into the PD, we knew that we had an outflow. So we stented from the distal RCA to the PD with a 2.575 into 28 stent, and thereafter the proximal to mid portion was stented with a 3 into 44 mm stent. As can be seen in this injection, there was some haziness at the distal part of the stent, and we knew that the dissection had probably extended distal into the vessel. So we decided to track that too. And after the stent was appropriately post-dilated with a 3.25 into 15 mm stent, the dissection can be seen in the distal part of the PT, which was stented with a 2.5 into 18 mm stent, and that dissection was sealed. After that, to our surprise, because this hardware required the guiding to be deeply throated into the RCA, we noticed that there was a proximal dissection. However, we wanted to believe it's just a spasm. We gave the patient NTG and nitro, but then it did not get resolved, and we knew that it was actually a dissection, and hence the proximal RCA was thereafter stented with a 3 into 28 mm stent, which was later post-dilated with a 3.5 into 15 mm balloon till the mid to distal RCA. So this was the final result that we got with the flowing PD with no dissection thereafter, and of course the PLB was as it is. There was no point tracing the PLB because the flap had extended to distal, and any kind of stenting into that vessel would not have yielded any results. But we had one functional outflow, and that was the saving grace. So the in-hospital course was post PCI. The troponins did go up, but the patient was clinically uneventful and was discharged on OHAs and antiplatelet therapy. The patient was asymptomatic at 1 month follow-up with no angina and was in functional class 2. So to summarize, pre-procedural planning is very important in these cases. One needs time to examine the diagnostic films and angiograms, and even during the procedure, one needs to be very careful where the wire is going and where one is going from subintima to true lumen, because any kind of manipulation in the wire, especially in the crux from subintima to true lumen, can cause the side branches to knock off the side branches. Appropriate vascular access, guide size, and dedicated hardware needs to be used. Occluded and contravascular vessels need to be reviewed in multiple projections, and the contrast volume needs to be defined in these cases. The role of dual injection cannot be overemphasized, and wire escalation strategy we need to be well versed with the wire escalation strategy. Thank you.
Excellent final result.
What was your RCA grade?
It was XP RCA. We could have used an AL1 also, but then normally we have seen that XP RCA gives you a good backup support, and normally the proximal dissections that we see with AL1 tends to be much lesser with XPRCA. So I kind of decided to take XPRCA.
Okay, so why do you think that the dissection had occurred?
I think we had kind of, while manipulating the instruments into the distal RCA, we had deep throated the guide, and that is why I guess we probably landed up with a dissection in the proximal RCA.
Okay, when you probably re-entered with the same wire into the PDA, why didn't you think of taking another wire? You already had access into the PLV on. You could have probably gone ahead and taken another wire.
No, we knew that we had dissected the PLB, and we knew that we would not be able to save it because we could see that flap extending right up to the distal end. And there were price issues as well, So and we thought that we knew that till the crux we were in the true lumen. So we thought we'd probably pull it back and get it into the PD.
No, even if you have a wire in the PLB, you go true, fall true. Once you stand, again that will be gone. So that'll be kind of a futile exercise. What sometimes can help you is if you have a cutting balloon on board, you can put a cutting balloon at the crux. If you put a cutting balloon at the crux, the flap which is going to come in front of PD or PLV, if you kind of fenestrate the flap, then the flow after stenting from AV groove to PD, after a stent here, you will still have a fenestration where the dye can walk through into both true and false lumens into the PLV. I think that could have been possible, slightly different, but I think finally the result was excellent. And one more.
Yeah, it was extending right up to the crux from the mid RCA to the right. And it was not filling antegradely, but if you see the left injection, there was filling only up to the crux. So it was a long segment.
If finance is not a big constraint, then I think guide extensions make the life very, very easy. Unless you want to plan 2 balloons and 2 bars and so, which probably was not the case in this case. And even if you want that, then you can temporarily take out the guide extension, because guide extension will give you a lot of power, save contrast, and these unsightly dissections, they can also be decreased significantly. And you don't necessarily need to take aggressive guides. Simple guide, extended, the same guide becomes implants.
Thank you, sir. Fine, thank you.
Nitin Bajaj. Just for all audience, at 7th minute the single bell rings. So just to wrap up your sessions, at 8th minute the session closes. 2 minutes is for discussion.
Thank you, sir. Just to the chairpersons, I would like to say this is not a complication case, but maybe in the wrong session, so I'll just go ahead. It's a LED ISR CTO case. So our patient was a 59-year-old.
In the marking, it's like novelty, presentation, and scientific importance. There is nothing like complication.
Case, so we don't get. Since it's a complication session, so I thought I'll just clarify that, sir. The patient underwent PCI to proximal LED in 2013, and subsequently this was at an outside center, unstable in January 2022. Again, an angio done outside showed ISR LED 100% and LCX 99% lesion. LCX was stented there, and PCI to LED was attempted, which was not successful. Subsequently, he was referred to us. Echo showed an EF of around 45%. LED territory was hypokinetic, but it was viable. So this is the coronary angiogram. As you can see, there is a proximal LED 100% ISR. Just there is small microchannel seen extending into the LED stent, and no other antegrade flow. And the LED was filling up from the right injection. So we planned an antegrade wire escalation. Initially start with the Fielder XT, and subsequently thought to shift to Gaia series. We planned to use intracoronary imaging and use of laser as we have it on board. And if we're not able to do, then the second plan would have been retrograde. So we initially started with a microcatheter, fine cross and Fielder XT. However, it could not go beyond the initial part of the stent. So we exchanged it with Gaia 2, and with Gaia 2 we could cross the CTO segment, and this we confirmed with a retrograde right side injection. As you can see, it's in the true lumen.
Isn't it too far a walk with your Gaia before you reconfirm?
Sir, it went into the diagonal, which we got it back into the LED.
What I'm saying is you walked too far long distance.
So with microcatheter we could not cross the microcatheter.
You're taking a check shot after walking near the apex.
Oh, sir.
Then the meaning of check shot probably is gone.
And then we used the laser 0.9 laser catheter, and used at 40 fluents initially, then 60, and then 80 fluents. Gave slow saline lasing. Then initially dilated the CTO segment and took an OCT run. So this is the OCT run as.
One moment. Why did you use a laser?
State of?
Why did you use a laser? I mean,
use laser for the as
novelty.
a ISR for a ISR this thing.
The lesion is started before the stent. You don't have a balloon uncrossable situation. You have choices which you can exercise. You are not even sure about whether you're entirely intraluminal because you've only got a wire re-entering into a diagonal. So I didn't understand it. So please, I mean, you must have had good reasons.
So we took it as because it was 100% ISR, so that is why we as an ISR segment.
You try to push in a balloon, it doesn't go.
Our microcatheter could not cross. We didn't try a balloon, but a microcatheter could not cross.
Which microcatheter?
It was a fine cross.
Fine cross did not cross.
Fine did not cross.
And your wire went all the way down into the distal LED.
Sure.
Fine cross did not. Okay.
So if what could have been done if the fine cross is not crossing, wire is almost till the LED?
We could have tried a small balloon. We could have.
No, even a fine cross. You could have taken a guide extension, there's a lot of things, and you could have taken. See, the question here is that is it a standard practice to state of walk with laser, or you have a laser on board and you can just use it?
No, we had a laser on board and it was an ISR.
Sometimes that's a bigger temptation. And see, the point which Dr. Harle is trying to tell you is that at times what is looking to be luminal in one projection may not necessarily be luminal. And either you take an orthogonal.
We checked an orthogonal view.
So that's okay. That's okay. Either you check in the orthogonal or you have a
We had checked in orthogonal views. It
Anyhow,
was luminal.
we are losing
so
sight. Thank you.
Continued with the intercoronary imaging, which showed in the distal part was less expanded, and there was a proximal dissection in the proximal part before the stent. So these were the analysis of the OCT. Showed neointimal hyperplasia and some stent under expansion at the which was there. So we further used an angiosculpt balloon and dilated it, and then we stented from left main to LED, 3.5 30 millimeter stent, and a port to left main was done. And this was the post OCT image, which showed good stent expansion, and there was no dissection or malposition. And so this was the final result. So since it was a ISR CTO, that was the reason that had its own challenges. Laser, we have it, and yes, we have seen it to be of benefit in ISR, and in fact we have been using it in a lot of ISR cases as such, and it has given us a very good result, sir. Thank you, sir.
Good result means?
Sir, we have not had any complications. All patients, I mean, till now we have done a lot in ISR cases. We have been doing laser very frequently. It's been proved to for us being safe. We have not had till now any perforations, and the luminal gain is good after initially laser and then subsequent balloon dilatation. Then either we DEB or DES. That depends on the type of lesion, and if there is a peristent extension, we do a DES. If it's a focal in-stent restenosis, then we can maybe get away with either a drug-coated balloon.
Your mid LED by any chance post run, did it show any significant? Because last shoot it shows near the diagonal. Probably is it more significant or no lesion at all?
This thing, sir.
So one more, you see, because you were going into an ambiguous territory, and with a laser, it's a big toy, it's a big weapon to have. Maybe that's what Dr. Trehan, when he mentioned that you should have taken a guide catheter extension, it would have probably kept your laser right in the middle. Because remember that even if your laser cannot cross a balloon uncrossable lesion, if you deliver energy, you can possibly come back and do a rotational atherectomy. Most of the time when we've used laser, it is when you have a balloon uncrossable, undilatable lesions, we cross with the wire, we cannot deliver anything, maybe get a microcatheter, tip in or whatever, and get a laser, the energy probably allows you to now deliver a rotational atherectomy wire and perform a rotational atherectomy so that you can get it. But at the same time, you said you didn't have complications because you've been using low energies. You've not used contrast laser in
Well,
any of these
very
cases.
very few we have used. Mostly we are using saline lasing.
Beware that the temptation to use a lot of lasing, especially if you use contrast laser, has landed people. I mean, this modality was virtually withdrawn. So we must not forget that.
Actually, the very diamond which you wanted to show in this case is under scanner by all of us.
I agree. No, that is the. I mean, that's always.
We are very envious of you that you have a laser on board. You should also think of using laser in STEMIs, which are not thrombotic.
So STEMIs. In fact, we have been using it in thrombotic lesions.
We
also.
would have all appreciated
no, not
that.
in primary.
We would have all appreciated, because this case could have been done by all of us by other methods, and the kind of good result which you have had, I think
But
all of us would
you
have.
have to use it. I would definitely have advocated using a guide catheter extension. It
Yeah.
would have kept your laser right
We've
in
been
the-
using it more in highly calcified lesions where we cannot get a microcatheter and done some lasing and then done a rotational atherectomy. We have been using it in a lot of spectrum of cases.
What is the long-term experience of?
So long term, I mean, I cannot. Been using it. The procedural success has been good. Complications as of now, we have not had any, not even a single perforation. Long-term results I cannot tell you because we have been starting it about a year back only that we have had the laser with us, and we've been using it for last 1 year. So I really cannot give you a long-term perspective. 3 to 4 times, sir. Thank you, sir.
Manju Bhargava, OCT detected post-stent dissection in LAD CTO PCA. Manju Bhargava.
Next.
Okay. Next we will go into case 4. Gautam Datta, Himadri Rai. Broken wire coil while doing RCA CTO PCA.
Good afternoon, everyone. Myself, Dr. Himadri. From IPGMR Kolkata, going to present a case of broken wire coil while doing RCA CTO PCI. The case was, chief operator of this case was Professor Gautam Datta. It was not moving.
Audiovisual.
Audible.
Then reset his time, please, because he should not be disadvantaged.
So
All
as
the same.
we have one absent, so you had a unraveling of the wire, isn't it?
Yes.
The wire got stretched.
You said, or the
Coil part.
The wire got stretched and then broke.
Yes, sir.
Was it a Gaia?
Why it is not moving?
Was it
No.
a Gaia?
Yes, sir. Yes, sir.
Next
My
time
patient
you will have
62.
Next, yeah.
My patient, 62-year-old male patient, was non-diabetic and having normal lung function, presented to us with CCS class 3 angina. He was having left ventricular ejection fraction of 55 to 60% without having any regional wall muscle abnormality. And coronary angiography showed that there is a long segment CTO, there is blunt proximal cap, and there was antegrade bridging collaterals and also retrograde from the left system. Then we tried to penetrate the proximal cap via by Gaia second wire, but unfortunately it went into false lumen. Then we tried to track the antegrade collaterals with filter XT wire. It also was failed. Then somehow after several attempts, we could manage to place the wire in the RV bench, which was confirmed by contralateral injection, and keeping the wire in the RV bench. And now with Gaia second wire, we tried to probe the CTO segment. Wire is probably in the true lumen. Till now, the procedure was uneventful and it was going fine. But then Then when we are giving torque from outside, it was not transmitting, and there was not possible to maneuver the wire. Probably the wire got stuck here, and possibly the coil part of the wire got trapped in the CTO segment. So what to do now? We are in trouble. We are intertwining 2 or 3 wire to retrieve is out of question. And it was evident that if we pull the wire by microcatheter, it will get detached and shaft will only come out and coil part will remain there. So we took 1 millimeter balloon and dilated as far as distal as possible. Then the wire and the balloon, the whole assembly was taken out. And the next angiographic shot revealed that there is a nasty dissection flap was created. Patient was in hemodynamically stable condition, and we thought to abandon the procedure and make the dissection flap as a part of investment procedure and call back the patient and after 6 weeks. Then after 6 weeks, patient came as previously. Radial and femoral lateral X-ray was taken and Judkins-Rice catheter was taken. And this time, with our surprise, the wire, the lesion could be crossed with cyan blue wire only with microcatheter support, and wire was in the true lumen. But again, we are in trouble. The smallest size of balloon couldn't cross the lesion, and we thought that from the tiny coil part which was remained in the RCA, probably hindering the progression of or advancement of the smallest size of balloon. So we took help of the body wire, and then 1 millimeter balloon can be crossed. Then gradually we upsize the balloon 1.5, then 2.5, then serially pre-dilated the lesion. Now this is the lumen after serial balloon dilation. Then we deployed, subsequently we deployed the drug-eluting stent, overlapping drug-eluting stent from distal to proximal, 3x24, 3x32, and 3.5 into 32. Then IVAS run. Then we post-dilated the stents rigorously with 3.5 into 12 balloon, and then IVAS run was made. There was showing good stent apposition and good expansion, and this was the final angiographic view. Dimitri flow restored after 3 stent deployment, and in 6 months follow-up, patient is doing well. He is free of any angina. So, from take-home messages from this case are: investment technique is an established strategy. If there is dissection, it may later help to find the true lumen. IVAS is helpful in CTO segment stenting and optimization. Too much rotation can break the wire in the CTO segment, as it was in our case, and it's difficult to retrieve the broken wire. Patience and perseverance is key to success in CTO revascularization. Thank you, sir.
Second time when you put the wire, before the wire, do you have an angiogram?
Yes, sir. The angiography revealed the CTO segment remained the same.
That's not
Put. Okay, sir. That was not put in the, but CTO segment remained the same, sir.
What do you think really worked in this case, in your favor?
Dissection.
What was the cause of dissection?
Probably the broken wire, the coil part.
That will almost never produce a dissection like that. This was an unintentional Carlino which was done by your guiding catheter, which was already wedged. Just go back to that. It's a wedge injection. This wedge injection produced an unintentional Carlino, and this pushed a subintimal space, opened into the RV branch relatively free. Also, it walked into the false lumen for a while, and then this healed. And once these parts they heal, then sometime if you bring this patient back, or sometime even in the same sitting, you left this case because you got scared of that dissection. Yes. That could have been done. Can we just see that? The shot. Look at your injections now with the guide out, and the injection at that point in time was with a guide already about 50. See that guide? Are you seeing the guide? Your guide is wedged into that space, and that is what is. You see, if you also look at it, this dissection is building up with the injection. As the injection goes, and you have a relatively free exit into the RV branch. So you broke out into the RV branch by your dissection. In fact, we have seen many cases. A bad CTO and you are struggling and struggling and struggling, and then sometime one of your assistants with your guide already wedged in injects, and you get a bad dissection, and then you have a wire which easily walks into one of the branches. So that's what it is. You did this case next time, but I think the credit should be given to this so-called wedge injection, which should not have been done. Thank you very much.
Thank you, sir.
Did you have a micro catheter in the first instance? First instance, because that's the reason that you were torquing, and probably you did not have probably enough. And already the crack in the second shot, you can probably see there's a small gap which is already seen.
After about 20 millimeters up, between 20 and 10
see
millimeters,
small
there is a
gap
small
is
gap.
seen.
Yeah, that's there. But that can happen even with a microcatheter. So that is another important question, because these wires will fracture. If you want to take a guy and start to spin like this, like you do with a whisper wire, or then you are bound to get a problem. Even the guy next will get entrapped and fractured. Guy next is resistant to get fractured and entrapped and fractured. This is a little more resistant because of the core. But if you continuously keep rotating your guy wire in one direction, and you find that the movement is not getting really transmitted there, then you are bound to get your tip trapped. And continuing to do something here with the tip trapped there, this is a recipe for kind of disrupting the wire, very often causing a partial fracture, and as you pull, this will kind of unravel and then break. The worst thing in such situation is if your unraveled part gets out of the ostium of right coronary artery and you don't know where it is, and that will almost never be seen by your standard fluoro. Will be seen either on CT or on intravascular imaging. Pavan Roy, yeah.
Case 5, perforation in L6, ISR, CTO, PCA.
Leave it, just leave it. Just leave it. Just leave it. The moment you started to ask the question, the answer is just leave it.
We were discussing
about
this yesterday.
Yeah. That's the best place to leave it. But you should be sure that it has kind of snapped and fractured. Not that it has unraveled and fractured. And how do you know it? The part of the wire which gets out, just inspect it. That will tell you, has it snapped, fractured, or it has stressed open.
Good afternoon, sir. You might recollect this case I have previously presented in few conferences, also in India Live.
We are old Alzheimer's.
Yes. This is a L6.
You can take the advantage of that.
So this is a middle-aged gentleman. He had previously a stent placed in a dominant LCX in the mid to distal segment 2 years before this procedure. He had a drug defaulter and a chronic smoker. He again presented with severe chest pain, and ECG echo showed inferior wall hypokinesia. The angio was done, which showed the mid segment. The stent was deployed just after the origin of the OM in mid LCX segment. The LCX was dominant. LED was showing minor plaque in the proximal segment. In the PA cranial view, the distal LPDA and distal terminal OM is filling from the LED collateral. RCA is non-dominant and normal and small vessel. So the plan is to open up the LCX. First, the right femoral approach with good 7 French XB support was taken. And with the help of 1.2 balloon, a pilot 150 wire was taken. Initial in the PA caudal segment, I entered into the stump of the proximal CTO segment. Then in LO canal, we asked the wire passed in the mid segment. Wire, I thought it was going outside the vessel lesion. However, there was no contralateral collateral as the distal LCX was filling from LED collateral only. After manipulating wire, I thought the wire was maybe in the distal 2 lumen, but however, this distal LPDA was not filling well. So
Deja vu.
I did
Deja vu.
Yeah. So
I remember the
after
case.
pre-dilation with 1.2 balloon, there was a perforation seen. However, patient remained stable. Then I checked the multiple views. It was a coronary sinus perforation, and the wire had entered in the one of the tributaries of the coronary sinus, causing AV fistula. Immediately on the cath lab, echo was done. There was no pericardial effusion. It is an intracardiac perforation. So I kept the distal wire in the 2 lumen, and the team discussion was done. There were 3 options: either to just leave the abandon the case. Second option to send the patient for surgery as initial hemodynamic is stable, and third option just go along the flow and keep this wire to a parallel wire technique and just drive the second wire entrance in the true lumen. I go for the third approach. As all the dye was going in the coronary sinus, I was not getting, the dye was not filling in the distal after taking the second pilot 150 wire. So I took a thrombosuction catheter to the mid LCX segment and inserted dye to visualize that the wire was indeed in the coronary sinus tributary, most probably in middle cardiac vein. And then again I attempted a second wire from another channel. And again I parked the second wire in the distal vessel. Still I couldn't confirm whether it was in the true lumen or not. And all the dye which was giving from the guide, all the dye was going in the coronary sinus because of the previous wire and balloon perforation. So again, I pre-dilated over the second wire 2.520 balloon so that I could pass the thrombosuction catheter again. And then after thrombosuction catheter passed, I injected dye through it, which confirmed that the second wire is in the true lumen in the LPDA vessel. So the plan was to remove the first wire and then put a cover stent across the second wire, which was confirmed by in the true lumen. So I took a cover stent graft master 2.8 by 26, positioned across the mid LCX segment, and then inflated gradually. After that, there was complete occlusion and sealing of the CS perforation. And the proximal to mid LCX segment was again second dash was deployed, and the OM got shut down. So I had to again negotiate another wire in the OM, do some dilation to open up the OM vessel. And at the end, the whole segment was aggressively post-dilated up to 24 atmospheres with 3 mm NC balloon to properly optimize expand the stents. So at the end, final result was a TIMI3 flow in the dominant LCX and a good distal flow and the complete sealing of the coronary sinus perforation. Later on, I researched in the literature. I found out that only 3 to 4 cases have been reported in the literature till now. I also made a case study and submitted in various journals. Still, it's in the process. And as I previously mentioned, there are multiple treatment strategies. Either you can leave it medically, do a coil embolization, cover stent graft, or surgery. However, this was a major coronary sinus perforation. It was created large AV fistula. So initially, patient remains stable for 1 or 2 months, as pericardial lesion doesn't develop. It is intracardiac. But later on, patient indeed develop heart failure due to large AV fistula and left to right shunt, and patient can go into heart failure and volume overload. So closure by cover stent graft was planned and it was successfully done as a parallel wire technique. And patient remained discharged and is followed up since many years. This case was done in 2017 or 18 after 1 or 2 years of my passing. Thank you, sir.
Which was the wire that you had used?
Pilot
200.
Pilot 150.
I am accustomed with only Pilot 150 or Fielder wire, and at the end, then only I go to Gaia, because this was a scheme patient and the hardware availability was limited. So that's why I have to opt for whatever the hardware was available on the shelf.
And how did you primarily, which view that you really got a confirmation that CS is there? Did you have a venogram which was there, or that already it had created a fistula in your
no, just after the first wire is this in this view. After doing a 2 mm balloon, just
that can be clearly seen that you are.
And in a allocranial view clearly showed that it was a coronary sinus.
A couple of questions are there. One is the big difficulty for you was to really get into the distal circ, that is LPDA, and you were into you were into one branch, and you took that thrombosuction device, which I think is a pretty heavy device, walking into circumflex, which was also not very healthy. It will take a lot of time, so you're likely to produce a lot of ischemia. Also look at the left main and guide. I think leaving a thrombosuction device from LM into circumflex and trying to, thrombosuction devices are in and out. Yes, if you keep them there, I think it's a source of ischemia. The same could have been done by another dual lumen catheters, which are relatively handy and small.
Microcatheter, dual lumen, all.
Yeah, that could have been easy.
Hardware limitation in this case.
So in the limited hardware, the other simple trick which can be done in such cases, because it's a relatively free communication in the left AV group between your arterial
Second
system.
option, I had do a ruptured balloon and then put a
No ruptured balloon. It's already seen you on the CS. Your problem was that you are walking out of the AV groove into an ventricular branch short of the LPDA, because your target was to get to LPDA. So the simple trick would have been that the wire which had 150, which had gone from left AV groove circumflex to CS, on the same wire which has walked into the CS distally, push the wire as distal. Where will you go? It go to RA and then RV and wherever. It gives you a lot of strength. Then you take a balloon over it, and inflating any balloon in CS, even if it is a 10 millimeter balloon, is not going to create any problem. So you can take a big balloon, a compliant balloon, inflate it, and try to bring it back slowly. It will kind of block the communication between the artery and the vein. And at that time, your crossing from AV groove into the distal will be pretty easy, because here the problem is you're trying to walk into that easily. That would have been pretty easy. The second comment is that you started having a problem in the big OM at the proximal end. I think in the hurry, probably your placement of stent could have been stent graft, because you perforated. If you look at
No, sir, the stent graft was way distal to the OM origin.
Way distal, no?
Yes, sir.
So, yeah, that's what I'm saying. That positioning could have been little better, because it's not a kind of tamponade where you want to put a stent graft. It's a cool situation, AV communication only. So your precision could have been much better than this.
Elective also, but then I got a distal wire. Second wire was confirmed within 2 lumen, and after aggressive predilation, I could negotiate the cover stent. So I did it in the same procedure.
And worst come worst, if nothing is happening. Not CS. It's a small communication between distal circumflex and CS. What went in just a wire, and maybe some gears went in. Na? So now your wire is free. That pallet 150 is freely going from distal circumflex to CS. So you take any balloon inside the CS and inflate a balloon and just pull it back.
It can increase the range.
Just in any case, even if it increases what? It's a bigger AV fistula. Na? In any case, you already have a stent graft with you, and worst come worst, if nothing is there, you put a stent graft from in the proximal part where you started, just put a stent graft. These kind of fistulous communication, unless they are pressurized, they will close.
Last option, I could have done LCX2OM.
Yeah, LCX2OM covered stent. So even if you do whatever, you take LCX2OM covered stent. That would have. So what I mean is, the life would have been very, very easy if instead of using a thrombus suction device, you had used a dual-lumen microcatheter, and if that was also not available, then a blocking balloon technique in which you take a balloon on that first wire, take it into CS, gently bring it back, keep taking shots wherever you find the exit of your dye from artery to CS is decreasing. That will make your life. Maybe these are the techniques which you use.
This is a long cover stent, so you put oral anticoagulation or antiplatelets?
No, on a dual antiplatelets potent, ticagrelor and aspirin. Patient was chronic smoker and also drug defaulter. As he was from periphery village area, and he was just a laborer, so he doesn't have any awareness.
With the resource constraint.
Yeah. I think great job done. Thank you very much.
Thanks.
Ankush, is he here?
Ankush is not there.
Ankush Gupta.
Parag?
Okay, if he's not there, next case number
Parag
7.
is there.
Autologous fat embolization for a very small multiple perforation in complex CTO. Parag.
Do we have a pointer or something?
The next person here, the next presenter.
Just the lighter side of it. Can you put a heterologous fat? What will happen?
We'll
get rejected.
We'll have to get an animal from outside.
No. See,
from our
owners,
yeah.
Inside the cath lab itself.
So we can use the clotted blood of the patient.
That was the lighter side of it. Not to get into details.
So thank you, the chairpersons, and I'll be straight away going ahead with this case. This patient lies with me for the past probably 9 years. She's a 70-year-old female now. When I did her PCI in 2015, which was an LAD and LCX PCI for angina class 3. So I've put my words very specifically that she was pre-diabetic, and she also had SLE and scleroderma. She had a prior angio at the time when I did a PCI in 2015. She had an RC of 50% disease, and now for the past 2 years, she was having angina class 2. I escalated the medical therapy to the maximum, but now she started developing an MR also, which was moderate. So taking into consideration all these things, I took her for an angiogram, and this is the angiogram, where you can see that the LAD is flowing well, the stent is doing fine over a period of 9 years. The circumflex stent, after that, there is a small significant ISR. The distal circumflex is doing fine. RCA was filling retrogradely, as can be seen in the epicranial view. And the right injection shows that there is a chronic total occlusion of RCA with the bridging ipsilateral collaterals, and doesn't look like a very big segment CTO, and there appears to be 2 parallel channels in the CTO, but not very sure by this angiogram. So we took a bilateral angiogram to see whether the artery is filling the retrogradely also, which was filling partially retrogradely also, but predominant the flow was antegrade. So I kept the CTO PCI simple, used a fine cross microcatheter. My first choice wire for this was a Gaia second wire, and it took like 3-4 minutes for me to cross the CTO segment, and the wire was placed in the PLV branch. The important thing which I would like to bring to the audience notice is that the wire never went into the PD branch. It always went into the PLV branch. And then I ballooned. Initially, it was difficult for me to cross the fine cross microcatheter into the distal vessel. So I had used an anchor balloon, which is also my personally favorite technique for getting a support. So I used an anchor balloon, and the fine cross was through into the distal vessel. And then I took my balloons and did the stenting, and everything went fine. This is the final result of the RCA. We had placed 2 stents. Distally, it was not stented. We stented from a zone where we found it was healthy. Circumflex was also stented after the RCA was done, and patient was shifted to the CCO. After almost 2.5 hours, the resident came.
Are you happy with the final shot of right coronary artery? See,
I don't know if this is the final shot of the right or the circumflex for that matter.
no, the right, see, once you complete and CTO PCI, the wire should be out, one.
Yeah, yeah.
And you should have enough field of vision.
Yeah.
And tell your technician, don't move the table.
No, move
but you yourself should be with your foot switch and pedal pressed on till you find everything is cleared.
Yeah, yes.
And sometimes it's a good practice to give lot of vasodilators, because sometimes your wire has visited outside the vessel and gone to the pericardium. And that area will be kind of vasoconstricted, and your casual shots will not show you anything.
Yeah.
So I think you should never finish your final shoot unless your wire is out, you have given enough dilators, enough field of vision, no movement, enough dye, and because whatever stented segment there, I think nothing. Rest of the people are looking at there. Let me tell you, most of the time your assistant will be looking at stented segment. They'll tell you well expanded, not expanded, whatever. You should be looking at where most people are not looking at.
Yes, no. That's a branch overlapping in that region, sir, where the microcatheter tip is there.
The second PDA, there is a second branch.
Yeah, that's an overlapping segment, sir. I'll show you. We'll come to that. It's an interesting case of perforation. So after 2.5 hours, when the patient had an effusion, so we took her. We did a puncture in the zephysternum, took a wire across it, drained almost 150 ml of blood. But still, after taking multiple angiogram of the right side, because that was the CTO segment, we were not able to actually localize where the perforation was. So I took another nice angiogram with good fluoro quality, very high fluoro quality. And what I was able to see is there was like multiple perforation, not one perforation. The PLV was having 2 zones of perforation. If I can enlarge this further, you can see here, as well as I'll show you here, there's a nice gush.
Yeah, below the pigtail.
Yeah, there's a gush there. And this gush is not only from this vessel, there's a gush here, there's a gush here, and there is a gush from the PLV also. So there were 4-5 perforation, and to be very sure, I never went with the Gaia in the PDA. It was always in the PLV.
The ghost had not come there.
So I was not sure why, and such type of gushy perforations are usually seen during the procedure. They usually don't get non-recognized.
So
they usually should get recognized in the procedure.
Can we just look at it? See, there are difference between the first and second shot. Second shot is with the guide deep in.
Yeah.
And with a lot of pressures.
Yeah.
In fact, that should always be resisted.
Yeah.
This can make your story worse. What could have been done in such a situation is the kind of guide position in the first panel. I think that would have been acceptable to me, and lot of vasodilators, tons of vasodilators. You can give tons of vasodilators intracoronary, and you can give NORAD systemically just to take care of the hypertension created by it. Many a time, those leaks which are not apparent will suddenly start showing. They'll suddenly start light up. And many of these patients, they will bleed once they are into the ICU. And couple of hours down the line, once they bleed, they have some hypotension, they again go into vasoconstriction. So by the time you bring them to the cath lab, you want to check, you see nothing. In fact, if you send these patients to, unfortunately, to surgery, surgeons will never be able to find anything.
So how much
there will be no.
vasodilator you will give? This is NTG you are giving.
In my cath lab, in my cath lab, almost every case will get 505 ek. The 505 ek, that's a slogan with most of my technician knows. 505 ek. 500 is 500 micrograms of nitroglycerin. 5 is 5 milligrams of diltiazem. 1 is 1 drop of norepinephrine or epinephrine. This combination, this kind of it works in most of the cases, and we give it slowly. And if there is bradycardia, you should be aware that you have to handle that bradycardia with epinephrine, more of epinephrine intracoronary. If you find there is hypertension, then we have a norepinephrine which is ready with us, which should be shot in from the veins. In fact, I do this 505 ek in almost every angiogram. Forget about CTO and all. And this brings the peripheral circulation, it just becomes pristine, very clear. And many times the size of the vessel, which we say, एंजियो पे 2.5 लगती है और आईवस के ऊपर 3, 3.5, 3.5 लगती है. And many times we all know that before you want to take an IVUS, you will give some nitro and all. And so your angiographic assessment also becomes much better. The only thing is, if you are giving this, a combination of this cocktail, then you have to be somewhat slow. And if you are somewhat slow, then you will find tremendous difference, and you know how to regulate these drugs. Parag, please.
So, yes. So when we see the PD area, there are 3-4 areas here and there are 3-4 areas here where multiple gushy perforations were there. So what I did was, like, I took my wire deep into this vessel, deep into this, even into this branch, and placed a fine cross microcatheter, and patient made a small incision on the patient's groin, took a very small piece of fat, macerated it with a needle, took it into a 2 ml syringe, and then putting it upside down, I injected the fat into that region, and that clocked instantaneously. But there were some more perforations here, so invariably I had to come a bit more proximal also. And after we can see that in this angiogram that there is no filling of the distal vessel, but later on I had to do it for the one proximal vessel also. We can see it here that we are injecting that fat, which has also some contrast behind it, so that we should know that the fat had to reach that area. And finally we had to somehow clock the PD also completely, but the best part of fat is like it gets recanalized in the next 48 hours without recanalizing the perforation. That's the best part of fat. So this is
why should fat get recanalized in 48 hours?
This is what I've shown in my case reports also in the past. I will be coming to that, sir. So this is a very rare case of SLE with scleroderma.
No, why in 48 hours the fat will melt?
So it will autolysis of our body, sir. So what happens is that it remains in that region, and
you have to have a circulation there for autolysis, no?
So it remains.
If you put a fat inside a metal box and implant it into somebody's body, it will not do. See, for anything to happen, just show us because as many number of cases fat ambulation you are showing, I think I must have done hundreds.
So that is why I
fat once goes in, theoretically the fat can get autolyzed and you can get recanalization. Theoretically, yes, but practically it is. I'll give an example. The PVA particles, permanent. If you take gel foam, everybody says gel foam will get recanalized in 2 weeks. That is, if gel foam is fully absorbed and that thrombus which was there is also not fully organized. But sometimes you obstruct a vessel. How do you get CTOs after an acute event? There is nothing. There is no fat, there is no gel foam, there is no PVA particle. You just have a thrombus which gets organized. Exactly. So don't say that the fat will be will get autolyzed in 48 hours. So that should not have been the target. I think it's...
Pulverize the fat. This one. How did you pulverize the fat?
We take a chunk of fat, sir, and we pulverize it using a needle.
From the groin.
From wherever. You can take radial, take an abdomen, you can take groin.
Yeah, and we pulverize it with a needle and put it into the hub of the needle so that it can be sucked easily on a 1 ml or a 2 ml. Best is to use a 1 ml syringe and then take it upside down, because the fat is actually lighter than the contrast. It will remain on the top of the needle, and then revert or invert the microcatheter and push it like this so that the fat goes first.
If it does not float, then what?
So we'll have to make it float, sir.
No, you
Or
can
else
have
you can just put it. Just put it into the hub of the micro.
No. See, once you are harvesting a tissue from whichever part, you are aiming at taking out fat. It is possible. It is not all fat. It may be some fibrous tissue also. So if it is a fibrous tissue, this will not float. If it is fat, this will float. If it is a blood, it may or may not float depending upon what is the status of blood. So if you want to block off the vessel, don't get carried away whether it floats or not. You just need something which goes and blocks there. So if it is not floating, doesn't matter. Just push it down, and we have done many number of cases where do not need to invert. If it is not floating, you don't need to invert. Let it go and settle down. With the needle you push it, or with insertion tool you push it, and then you push it with your 1cc syringe very gently. Very gently.
Otherwise
Because
it can be
the big problem while delivering these fat particles by push technique only is that it's an interplay between your force, the size of the particle, and the lumen of the microcatheter. If the particle is bigger, your force required may be more, and what happens is you keep applying force, and suddenly it goes like a missile. If it goes like a missile, it can go out of the vessel.
And it is a major perforation after
So
that.
it is, and one of the sometime if you have a prograde catheter, then you don't need to do all this. Then you just take the standard delivery wire of the prograde catheter, and you don't have to push it like this. Take a prograde. You have dipped that, you have dipped it in dye, and you can see that part walking, and you take it. And sometime if you have a wire deep in, you can take a part of the skin which is cut and pierce it with the wire. Now this becomes patang mein dekha hoga chitti udate hain saath mein. So similarly, so all those people who have played kite flying, in the kite flying, if you take something, put a hole, and put a thread out of it, this air will take it up. Same thing can be done. You can take a very small piece of skin cannot be pulverized, pierce your wire, the back end of the wire. Now this goes over it, and you push it with anything, microcatheter balloon, it will go there and block. There are some places where your microcatheter cannot go, or you do not have a microcatheter. In that situation, you can take a small piece of skin, create a hole, load it on a wire, and push with anything. Anyhow, great job done.
So
I think
there are two food for thoughts in this case, sir. Whether the perforation was really wire-induced perforation, because she's a case of SLE with scleroderma. I am thinking like this is a chronically underfilled vessel, which suddenly with a gush of flow, there were multiple perforation, and because these are the patients who have corkscrew multiple collaterals. So that is one thing. And sir,
you may have 1,000 collaterals, but they don't communicate with pericardium. So you had a pericardial effusion, you aspirated 150 ml. So, see, let me tell you, it is always you have visited, intentionally or unintentionally. Whether you caught it on camera or you didn't caught it on camera, it's a different story. That is why people say any complication within 1 hour, within 6 hours, within 1 day is procedure related. You have to explain rather than saying isko pehle se tha. So in fact, if you...
It's a very unusual perforation that we have to admit.
What?
So this was bothering me, whether this was wire-induced or not, but it is very unusual to get multiple sites within the same arterial territory, within the same branch. So it is not just 1, 2 or 3, it is about 4 or 5. I do not know if they were even...
One reason could be that during the time of injection there was some wedging.
Yeah,
that they can blow open some of the weaker links.
Which is like a
Weaker links.
happening
Yeah.
naturally, which is something which
That
you
can happen.
understand.
Or maybe in SLE it is fragile.
Yes. SLE and scleroderma has something to do with this.
That's a vasculopathy.
You know, we understand that inflammatory
And like
diseases...
we did her echo after a few months, because this was done in the month of August. She has absolutely normal left ventricular ejection fraction.
You started with a normal EF, kind of. Yeah.
And this is our case report where we have demonstrated also how to take a fat. This is not floating now because the syringe is lying on this. And in this case, report we specifically showed that how the autolysis has happened. All 3 cases we embolized. One was a PLV embolization, one was an LAD distal. They recanalized.
No, autolysis can happen. Second thing is wherever a thrombus went, either you have thrown a thrombus or a thrombus formed around the fat, that getting dissolved or fat getting dissolved. We know it, but we can't give a statement in 48 hours this will be low. By the time in 48 hours the vessel and myocardium will go off. So let us not just get carried away. I think that was not a precise placement of either could have taken a coil there or taken a microcatheter there and delivered very small quantum of it. So I think losing out PD was, I think, in a way, a defeat. Don't say that it's a win-win situation. I would have never aimed, I would have been very unhappy if I lose a PD in that situation. I would have been very happy by just free flow of that distal one and another one there, and then just reverse anticoagulation. After all, these kind of bleeders, they all stop. You have a groinal bleed, you press it for a while, they stop.
So would you have waited over there for some period of time?
Yeah.
No, was the patient hemodynamically deteriorated?
Once you have
after
a
150 ml, were you were you aspirating still after an hour?
Aspirating, and that's why desperately I used this as a
because otherwise, to my mind, just block it to the proximal with a balloon. Once your gear is out, give some protamine, depending on the ACT. I think it should be
ACT
good.
was 168 and we took her
So
to the table.
very strange. There's something very strange which are not explained in this.
And that's why I brought this concept of like she has vasculopathy and this perforation I am not very
We
sure.
should then be getting a lot of perforations in regular lives also in these patients, which we don't. We should get perforations in small vessels in the eye. We should get perforations everywhere. If you really think like that, but then at least I think we need to think about this a little more before we accept your hypothesis.
See, there is a clear difference between two panels, first panel, second panel, and the guide little out and like guide little in. In fact, the moment you want to see little better, you want to take a bigger guide, you want to go in, you want to give a contrast with some force. So this is a big recipe for worsening of perforation, regardless of the cause.
Rather, exactly, the left panel you don't see anything primarily.
No, left panel also there are 3-4 perforations. We can see there are 3-4 perforations. We can see it over here.
Yeah, it's very strange because it wouldn't happen with just
Yeah. If you look at it, two of them I think are coilable and are size enough to be occluded with fat. And rest of them, I think, the moment you take care of them, reverse apparent, take out everything, keep a watch on his pressures, have a pigtail in. I think, in my practice, they should have.
Thrombin, fat,
Yeah.
it can be used interchangeably depending on what it is. But I'm a little perplexed as I don't know.
And wherever I always feel that out of all of them, in my experience, probably hundreds of perforations have in the last more than 30 years, 35 years of my career. Hundreds of them, I have been able to handle them. And in fact, we handle them with as much ease as if you are just trying to coil some common fistulae. And according to me, the most reliable way of controlling perforation is using coils. Because you can see them, you can control them. And in fact, if you have some friend of yours who's in neuroradiology, then you can take Guglielmo coils. And these coils are detached. They are detachable coils. You take the coil there wherever you want to deliver. Be very sure that the things are fine. If their things are fine, you deliver 10 volt of current from outside. This will get broken. That solder will get broken. So then those coils will be there. So they are kind of what you want. You want to see the best thing about small vessel perforation is that you can sacrifice them. And if you want to sacrifice them, then sacrifice them in such a way so that they don't come back again.
Can I just ask you, suppose what you have done in the mitals, you know that Dr. Trehan has popularized a procedure that if you do have a stitching phenomena and you've trained it during a balloon mitral valvotomy, and then you inject biologic glue into the pericardium, and it kind of goes exactly to the point where the stitching phenomena had occurred and seals it. Right, sir? So in this case, were you to do that, of course, there's a challenge because this is a coronary event. So I don't know whether that would...
No, this will be difficult because in PTMC with stitch phenomenon, you have that big dilator there which can guide your things there. Here, you don't have...
We had 2 wire perforations. I mean, it's an isolated perforations. We don't have any coils, anything. The best thing what we have done, you take the coronary wire, soft tip, you cut the small piece, put it that is the easiest way of doing it.
So that some 20 years ago I had published all these things as to how to cut these, how to make coils out of the coils, how to take 1-4 and
that is the best thing instead of searching for the neuro patient.
Actually the problem with them is one is you have to cut them. Third is no. See, let me tell you.
You sharp scissor, you take it, make in a small cut.
Yeah.
Put in a same micro catheter, and push your
Yeah, it goes there. It goes there. But let me tell you the problem with, I started doing I think some 30 years ago. At that time, we used to have hyperflex wire from USCI, which was a 30 centimeter radio opaque part. So you could use 30 centimeter pieces. Here, most of the wires are 3 centimeter. And the pieces, 3 centimeter radio opaque. So if you cut that at the maximum, how many? Some pieces will be there out of that 3 centimeter part. Rest of the part, if you cut, one is that it is not that floppy. It requires a little more strong syringe. It's also not that nicely visible. So, and thirdly, these coils, whatever you see, unlike the fibered coil is a coil which is like this, but is able to take care of closer 10 times than this. And hydrogel wires are about 20 times the surface area of what is being shown angiographically. So this floppy tipped wire I have used like in TOF patients. I have published cases of using floppy tipped wire in Hockham patient for devascularizing the septum and whatnot. But if you ask me honestly, I think that's a poor man's system.
On table you can solve this.
But I'll say that it is not very difficult to have a microcatheter and 2 millimeter or 1 millimeter coils in the shelf. And all of us who are doing, we are putting stent graft now. They are costing somewhat, and these all of them can be. The only thing is you have to do them, kind of do some dry runs at the time when these things are not there. Some like Saturday if I have to do it, so we should do some kind of a rehearsal. And if you have done it, then they are not very difficult. Why I'm saying is that's the most predictable way. In this case, there could have been some issue about delivering the coil into a branch of PD. Then in such a, because sometimes once you're delivering a coil, the microcatheter has a tendency to kind of prolapse back into the main vessel. So that can be prevented by having another wire there and another 1.5 millimeter balloon. You just spin that catheter there with a 1.5 millimeter balloon, inflate it there. Your microcatheter is already deep into that branch which is perforated. And you can almost predictably close everything. Means very predictably close.
I wanted to ask you one thing. Suppose this proximal balloon occlusion.
It's like a block.
If we do a proximal balloon occlusion, long stent we have put, do we give protamine or not?
So let me tell you, first of all, one rule one should remember, which we had made a lot of mistakes in the past. If you have any kind of gears inside your intravascular compartment, in the intravascular compartment, other than your sheath, which you have to leave in any case, not even a guiding catheter, then the moment you are or reversing heparin, everything should be out. Because you don't want two kind of problems. A thrombus on one side and a bleeder on the other side, because that will be kind of an invincible situation. If you kind of form a thrombus in the mid-RC and the stent in this situation, the artery is flowing, but you have a filling defect in the stented segment, and you have a pouring distal vessel. What to do? It is like ice cream le aao yaar jalte hue कोले पर डाल के कैसे ले आओगे तुम? You can't give it. So क्या किया जाए उसमें? I think as long as your gears are inside, your anticoagulation has to be like you are doing in routine angioplasty, so that you don't form a thrombus. And you want to take a gear inside because you know where to go and how to pin it down. So according to me, you pin down two areas, and after that, since there is a lot of ambiguity, you're not very sure, and not every small little bleeder will be taking away life. And in fact, this patient is not in the ICU, he's in the cath lab only. Pull out the gears, have an echo, have your system, and then you can reverse heparin. And in such cases, I think the rule will be, thing will stop. That's the rule. Exception will be that you still continue to bleed through those bleeders which were not seen, and you're trying to look at the bleeders that were not seen. So I think the message from this case is, first message which I gave was, this case, he finished with an angiogram, final angiogram, which according to me is absolutely wrong. You should have seen everything at the time once you were finishing a CTO. Second is, they did manage the case very well. I think the house staff would have managed and called him, because no, they credit to them. But credit to whoever inserted a needle in the pericardium with only 200 ml of blood, not walking from the pericardium into the RV or RA. So that credit can be given. The subsequent injections, I'll say that should have given tons of vasodilators and should not have given a wedge injection. And after that, should have taken care of two big bleeders. And sometime, once you take your microcatheter there and then you inject and see. Because at times, whatever you're saying, vasculopathies and whatever, all of them may not be frank communication with the pericardium. Some of them may be the communication which are already there. So you can take your microcatheter there, just light up that area with a very small contrast. And sometimes you don't have to push contrast with your syringe. You just have a contrast in the microcatheter, loaded contrast in the microcatheter, and you quickly pass a wire just short of the tip. And how do you know just short of the tip? You let the wire be there in the microcatheter, pull it back short of the tip, apply a torquer. This is like you do a sternal puncture with a guard. So you put a guard in the form of this torquer, and then with some contrast in the microcatheter, if you push your wire fast, the contrast will walk out of this microcatheter in that constrained environment, and it will outline everything. In fact, this is one very simple way of where you don't want to inject, yet you want to see, and anyway you are passing wires in and out. So you can leave some contrast there and pass the wire. Be sure that you are just not exiting out of the microcatheter, and that can delineate you. Anyhow, but the case was very interesting. We should, with this lot of healthy criticism, which I will call it, I think
it's food for thought,
yeah,
it's not criticism.
Yeah.
Because I don't think we actually know everything.
Completely agree with the panel, sir. Thank you.
Thank you. And Dilip, you're going to teach us some wires this time?
So good afternoon, everyone. So I've been given this task to talk on new CTO wires. So it's my submission that what I have found from the literature, there is not much of new wires coming in last 1 or 2 years.
But do you have as many number of wires as are the degrees with
Yes,
you?
I will skip through this, sir. So probably we are at the zenith of advancements in wire engineering. So these are the CTOs, and we need to approach them. We need to know exactly which substrate we are dealing with, what approach we are going to have, like antigrade, retrograde, ADR, or whatever the possible strategy. Then we decide our wire in these situations. So before I dive into the new CTO wires, let me just give a glimpse of what essential components of a wire. So wire basically has one core, then there is a sleeve, and the sleeve consists of inner coil, outer coil, and the coatings, the jackets and all, and then there is a tip. So this is how a wire is made. And the core is of stainless steel. The stainless steel core gives more strength. Nitinol core gives more flexibility. And then there are coils of on the core component, and then it will add the strength and the torqueability. So nitinol gives more of floppiness and the flexibility, and stainless steel give you more of strength and penetrating power. And it also depends on the length of the tapering segment of the core, and if it is a little longer, it gives you more ease of prolapsing and passing through the side branches. And these are the spring coils, and the inner and outer coils, and the polymer jacket, which is extending till the tip or not, only limited to the ribbons and coils. So these are the various designs, and the polymer cover and coating gives you more lubricity. And if it is hydrophobic and there is no coating, then you have a good tactile feel, and that is very important when we take harder wires. So I think all of us sitting in the room are aware about all these wires which we use. And what's the new? What's the new is the new technology is happening more in Ashai front. So this is the composite guide wire structure. And this is not the competitive side. I don't know why they gave us. Just.
We are not marking you.
Yeah, yes.
You already marked 100%.
So this is the composite guide wire structure. So a core wire, the core component is mounted over by an inner coil, and that is the Act1 technology patented from Ashai that provides torque force, torque response, durability, and flexibility. And there is an outer coil, which is extrand coil in Gaia Next. So this is how complicated a wire is. These CTO wires, newer wires. So there can be a single wire which makes the coil, or it can be a single wire rope coil. There can be a multiple wire coil, and there can be a multiple wire rope coil. So if your wire is having a multiple wire rope coil, just like Gaia Next, it will give you 1:1 torque response. So every Gaia wire tells you and ensures you that torque response will be 1:1, but Gaia Next probably ensures the most. And this is the cross section. There is a core, the inner coil, and the outer coil. Outer is the extrand coil. That is also a patented technology. And just to have a look of further details. And these are the tip loads. And not only the kind of core and the cables, it's for core and the coils. The tip is also a little different. The tip is a micro cone tip in Gaia Next. This allows better penetration and also having a trap resistance. So many times when we are going for a calcified CTO wiring, we see that our tip is getting stuck somewhere, and some part of the tip of the guide wire can be retained there as well. Ashai Gaia Next ensures that nothing is trapped. So I will quickly go through this case. This was a long CTO and of the RCA, and I initially started with antigrade, and this was a Gaia second wire. It crossed the CTO segment every time it was going into the side branch, the marginal branch. I did try a double lumen catheter, nothing was working, and then I went to retrograde, but none of the connectors were connected to PDA. You can see here, it was not connecting. So I shifted to Gaia Next here. Gaia Next can take bends, and you see how well the Gaia Next took the bend and went into the normal lumen, and finally we could do the procedure. So Gaia Next is a good a wire to have in ourselves in kind of complicated cases when Gaia 2, Gaia 3 is not working. Gaia Next can negotiate through bends. It can have a more predictable penetration. Gladius wire, we all know it's very, very useful. It's a soft, stiff polymer jacket wire with Act1 technology, again from Ashai, and it has a slip coat coating, and it's a hydrophilic coat, and this is not a very heavy wire, but it's very, very kind of negotiable. The beauty of Gladius Mongo is it will allow you to give you a smaller knuckles. Why smaller knuckles? Because there will be lesser hematoma, and chances of hematoma-induced problems will be lesser. You see a Pilot 200, how big the hematoma you're going to create. You're going to get a knuckle, but the hematoma you are creating is little larger, and Gladius Mongo give you a kind of contained and a desirable knuckle. So I will flip through this, and torque response, again, Gladius Mongo is good. And these wires, they don't tend to go outside the vessel. So give you a knuckle, but doesn't give you
Do you really need any torque once you have a knuckle, small knuckle formed by Gladius Mongo? Do you really need a torque?
Not much, sir. Yeah, not much. So this is a case where antigrade we failed. We went to retrograde. Retrograde wire went to left main, which is insurmountable plaque, and then we wanted to knuckle it. This is the Gladius Mongo, how it makes a knuckle. And then septal stuffing. Many Indian cath labs, they don't have SUO03 wire with them, and that is an essential wire, I can tell you. So it has a ability to cross the epicardial channels with there and see how well it can cross. And finally, one or two wires which are important: Hornet wire, a Stato wire. These are very high tip load wires, 20 to 40 grams. Stato is used in Basilica in procedure in TAVI. So it is such a hard wire, and it virtually is non-directional stiff penetrative wires, good for lesions which were conventional wires like CP12 fails. And
basically a peripheral CTO wire.
Yes, sir. And this case was not done by me. It was done by one of the Japanese operator who came to my center, and I was surprised how diligently he saw the IVAS and punctured the true lumen. And this was a CF12 wire was used, and a similar job can be done by Hornet and Stato. And I will leave you all with this was the final result of that patient. And I will leave you all with this wiggle wire. Wiggle wire, I just now inquired. I haven't used this wiggle wire. This is a Abbott's wire.
This is not available in India, despite
Abbott just told that it's available.
No, let me. This
limited, yeah.
Because let me just. This is not available in India. I've been telling Abbott people for last nearly 15 years. The biggest user of this wire is Paul Tiestin from Tuft, and almost 90% of the wires which are manufactured, they are all used by Paul Tiestin. And last time I had a word with this. They had already raised this demand with the Abbott people. So it is possible that they have just come with the wire.
Yes, sir. The wiggle wire has a bend at the distal end of the shaft just before the tip. And how to wiggle?
It's about 7 centimeters.
Yeah.
Is
So this is the last slide. So when encountering an obstruction, position the curves of the wire adjacent to the obstruction advance the catheter over the wire, and if necessary, advance or retract the wave of the wire from the catheter to redirect the device tip from the obstruction. This is how it is used. So immense development has happened in the wire engineering front. Knowing and rightly choosing the wire can significantly increase the success of CTO wires. Thank you so much for the patient hearing.
Thank you very much. In the wording of Paul Tastin, this wiggle wire with a 7 centimeter of wiggles, the how to use it. And the commonest situation where you have to use this wiggle wire is that you have stented and you want to take a post dilatation, you want to take a NC balloon, which are anyway stiffer, then the material is also stiffer. If you have a guide wire bias, then the guide wire bias will try to take your balloon, which will be striking at the edge of the stent, at inlet. And the more you try to push a balloon, more the edge of the stent gets inverted. And after some time, it will become difficult. And of course, most of us know it that if there is a wire, put another wire, then kind of take a parallel wire. But buddy wire. But how Dr. Tastin does is, he takes this gear, whichever, let's say microcatheter is not going over it, or IVUS catheter is not going, or whatever gear is not going over it, take it close to the site where it is supposed to stop. Now, with a gentle push on your gear and pull on your wire. So your wire is like this. So if you push your gear, whether it's a balloon or whatever, and pull your wire, because the wire is like this, the wire will just get off that guide wire bias. And the moment your nose cone of whichever gear gets past that, then it's pretty easy. Second thing is, if this trick does not work, because sometimes if you're doing it like this, then your wire gets pulled too much. Then what you can do is you can have your wire and your gear together and advance them like this, together. So this is what his wording, that it works in majority of those situations where a guide wire bias is preventing your gear to enter into the stent after deployment.
Yeah, but there are new wires which are coming.
So, Dilip, you are confirming that this is available? Just now he told me. So, I think last meeting I again kind of pressurized them. Why is it so that last 10, 15 years you're not getting?
But
they were saying nobody wants to use it.
With the guide cut extension having come, the buddy wire utilization and the wiggle wire utilization should come back. Because they've been game changers in a lot of our practices. There are a lot of new wires which are the Guy Next Door, of course, we heard about during this meeting. The Conquest Pro ST and the Conquest Pro Super ST which is the super sharp tip, are going to be available. We already have the Astrato 820 or the Conquest Pro 820, which is available. Astrato 30, 40 are also available, which are peripheral wires. The idea is to keep life as simple as possible, not go as complex, and simplify their utilization. Plasma wire is a very exciting new concept, which once available, we'll probably be able to think that CTO is not really the last frontier.
So I thank my colleagues and all the audience, and we close the session. Thank you very much.
Thank you very much, sir. Thank you, Vijay.
Sir, in any
Anil,
session
sir.
when Dr. Trehan is there, the sessions are found to be very interesting and lively. So please give him a big hand.
We really thank you, Terence. It's always your educative part which always helps fellows for their learning. Thank you, sir, for an excellent session, and thank you all participants. Next, we are moving to the next CD presentation session. It's the same, the rules remain the same. It's 8 plus 2 minutes. At the end of 7th minute, one single bell rings. At the 8th minute, there are 2 bell rings. There are 2 minutes of discussion. I request chairpersons to come on to the dais. M.V. Reddy sir, Sridhar Kasturi sir, Raghu sir, Guru Prakash sir. And discussion Ranjit Kumar sir, Srinivas Reddy sir, Rakendra Singh sir, Damodar Rao sir, Sahu sir. Hi. I request all presentations, please stick on to the time. There are 3 exciting prizes waiting for you for the best 3 participants. So the judges will be the chairpersons on the time. It depends on the each novelty of the topic, presentation skills, and the scientific importance. First presenter, Rajaram, PCA of the calcific RCA CTO. Sir.
Respected chair, audience, good evening everyone. My case is a 75-year-old male patient, hypertensive, presented to our ER with the chest pain associated with shortness of breath since morning. So he is a known case of ischemic heart disease, underwent PTCA plus 10 to circumflex in 1996, underwent CABG with 3 grafts in 2001, and PTCA plus 10 to RCA in 2007. Now the patient presented with the ACS, that is chest pain. ECG was showing ischemic changes in the inferior-lateral leads. 2D was showing there is no RWMA. Ejection fraction was 56%. Investigation showed trop I is elevated, that is 345 nanograms per liter, but otherwise other parameters are normal. So diagnosed to have the ACS and STEMI with good LV systolic function. With that, we did the angiogram. It is the LAD injection showing there is a severely calcified LMCA as well as LAD and SERP part. Proximal LAD is showing 100% stenosis. Proximal LCX is around 60 to 70% stenosis. Mid LCX, it is stent is patent with mild ISR. But the interesting part is there is no visible collaterals anywhere from the LAD or from the graft also. There are some small retrograde filling of the RCA with the branches from the circ. And this is the RCA injection where you can see the diffuse disease, and it is severely calcified from proximal to the distal, and the mid part of the RCA is showing stent is patent with mild ISR. Distal to the stent there is a CTO with ipsilateral bridging collaterals, and there is a good distal vessel. So with this, the JCTO score, the cap is somewhat tapered but short lesion. Collaterals are present, severely calcified. So it is next we did the graft angiogram, showed Lima to LAD was patent and radial artery to OM was patent, and SVG to ramus was proximal 100% stenosis. So with this, the JCTO score of approximately 2, it is going to be difficult, and the STS score was showing morbidity and mortality of 19%. So heart team advice was to PCI to RCA in this case. So we went ahead with the JR 3.5 7 French guide catheter. So initially we tried to cross the lesion with a Ranthro wire but failed. So we kept that wire in the RV branch, which is just proximal to the cap. Then we took the Crusade dual lumen catheter, dual lumen microcatheter, and then through the dual lumen microcatheter, we tried to pass with the Fielder XT wire. We could not cross the lesion. And then we took the Gaia 2. With the Gaia 2, we have perforated the proximal cap and then entered into the body, but we could not perforate or cross the distal cap of the CTO. Now finally, we took out the dual lumen microcatheter. Over the Gaia 2, we passed the fine cross microcatheter. Through fine cross microcatheter, we have perforated the distal cap with the Gaia 3 with a difficulty. So over the Gaia 3, just short duration, only short distance Gaia 3 was perforated. Then we have tried to pass microcatheter over that, but we could not. Then we exchanged that Gaia 3 with the regular wire, that is Ranthro wire. Over that, we have tried to pass the small balloons, 1 into 5 mm Ruri balloon and Alveo HP 0.75 into 10 mm balloon. And these balloons are also we could not cross across the distal cap, which is severely calcified. So in view of severe calcification, so we have decided to go for the rotablation in this case. So Ranthro wire was replaced with the rotafloppy wire. Then we did the rotablation. So up to distal part of the distal cap part, we were able to rotablate, but because of bend and all those things, so we were not able to cross that bend initially. We took the rotablation burr of 1.25 mm burr. Then initially we thought that we will go for the pre-dilatation, that is a halfway rota strategy. Then we took out the rota floppy wire and then exchanged it with the regular wire. Over the regular wire, this time we were able to pass alveo HP 0.75 into 10 mm balloon. Then we have dilated it. We have dilated the part just distal to the calcified lesions. And followed by, we did pre-dilatation with the 1.5 into 10 mm and then Ruri and 2 into 10 mm Ruri balloon. Then in view of severe calcification, we want to do IVL in this case. So this is the, initially we did the IVAS run. So IVAS run showed severe 360-degree calcium from the distal part of the RCA to proximal part of the RCA. And very severe narrowing, these are the still images. The severe narrowing, it is almost in the mid tightest portion, it is 1.6 mm after the post dilatations. Then we have decided to go for the IVL balloon in this case. But we could not press the IVL in the tightest portion. Again, same problem has taken place in spite of pre-dilatations. This time again we have exchanged that regular wire with the rota floppy wire, and then this time we want to do full rota. So this time we were successful in passing our rota burr across the complete lesion distally. So this is after complete rota. Now after that we were able to pass the IVL catheter over the regular wire. So we did IVL 2.5 into 12 mm balloon. It is 120 pulses from distal RCA to proximal RCA. Then after that, so further block modification was done with the NC balloon 2.5 into 12 mm balloon. Then this is the IVAS run showing adequate block modification with various plaque ruptures we can see. And then we did the stenting in the distal RCA 2.75 into 38 mm resolute onyx frontier we have kept, and then proximal RCA was stented with 3 into 38 mm resolute onyx with the overlap of the distal stent. Post dilatation was done with the NC 2.5 into 12 mm and 3 into 20 mm balloon in the proximal portion of the RCA. So this is the finest IVAS run showing a good MLA, distal RCA showing 5.3 millimeter square and proximal RCA showing 7.4 millimeter square. Final result was good TME3 flow. To conclude, a sequential strategy, planning and various techniques, sometimes in isolation or in combination, are required to tackle the calcified CTOs. Antegrade wire escalation as a first line approach in the case of non-ambiguous proximal CTO cap. Good quality distal vessel and short occlusion length, less than 20 mm, is the ideal one. And intravascular imaging offers precise lesion characterization to guide strategy, tool selection for a tailored lesion preparation and recanalization technique. In balloon uncrossable calcified lesions, rotablation followed by IVL is an effective strategy for superior lesion preparation, stent delivery, and optimization of stent expansion. Thank you.
Why initially half rota was done? It should have completed at the time only.
No, actually we want to do the full rota only, but because of severe bend, that we were not able to negotiate even with the, by the time we have finished almost 6 to 7 runs. That is what I have shown. So after that we have changed our mind. Okay, we will take out the rota burr and then we want to do some dilatation, pre-dilatation.
But initially you had a difficulty in passing the micro catheter also, right?
Yeah.
But how did you exchange your rota wire?
Just we have kept that micro catheter at that distal part wherever it has stopped it, and then through that micro puncture wherever we have done, through that we have passed the floppy wire of the rota wire. That is a risky because we were not able to pass the another side wire just beside that Gaia wire.
in the initial part, you didn't use the guideliner. You have taken the help of guideliner in the second part.
Yeah, initially when
In the
we were
part
not
one,
yeah,
where
yeah.
you were not able to pass the balloons and all.
From the beginning, we were having initially we took the dual lumen microcatheter. Then later on switched to, once our proximal cap was punctured, then we took
But you
the
have
fine cross.
taken the dual lumen, but not tried the guideliner in the first part. Part one.
Guideliner, no. Guideliner was last when we were not able to
No,
pass
initial
the
part
balloons at that
itself,
time.
when you are not able to
Initially,
pass the balloon, you should have taken a guideliner support, number one. Number two, imaging you should have done initially itself, so that your total planning, right from the beginning, you should have planned properly what is the level of calcium, severity of the calcium, whether rota necessary, IOL necessary, laser is necessary, what is the amount of difficulty you are able to face, so that your planning would have been better if you have done initially.
because that is a CTO, when we were not able to pass the Gaia 1 wire, after Gaia 1 wire, after pre-dilatation, after rota, then we did the IVAS. I have shown 3 total IVAS runs.
Guideliner and dilate the balloon have crossed, dilate, and then IVAS can go.
No, the guide support, AL 0.75 would have been better in this case. So you have a severe bend and you have a severe calcium. I don't know why initially you tried a floppy wire. Initially first wire was floppy. I didn't understand. And why
What we
AL
thought
was
was,
not.
I think we can find out some, because there was a good flow, probably some channels, some collateral channel. Suppose if it is a newer CTO, then we would have easily slipped that wire into the distal part. That was an idea initially.
I think probably they never thought it was a CTO. So they took
Yeah.
a JR, they took a run-through wire. Only when it was not crossing.
Initially we thought
maybe
that it
an
may be
AL
some
would
acute
have.
closure and all those things. So because there was not much of collaterals and all those things. But later on we found that it was a severely calcified CTO with filling with the
Maybe a good guide support and a guideliner would have solved the problem rather than IVL usage. I don't think IVL being a bulky device, it will never cross such a tight.
Even initially that IVAS catheter was also we were not able to pass. This IVAS catheter was also not able to cross. Yeah, thank you.
It's a very good case and has demonstrated excellently the various difficulties and how to handle the difficulties, and finally came out very well. Thank you.
Next case, Dr. Arti Mishra.
Good afternoon, Hyderabad. I am Dr. Arti Mishra. I am representing Mumbai, Bombay Hospital. I am presenting a case which I am a DM cardiology third year resident. I am presenting a case CTO PCI in post CABG when only left main stump was a guide. I have done this case with my professor, Dr. Nagesh Wagmare, sir. It was a 68-year-old male diabetic. His CABG was done in 2019. It was a reverse composite graft. Usually we see lima, lima is attached, rima is harvested and attached to lima, but it was a reverse composite graft. As we received information from the surgeon who did this, he was telling that there was some stenosis at the lima, so instead of rima, they harvested lima and they kept rima as a pedicle graft and lima Y they made. So it was first it was rima to LAD, then second was lima Y to OM and RPLV. Now this patient has presented with dyspnea on exertion, NYHA class, functional class 3 since 5 months and refractory angina since 5 months. As you can see in the picture how the grafts are done. So CT angioimaging was done for this patient. In first image we can see the rima to LAD graft. This rima to LAD graft till rima lima Y was there, it was patent, but beyond that this graft was completely occluded. Lima to OM and Lima to PLV were well-functioning grafts. Then we went ahead with 2D echo imaging. His ejection fraction was 45% and there was regional wall motion abnormality at the LAD territory, apex, apical, intraventricular septum, inferior wall, no hypertension, no pulmonary hypertension and walls were normal. This was the CAG. As you can see, the RIMA Y to LAD, this pedicle graft was completely occluded. Then we proceeded with the angiography. Native vessel angiography, left main, as in the first picture we can see, it was completely 100% left main ostial occlusion with blunt stump. RCA was dominant, ostial 80% calcified lesion was there, and PDA was 70% calcified lesion. This was native vessel angiography. Then graft vessel angiography, RIMA, LAD, totally occluded, as I have already specified. LIMA, OM and PLV, patent but inadequate blood supply. So this was a dilemma situation. Post CABG case, usually we prefer to go with native vessel PCI. Then what should be our plan? Because the left main, only we can see the stump. So we literally felt like dinosaur in a lost world. So what to do? We decided to go ahead by opening this left main. So the hardware we used in this procedure was, access was right femoral artery 7F, and one more access 6 French venous we took. Guide we took was JL 3.57 French. First, initially, we tried to pass filter FC wire. However, in our 2-3 attempts, it was not able to pass. So we upgraded our wire to stiff tip wire, that is Conquest Pro, with the support of microcatheter. As you can see in the upper second picture, with the support of microcatheter, we could advance the Conquest Pro wire. So in the last picture, you can see how the wire was able to pass. We crossed the lesion. Only the nipple of the left main was visible, but we could we could pass the lesion with Conquest Pro. Then once we passed the lesion, then we changed this wire over microcatheter support to more safer wire, that is BMW wire. Then we proceeded with balloon dilatation. First we dilated the LAD, proximal LAD, left main, and as you can see in the last picture, there was also diffuse distal lesion, which also we dilated with a small mini trach balloon. However, in this case, we also needed support of Wolverine cutting balloon. We used 3x15O Wolverine cutting balloon. We did cutting balloon of left main as well as LAD. Then we proceeded with stenting. We had put a Orsiro stent, which was 2.75 by 26 mm in proximal LAD, and in left main we used 3 by 15 mm Zions Expedition stent. This whole procedure we completed under IVUS guidance because it was a left main plasty and very well indicated IVUS imaging. So under IVUS imaging, once after balloon dilatation and stent placement, we again revised the morphology of the lesion. So post dilatation, I'll show the IVUS images after this. But after placing the stent, we post dilated the lesion. First LAD we dilated, then post dilatation of the left main. Left main we dilated by 4x8 non-compliant balloon. So this was the final result. We were able to achieve TIMI-3 good flow, and this CTO we could open very well with the support of IVUS Wolverine cutting balloon and help of Conquest Pro wire. This was the left main IVUS image. First image showed before balloon dilatation, the stent area was 4.3 millimeters square. After dilatation, post dilatation with 4x8 O balloon, the area, maximum area which we achieved at the end of the procedure was 12.2 millimeters square. So these are the IVUS images, pre-dilatation left main. It was a more of fibrotic lesion. Then in the second image, after post-dilatation, the result we obtained, the area, as per the guidelines, we achieved 12.2 millimeters square, which was a good area achieved. So in the second image, we can see the final result. So take-home message from this case was, post-CABG PCI subsets are complex and challenging cases. Only left main stump can be very difficult, but can be possible. Multimodality imaging is very helpful. As in our case, first we did was CT angio because it was a composite reverse graft. Difficult to understand the anatomy, which graft is connected to which vessel. Actually, we got confused because LIMA usually is attached to LAD, but in this case, it was RIMA which was attached to LAD. So imaging is very important in such cases. IVUS guidance is important, taking support of good wire support is important, cutting balloon and all those hardware materials are important. So thank you very much on behalf of Mumbai.
It's a good case, very well done. You have stented across the circumflex.
No, sir. Left main LED.
Left main
Circumflex we didn't touch, sir.
Across.
Across, yeah, across.
So, doing such a big vessel, do you recross and open up the vessel or not?
No, sir, because circumflex was already protected vessel. It was the graft which was given, sir, the grafts were supplying were Lima wire grafts were patent. They were flowing well. So it was a protected. RCA was protected, CERC was also protected.
Yeah, protected, I understand that. So, if you can give more supply to that through opening, it would have been better, I believe.
Yes, sir, I agree with you. But the time, already fluoro time was 31 minutes. And it considering it a very lengthy procedure, use of dye, and considering all that, we thought better to not to go with all vessel opening in the same.
Because it is better always not to go by the graft flows, because we had one problem where we thought the Lima to LED is patent, and when we doing LM to LCX, when the LED closed, the patient had VT and crashed, and we could revive. So even though we feel that it is protected by the graft flow, sometimes we may not be very sure the level of the flow. So better put a wire and protect. Suppose that circ closes, there is no guarantee that the graft may always protect per 100%.
Yes, sir.
That is one. Another thing is you have taken the guide gel. Routinely in left main you take gel guide or?
Sir, in case of CTO, we take a JL guide because there is, if we take more aggressive guides, there is risk that it may suck in and can cause dissection or catastrophic events can happen if we take more aggressive guides. Like
because
XB,
you don't have any stump, it's a very difficult left main. Another thing is puncturing this, you can take the help of IVAS also. Oh. Left main puncturing of the ostium of the left main, CTO. If you take the help of IVAS guided puncture, it will be easy. And your right coronary artery is having a disease, severe disease?
Yes, sir, it's showing.
Are you handling it or you are leaving that?
Sir, we have left that.
Because even in angiogram, you said that the graft flow was not adequate, even though the grafts are patent, but the flow is not adequate. That is your statement.
Yes, sir. Considering, one point is that considering viability based on echo and all, we thought it's more of LED. LED territory which is showing hypokinesia. Opening such CTO with questionable benefit, we did not.
Yeah, there is a title, osteal lesion. That graft, I think, is not doing a good job for the right coronary.
Yes, sir. In the further settings, we can.
I think it should have been opened first. Yes, it is an proximal lesion. It should have opened first easily. And yes.
Yes, sir.
But it's luckily you can be able to see this small stump. That's what you can able to engage. And
yes, sir. And a very thin line of LED was visible. That the calcified part was helping to direct actually with a small nipple on the left main and a thin in one of the images, a little calcification of LED was seen. So
because
we tried to attempt.
These kind of proximal lesions very difficult to penetrate. Guide will not have a good support. The moment you pass a wire or stiff wire, the guide backs up.
Just probably expertise of ours, sir. Actually.
Another thing is you can take XB, and if you are fear of causing problem, you can use that Serpia wire. You can use another wire, floating wire technique, where you use a wire which floats into the aorta, and it will not damage the ostium of the left main.
Yes,
you can
sir.
take that technique. You can take the help of that technique.
Yes, sir. That is.
Thank you. You have done an excellent job.
Thank you very much.
And made it very simple.
Next presenter is Shahir Ahmad.
Good evening all. The case is a 62-year-old diabetic and hypertensive had presented with breast angina. He had a past history of CABG done in 2013 with a SVG2 LED D1 and OM. Currently, he was diagnosed with the non-ST elevation MI with the TROP positive. He was compliant medication, however, his blood sugars and LDL are not adequately controlled. echo showed a normal LV function, and coronary angiogram was done, which showed a LM to ostial total occlusion. However, this OM graft is patent, whereas the graft to LED, SVG graft to LED was occluded, and the diagonal flow graft also was patent. Also, the right coronary artery had a proximal tight 90% stenosis, so we decided to go ahead with RCA lesion first, since it is very tight. So this was the RCA lesion, a significant 95% discrete lesion in the proximal RCA. We did it from the radial axis, crossed with run through extra floppy NS, and dilated with 2.5 balloon, standard with the 3 into 24 mm DES, and post dilated 3.5 mm NC. So even after this, you could not see the retrograde filling of the LED from this. So, post PHC, patient's angina was still persisting. TMT was strongly positive with the excess capacity of 5.6 meds. Then we decided to do a CT angiogram to see if at all there is any filling of the distal LED in the CT angiogram. And probably the RCA PCA might have helped to give more collaterals and might be able to see distal LED. So now CT showed multiple areas of calcification from proximal to mid LED, and the distal faint filling of the distal LED seen in the CT. So since L6 is already covered by the graft and diagonal is also separate for the graft, we decided to try to put the stent from LM to LED. So these CDO score was 2. So took a dual axis, right radial and right femoral axis. Took a 6F guiding catheter, EPU 3.5, and a TIC catheter to the RCA. Here we can see the simultaneous injection. Now post PCA of RCA, you can see some filling of the distal LED coming up. So initially we tried with the Gaia second and fine cross micro catheter, but however this guiding catheter was not at all giving support and was repeatedly backing out. So we changed the guiding catheter to AL to 2.0, and again tried with the Caravelle micro catheter and Gaia second wire. So with this, we could able to cross the wire till proximal to mid part of the LED. However, this micro catheter won't cross the lesion. So ultimately, Caravelle was exchanged to cos the airport access, which is the torqueable micro catheter, which might be helpful in advancing. So with this, we were able to advance the micro catheter, but however, near the distal part of the CTO segment, the Gaia second won't advance. So subsequently, we escalated to Miracle 6, and ultimately we could cross it with Miracle 12. So again, once we reached the distal segment, this Miracle 12 could not cross, probably might have entered a false lumen or quant unbendable. So since from the retrograde injection, we were able to see some channel retrogradely, we tried to cross it with a field XTA. So with which we were able to cross the distal LED and exchange with the extra floppy NS. So subsequently, we serially dilated with 1.25, 1.5 and 2 mm SC balloons, and ultimately 2.5 NC balloon. So IVAS we did, which showed a diffuse plaque in the proximal to mid LED segments with a reference diameter of 3 mm in the mid LED and around 4 mm in the proximal LED. So subsequently dilated with 3.5 mm NC balloon, but however, this is a short after that. We could not see any septals or anything filling out of it. That's a small vessel which is filling. So probably putting a stent in this without any septals being seen might be counterproductive. So we thought we'll we call after 2 weeks and see how the angiogram is. So now we can see the vessel has grown up. You can see good septals coming from the LED and can able to see good myocardial blush also. So again, this time we took a 3.5 EBU crossed with run through, and we plan to do IVAS. But however, IVAS catheter would not pass the wire, even though wire went relatively easy. Then we probably thought maybe there's a dissection segment here. Probably it might have gone through a false lumen and again came into the true lumen. So we kept the run through wire there and took a Sion black and crossed it through the true lumen. You can see here the two lumens can be seen separately by two passages of the wire. So sorry, this IOS image is not moving. So based on the IOS measurements, we dilated a 3 mm NC balloon. Then we took a science expedition 3 into 48 mm stent and deployed from the LM ostium till the mid LED segment. And this is the result after the stent deployment. We post dilated the LED mid with 3.5 mm NC and LM with the 4.5 mm NC. And subsequently his symptoms also had improved. So basically, we had initially there's a lot of hardware here. Initially, tried with the EBU guide, which could not go. Ultimately, switched to AL. Guide were initially, the initial segment was able to cross with Gaya second, then which could not cross the further segments, then we escalated to Miracle 12, and subsequently de-escalated to Field XT and run through. And Caramel, which could not cross the entire CDO segment, we had to upgrade to a torqueable microcatheter, which is cost there. So in presence of a tight lesion in the donor vessel, the PCA of a donor vessel might improve the collateral segment to the occluded vessel and facilitate CTO intervention later. Coronary CT might be helpful in planning intervention in totally occluded vessels where the retrograde filling is very poor. Good guiding catheter support and choosing optimal microcatheter and taking advantage of unique features of the various CTO guide wires will help to achieve a successful crossing. And vessels with chronically underfilled large side vessels, initial POPA followed by stage PCA might allow the vessel to grow up and make the stent placement easier and accurate. Thank you.
In the first phase, when you have left at that stage, have you checked in two orthogonal views whether your wire is in true lumen in the initial stage, first?
It means when we crossed initially.
When you have just left at that stage, when you have crossed, are you sure at that stage your wire is really in true lumen?
Didn't check at that time, but however.
Because the initial stages, when you are in after you have opened a chronically occluded, you have to recheck before you leave. You have left like that. So before you leaving, you have to recheck whether you are in true lumen or not. Suppose you have dissected and leaving that vessel like that. Suppose the vessel closes, patient goes home and suddenly the vessel acutely occludes. That is also maybe a problem.
But since there are good collaterals from RCA, thought maybe it won't be that much a risk.
Suppose RCA closes.
Yeah.
So RCA goes into a stent thrombus. Because that's why general dictum, not in there, is always open an occluded vessel first and then go for the other vessel when you are doing a intervention of an occluded vessel and another vessel. Try to open the occluded vessel first and then do intervention.
Here the issue was we were not able to see the LAD at all in the initial angio. So whether LAD was there or not, we were not able to show that time.
I think whenever there is a lot of extensive dissections, so that when you want to put a second wire, it's always better to exchange with a microcatheter or a dual lumen catheter. Because
fine cross may do better.
Yes.
It's bigger, softer. Okay, a very nice case done neatly. So we'll go for the next presentation.
Dr. Shravan Kumar.
Respected Chair and good afternoon, colleagues. I'll be presenting a case of PCA to the rescue of the post-CABG LMCS CTO. This is a 66-year-old lady, hypertensive, and has a normal LV function. Actually, the story began around 6 months back when the patient had chronic stable angina, and angio revealed there was a mild LM disease along with disease of the LAD and LCX and mild RCA disease. And she underwent PCA to that critical LAD lesion. And again, after around 5 months, again the patient had recurrent angina. And this time they thought that LM disease was significant, and so she was sent to CABG. And she underwent 2 grafts. One is Lima to LAD and the RSPG to major OM, and that was piggyback to the diagonal. And after this, the patient has come to us after this post-CABG status with symptoms of, again, angina. So we did she underwent an angio. With that angio, she has come. In that angio, there was a LMCS CTO. The Lima to LAD, it was 70% occluded. And the piggyback diagonal was also occluded. And mild RCA disease was there. So at the current admission, when she had angina, she had significantly functional class 3 angina. We can see T inversions in the anterior leads. So this was the initial angina, first angiogram done. Here we can see the LAD lesion is critical. And there was an ostial LMCA disease. And we can see ostial RCA disease. So the operators initially thought that only that LAD is significant. So they stunted that LAD. And after that, again, she had symptoms. So they did an angiogram. Now we can see the LM ostium disease progressed. However, the stent is quite patent. So they have sent her to CABG, but as we can see that RCA there was not significant lesion, so they only advised grafts to that LAD and OM lesions. And post CABG, now she has come again with angina. Here we can see, now we can see there is no flow at all through the LMCA. The RCA disease appears to be progressed little, but it's not critical, it's mild to moderate lesion is there. And the graft, as we can see, Lima to LAD, at that anastomotic site, there is a disease there. We can see it at the anastomotic site. That is significant. And it was filling retrogradely. So what we thought was we'll open the native vessels. So there was no flow at all antegradally through the LMCA. But we had a SVG graft to OM that is patent. So what we did was we passed a wire through that SVG graft. We came into the LMCA and we tried to probe that into the LMCA. So we were lucky enough to get into the aorta. So through that retrograde graft itself, we have ballooned the LMCA ostium. And after balloon dilatation, we can antegradally see some trickle of flow now through that LMCA. But however, we could not cross balloon antegradally. So further we have to again dilate with a larger balloon. And later, now it's a straightforward case. We wide the LAD and we stented the mid part with 2.5 to 48 and the proximal part with 3.5 to 28. And this was the final angio result. So new CTO of the native coronary is quite more after post CABG because there is an accelerated atherosclerosis in these patients. So post CABG we have various options. This patient we have seen the rapid progression of disease over 6 months. So we evaluated whether she could have any autoimmune disease. For that we have done an autoimmune workup. But because the osteal lesions were involved, LMCA, ostium and RCA, but that was negative. And we could not find any features of any Takayasu or else, and markers were also negative, ESR, CRP, and LDL also was very much controlled. Thank you.
But the Lima insertion site only was a lesion, right? The rest of the things, you should have done a PCA to that part. It would have been much easier.
We thought, but we first tried with SVG graft, so we thought that we'll establish the native coronary vessels.
I don't know, because that would have been much easier. I mean, you've gone through the Lima and would have dilated, would have stented that area.
It was exactly the anastomotic site, so stenting also will be difficult to the vessel to the, we have to stent from the Lima to Lima to LAD.
It can be done.
Lima to LAD.
Done also, it can be done. It's not that. And that would have been much easier than instead of going through the left main and putting.
But if at all it gets occluded, then patient will have some problem during the procedure, because that is the thing that is supplying all the vessels now. We don't have any antegrade flow to the LAD, so it's unprotected. So if something happens to that Lima to LAD procedure, then we'll have problem. Because this SVG graft, we have gone through the SVG graft, that's a protected left main. Like LAD is flowing, so we were going through SVG graft.
SVG closes.
Thankfully, it was a recent
because it's a donor.
Otherwise, it would have been
technique.
Knowing that this patient has multiple very aggressive atherosclerosis, did you investigate for LPA levels, other forms of?
LPA we did not check.
So that's why it's because 3 times is.
LDL is quite controlled. Its LDL was 50. She was using drugs. She was taking properly.
Some other, the osteal lesion was not that much. It progressed rapidly.
That's what we thought. Some autoimmune disease might be there.
Must have been something missed. Most probably LPA must have been high. You can go for increased on such case.
Takayasu is not there.
Very good that you have done
Takayasu autoimmune workup, everything was that was
because as the colleagues said,
blood pressure,
it is very, very important to aggressively go through what is happening in this patient, because again, whatever you have done, again it may have trouble, but something is happening which is we are not able to understand. Such a rapidly aggressive atherosclerosis, even in grafts also. Not only stents, native vessels, grafts are also going in for severe atherosclerosis. What are the anti-lipid agents you have put her on? What are the drugs you have put her on?
Atorvastatin 40 and ezetimibe 10 mg.
You have to aggressively control these patients with triple regimes and all those things, and monitor her very closely and regular lipid profile, and then see again this patient may progress further also.
Imaging we did not. Imaging was not done.
But I think you are even in the first instance who has put that LED stent, they should have done imaging actually. I feel your even RCA osteum also looks significant. To me.
In the first place,
So
itself,
if you do
left
imaging,
main,
definitely that
LM
also
and-
will be significant. Yeah, FFR or
It has
imaging
been
like
significant.
OCT
The
and
last again when we did, it was actually.
The
and
first
another thing
operator
is
would
what
have-
stent you have put in the left main, that also I feel it was little undersized.
Underexpanded.
It is
Under-
underexpanded.
undersized.
Yeah, it is
Undersized.
undersized. So I think you have done so much efforts. Imaging is mandatory. You
Any
should
left
not
main
attempt.
intervention, imaging
Otherwise,
is a must,
as
right?
per the suggestions of the panelists, you should have done only the Lima to LED intervention at the anastomotic site. Because putting stent in the left main, again you are inviting the trouble. She may have again.
Such a background.
Very,
Aggressive
very
atherosclerosis.
progressing very.
Anyhow, it's a LMC CTO, so
Again, how many days, months follow up there?
around 3 to 4 months.
As she has.
Probably we'll see how she does.
Maybe she comes back in another 3-4 months.
Thank you.
Thank you. Very interesting and case. So this patient has to be followed up. So it has done the case like a retrograde CTO. So we will call upon for the next patient. Next presentator.
HK Bali.
Good afternoon, everybody. And this patient which I'm going to present has been with me for almost 20 years. He's a 70-year-old male, a doctor by profession, hypertensive and diabetic. He presented to us with the angina of effort for 2 months, which was crescendo, class 3, no rest angina. The past history was very important. He had an ST elevation acute myocardial infarction in 2003. That was class 3, and I had done a primary angioplasty on him in the LAD, proximal LAD. He continued to be in severe left ventricular dysfunction, and he underwent a CRT-D for class 3 symptoms despite optimal guideline-directed medical therapy, and he continued to have angina after CRT-D. In 2023, an angiography was done, which showed a left main and triple vessel disease, severe left ventricular dysfunction with ejection fraction of 22%, global hypokinesia, more in LAD territory, and mild MR. At this time, he was advised a CABG. He underwent a CABG, high risk, off pump, and received SVG grafts to LAD, OM, and PDA. He required an IABP in the post-operative period. He remained angina-free for 6 months after bypass surgery on optimal heart failure treatment. 6 months post CABG, he started developing angina again, and it rapidly progressed to class 3. On evaluation, he was found to be on biventricular pacemaker with a QRS of 130 millisecond. Echo showed an ejection fraction of 20%, global hypokinesia, mild MR, moderate pH. The stop was negative, and NT-proBNP was 700. A CT angio was done, which showed left main critical stenosis, a native triple vessel disease, patent grafts to LAD and PDA, and an occluded SVG to OM. So in view of progressive worsening of angina in a post-CABG patient and CT showing occluding SVG to OM, he was advised angiography. Angiography was done through the right femoral route. Left main showed a critical stenosis in the mid segment. This is the angiogram, native vessel. Left main, heavily calcified artery, critical stenosis in the shaft, and proximal LAD stent is patent. And we have a diagonal which is showing critical stenosis at ostium with a diffuse disease, again calcified vessel, and we don't see a circumflex in the native angiography. His SVG graft to LAD is patent and free of disease, and SVG graft to PDA is free of disease. We see the leads of CRT-D. So plan was to go ahead, do an angioplasty for relief of his angina symptoms, and because the circumflex we did not see, we said that we will try to open up the circumflex But if we are not able to do that, then we'll go ahead and do an angioplasty stenting of the diagonal part, which also was supplying a large area of myocardium. So it chose the right femoral root, 7 French sheath, loaded with ticagrelor and aspirin. We planned a left menoplasty as well. So this is the 7 French EBO guide catheter, and we wired the diagonal with a BMW wire, and we tried to negotiate a wire into the totally occluded ostial LCX. The advantage I had is because I had known him for 20 years, I knew that the LCX was a very large vessel, and I had some idea where it was arising from. So I was able to negotiate a pilot 200 wire into this totally occluded LCX, open up with a first with a 1.5 millimeter balloon, then 2 millimeter balloon, 2.5 millimeter balloon, and 3 millimeter balloon. And after that, we did a cutting balloon of the circumflex ostium and of the left main as well, with a 3.5 millimeter balloon. And after that, we did an IVL 4 millimeter of left main. Then we put in a stent in the circumflex and another stent into the left main to circumflex, telescoping into the first stent. We optimized the result of the circumflex with 3.5 millimeter balloon, then we did a 4.5 millimeter balloon, 5 millimeter balloon pot, and this is the final result which we got. We decided to leave the diagonal as such. So this patient was discharged on 3rd day. He's been angina free for 4 months follow-up, and he's on good medical therapy. So to coming to the take-home message, ostial LCX CTO can be challenging, especially if there are no collaterals from other vessels. A careful study of previous angio, if available, is extremely important. Frame-by-frame study of angio and prolonged angio to see delayed frames are extremely helpful. Evaluation in different views may help in identifying where to explore. Different wires can be used, but I have found that Pilot 200 is also a very excellent wire because we can make a good curve on that. It gives a good maneuverability. The negotiation can be done much better. So Pilot 200 was used in this patient to open up the LCX CTO. Cutting balloon should almost always be used in LCX osteoplasty. IVL is useful, especially in heavily calcified lesion. And on that particular day, we had some technical issues with imaging, but imaging would have been added to this. Thank you.
Sir, one thing is whatever excellent way we do, sometimes the circumflex ostium is very prone for So do you think about just drug-eluting balloon for the ostium of circumflex without stenting?
I thought it was a very large vessel. And we have done ostial circumflex with cutting balloon and DEB. But in this particular patient, looking at his clinical profile, this vessel was very important, severe left ventricle dysfunction. I thought it's a good idea to go ahead from left main to left circumflex.
So this was done without using imaging?
This was not. On that day, we had a technical issue with imaging. Normally, we have about 85% imaging, but on that particular day, there's some issue with the machine, so we couldn't use imaging on that day.
The reason why you could not able to do the stent, any intervention to the diagonal, because you put a stent across the LAD. So you should have completed the distal lesion, then you would have done.
Yeah, I think I debated on that particular point, and it would have been it would have taken 2 minutes more.
Yes.
The problem was we have an SVG graft to LAD, and we have established flow from left main now. So if we had done a diagonal ostial stenting, I wanted the native LAD to be patent. So I did not want to put in a stent there or end up with a bifurcation stenting of the diagonal and LAD. So that's why I thought we will come maybe next time around if the symptoms persist. But he's been angina free, and this disease in the diagonal has been with him for almost many years. We had previous angio to show that.
Sir, the fact that he's suffering with severe LV dysfunction, LV of 22%, have any technician scan, viability scan was done, sir? Because it's been post CABG, for multiple stents.
No, I think if we go back in history, he had a massive interval MI. That was 2002, 2003. And at that time, he had severe LV dysfunction post MI. We've done an angioplasty, but he continued to be in heart failure for a very long period of time. And many years later, he started developing angina because of progression of disease elsewhere. So therefore, I think the LAD may be viable, may not be viable, little difficult to say at that moment. The question is that now we have opened up the left main to LED. So maybe at later stage we can complete it because this venous graft is not going to last too long.
Was there any improvement in the ECG after CRTD?
His QRS is same,
QRS.
130
It
milliseconds,
didn't,
but his
so
effort tolerance
CR
has improved significantly. He is able to walk about 4 5.
EF has not improved.
EF has not improved. EF is
Any need for any circulator support for him?
Yeah, we debated on whether Impella should be put in or not, but we decided that we could do that without that. Thank you.
We'll go to the next session, last case, Pankaj.
So this is not a case actually. Actually, I'm presenting on somebody's behalf. The original speaker is actually no. Original speaker was somebody else, and I was told to prepare this topic just one day before. And
angioplasty.
I am a locum speaker.
Half an hour is enough for you.
Thank you, sir. So actually, truly speaking, I am not expertise in this technique, and I have studied this just in one day, knuckle wire technique. Truly speaking, I have done only once or twice, but not in a true sense. I am expertise in doing it. So my presentation is a theoretical presentation, and those who are expert here, CTO experts, they can share their experiences on the knuckle wire techniques if they have done before. And I was going through some of the videos done of using it. So as we know that subintimal angioplasty has been done in peripheral intervention. I think all of us has done this subintimal angioplasty in peripheral femoral and common femoral arteries and femoral popliteal occlusions. And initially in coronaries, this technique came as a star technique done by Colombo et al. For coronary occlusions. And what we use is basically a hydrophilic wire with a J loop to create a separation in the subintimal space. So when you are not able to enter into the true lumen, we try to go through the subintima, and that is, and then again you have to come back to the true lumen by using some kind of re-entry mechanisms. So basically it is a gentle separation, and in peripheral maybe sometimes we do a vigorous, but in coronaries we cannot afford to have a very vigorous subintimal separation. We have to do very gently, and we have to use varying resistances in the different. Usually this is not a first technique to be used as a first line of therapy. It has to be sorted as one of the last option when you fail most of your techniques, and this is how you go into the subintima through the CTO. And it is one of the approaches to whenever there is an ambiguous cap and there is a long course of occlusion, that time we try to go for this, and usually it helps to CTO crossing. And but if you are not done carefully, and if you are not an experienced operator and you have not done it properly, you may complicate the procedure. So chances of worse dissections and even perforations are also possible. So usually the algorithm says that modern techniques of CTO intervention, it should be used as a last resort, and particularly this technique now in today's contemporary CTO techniques has to be done by using crossboss and stingray system, and where you can do a controlled antegrade and retrograde technique and as a part of cart or a part of reverse cart. And it helps to preserve the guide. The advantage of this is you're positioning into the subintimal space, and the distal vessel usually remains patent. Even if you do some bad dissection or something like that, you still have chance of doing a retrograde technique and you're not damaging the portion. So this is a differential resistance by creating a subintimal dissection, and you have to take a knuckle wire, and you are creating a subintimal between media and adventitia and progression into the subintimal space. So this is basically a principle of differential resistance, how this knuckle exists. And this is, you can see the below the subintima, you are creating a space there. So when to use this knuckle wire technique? So this is an advanced technique, and knuckle wire should not be primarily wiring system in most of the CTO. You should not use as a first line of therapy, and it is when angiographically when you are not having any clear-cut path, there is a convoluted and calcified long CTOs in antegrade retrograde wire escalation and retrograde approach failure, and we are planning to go for a cross-boss catheter. That point of time it is used. So these are the different kind of knuckles you can prepare. Umbrella handle, which can be used to start the knuckle. You have to give a J tube to the hydrophilic wire. Mostly you can use XTA or cyan kind of wires. They are very easy to form a knuckle, and this is basically a form knuckle, transition in the floppy and stiff part of the wire, and large knuckle should be avoided. It should be avoided for making re-entry. It becomes very challenging for that. So Fielder XT or cyan block or pilot series of wires can be used, and usually you have to use always along with the microcatheter. So the microcatheter helps to keep the knuckle, and while rotating when constructing a knuckle it prevents the knot formation, because when you are trying to push and produce a knuckle, sometimes it may become straighter. So when you are trying to, you should not rotate it. So it should be only advanced with a little gentle pressure with the support of some kind of microcatheter, over the wire support of microcatheter, which helps to keep the knuckle length and breadth when you are pushing into the. So it is a plain knuckle wire technique is very faster and is less expensive technique, but it is not totally controllable and predictable. So re-entry sometimes becomes very difficult because you create a lot of dissection and intramural hematoma. So always it is better to use with cross-boss catheter and stingray, which I am not discussing here because it is one totally different topic of CTO intervention. So I am remaining to the knuckle wire technique. Initially, the star approach was used for the knuckle wire techniques, and there are some re-entry devices were there after coming to the crossing the CTO segment and coming back to the true lumen distally into the CTO. But in modern CTO, knuckle wire is only and only used when you are planning to use a cross-boss stingray system, which is a more predictable way of re-entry. So when not to perform, that is very important. And the biggest challenge of knuckle procedure is unpredictable, and it has to be done very carefully on the case-to-base selection. And when proximal presence of good interventional collaterals and access to retrograde system is a big advantage when you are doing into the antegrade system, and it could not produce the desirable result. Ambiguous CTO entry cap, when CTO body involves significant side branch, there is a diffuse disease. Then we have a technique called retrograde knuckle, and where it shows that when antegrade wire fails, then from the retrograde you create a subintimal dissection, and which is a part of actually a reverse cart. And as you can see in the this case, this retrograde knuckle, and then it creates a subintimal space, and then antegrade wire can enter into the subintimal space, and then you can connect into the subintimal space by putting the balloon, and balloon dilates, and then it can connect between the CTO from the retrograde approach also. There are some other ways also of doing it, base technique, and another is a side base technique, where there is another called power knuckle. So you can anchor the using one balloon in just proximal to the CTO, and then when the balloon anchors, then another wire with the help of some kind of a microcatheter, you can go into the subintimal space. This gives more force to anchor the vessel, and then it is called as power knuckle. And the side branch, side base technique, where when there is a large side branch is there, you can occlude with the balloon, and then you can pass the knuckle into the CTO. So the take-home message is knuckle wire approach, when traditional or modified for control knuckle, it enhances the CTO interventions for unclear vascular course and long length occlusions. And it is the last resort when we are unable to advance through the impenetrable plaque or unclear route. And in modern CTO, it has to be done with the help of cross-boss catheter system. And a solid understanding of the CTO anatomy and subintimal space is required, and effective protection of the distal area for subintimal hemorrhage is crucial during this treatment. You should not create ischemia by closing the vessel if your dissection extends further into the distal system. And if you collaterals also gets occluded, then patient can become ischemic. So thank you very much, and if any points are there and experiences which can be shared. Yeah, please.
See, the point is, as you rightly mentioned, in knuckling, the biggest problem is...
You can come to the mic.
Sure, I'll come there. So, how are you?
I'm fine.
Yeah, we're meeting after a long time.
Yeah.
I was with Shiv Kumar. So the point is, when you're doing a knuckling, as such as a technique, if you see any good CTO operators, they don't prefer to knuckle
Yes.
it down. The reasons are two: one, you're damaging the wire, and secondly, the subintimal space, as you said rightly, the dissection can extend to any long segment. Rather than that, what you do in a reverse cart is also something similar. You create a crack in the subintimal space and then take the wire across it, which looks more sophisticated and far better a technique than knuckling as such.
Yes.
Basically, there's an American-driven technique, so they prefer it. But to be honest, if you see any Japanese operator, they are not a very big fan of knuckling. I have to be very honest with you. So I preferably do not prefer knuckling as a technique to open a CTO. Subintimal space working is very fine. Absolutely no problems with that. There are a lot of papers which have shown that working in subintimal space is not a problem.
I think reverse cart, I think when you are using ADR technique, antegrade dissection re-entry technique, using cross boss, it is a good idea to use it.
Yes.
But otherwise, as you said, we have to go in a reverse, we can put the balloon to create the space. Antegradely, you can have a balloon, and then you can go with the reverse cart.
That's what, you don't know how much you're entering into the false human and how long a stents and how many stents you're going to end up using this knuckling technique. Sometimes these type of
There is a problem
do come
is at the point of knuckling, you have to use some kind of imaging technique because there is a under expansion of the stents, and the approximation of the stent also is not proper because you have created a very big space there.
Absolutely.
So when you put the stent across the knuckled area, there is a lot of subintimal space has been created.
Yeah.
So the stent expansion will not be there.
You end up
so
losing
the
septals
stents
also.
will be hanging inside the knuckled area. So sometimes restenosis rates are very high. So you need to use IVUS or some kind of imaging technique to see whether stent is properly expanded or
And
not.
especially if you're looking at LAD, because the major supply is not by the vessel, it's by the septals. You end up losing a lot of septals also.
This is not the ideal technique to use across the major side branches.
No, yeah, it does. That's what I'm saying. Septals and major side branches. It's not a technique as such a very good technique.
If it
Damages
is
lot
side
of
branch
material.
is there, you can use side-based technique.
No. I'm telling the important
Yes.
Yeah, that subintimal space can shut
Yes,
down the
yes.
side branch.
Yeah, if there is a large branch is there, and if you create dissection, you may close the side branches.
Absolutely.
Yeah,
That's what-
absolutely.
So,
the benefit of opening the vessel if you just create a single element.
Yeah.
Short segment, okay.
so it can be something better than nothing if you don't have anything left. To push it and
Is
take
a
it out.
last resort.
Just a couple of comments. First of all of us agree that knuckle should be rarely, if ever, used. 2 points. One, it should be used only in right coronary, nowhere else, not in the left system. Second point is
Antegrade knuckle, you meant to say.
Yeah. Whatever, because it's going to knock off vessels and you will do the worst. The second point is if you've done a knuckle and open it up, leave it, come back after 6 to 8 weeks, what we call as an investment technique. There's no idea of stenting the entire subintimal space. So you would see that after remodeling, when you come back, the procedure of doing angioplasty stenting becomes very well. So it was described by Colombo, but rarely to be used, but with these 3 writers. Thank you.
Thank you.
Yeah, one more thing, last thing I would just want to put, as sir rightly said. See, I don't know how far it is to Colombo did the step starting. It is antegrade re-entry and then you're re-entering into the vessel. The part of the vessel which you're damaging in the subintimal space, I don't know how much it is prone for future aneurysmal dilatation and forming big coronary aneurysm. Because anyways, the media is being used, so you may, decrease the strengthening of the vessel per se itself. It's just an out-of-box thinking, that's for
Yeah.
sure. But I think logical.
Thank you.
So we'll close the session. It was a nice interactive session. We'll go for the next session.
Thank you. See your papers with names written on them. Thank you. Thank you, chairpersons. We now go to the third CD session, which is mostly based on imaging techniques. And I invite chairpersons Dr. G. Suryaprakash, Dr. M. Gokul Reddy, Dr. T. Madri Narayan, Dr. Rajiv Menon, Dr. Inderjeet Singh Monga. And discussants, Dr. Damodar Reddy, Dr. K. N. Ganesh, Dr. P. K. Pradhan, Dr. C. Mamta Reddy, Dr. P. N. S. Harita, Dr. Bhishma Chaudhary, and Dr. Stalin Roy. Please come to. This session will be image guided CTO PCI.
Good evening, everyone. I think in the interest of time, we'll get going. The first case is Dr. Tanuj Bhatia. He'll be talking to us about challenges of bifurcation CTO PCI image guided.
Good evening, everyone. Bifurcation PCI and CTO PCI get often coupled together in approximately 1/3 to half of the cases, with the bifurcation in 1/3 of the portion in proximal cap, distal cap, or the body. And more so than any other case, the side branch risk is more because of dissections, hematoma, and the plaque overload. So my case is a 53-year-old overweight individual, a history of inferior wall MI and PTCA to RCA around 4 years back. He had started having angina 2 years back and documented CAG 6 months back that documented a LAD CTO. The blood pressure was normal. He was recently diagnosed as diabetic. He was dyslipidemic. At this admission, his troponin was negative and the eGFR was 74. This is the baseline angiogram. The stent in the right coronary artery is patent, but there is severe disease proximal to the stent that was placed earlier. The left circumflex also has disease at the bifurcation into OM and the distal circumflex continuing as OM2. And there is an osteal LAD CTO that is at least 6 months old. And the distal LAD as well as the diagonal is filling from the collaterals, both from the right coronary artery as well as the left circumflex. So we started with an antegrade approach. The stump was it was a tapered stump, so I was pretty sure that we'll be able to use a microcatheter support, and with the help of a Fielder XT wire, we might be able to penetrate through the total occlusion. And if you appreciate the distal landing portion of our stent would be slightly distal to the LAD diagonal bifurcation, and the diagonal itself has a critical disease, and there is a quite a severe angulation just distal to that bifurcation also. So in the middle figure you can see my guide wire, my guide catheter is buckling back when I'm trying to advance the wire towards the LAD, and the last angiogram shows that I'm pretty outside the vessel architecture right at the level of bifurcation. So at this point I paused. I realized that there was a significant dissection, maybe progressing to a intramural hematoma at the site where there was a very severe angulation. But where did I start going into that plane? So I hesitated from using a dual lumen microcatheter at this point of time. Angulated was not available. And after a few more attempts, my attempt was to at least reach one true lumen. So we were able to enter the diagonal after a few attempts. And this is the when I could advance the micro and enter the diagonal in the true lumen. So in such cases, there are various options, maybe moving to a retrograde axis at this point of time, use of a dual lumen or a venture catheter, but we or use a different wire or reshape the tip of the wire. So we did a IVUS pullback to see where the problem was. In most of the places, the wire was in true lumen, except just at the level of the bifurcation, just proximal and distal, it was hardly 2 to 3 millimeters of portion where it was going subintimal extra plaque. And at this point of time, there was one option of preserving the side branch and then try to rewire the main branch, but I felt that the dissection was very small, so I preferred not to lose the main branch. I just came proximal to that small 2 to 3 millimeter segment, de-escalated my wire, which was a Fielder XT till that time, converted into a cyan blue because I had already crossed the CTO segment, and redirected it towards the LED. And we were successful. So besides the plaque shift and Kirina shift that we classically explain for progression of a lesion in a side branch, there are additional parameters in C2 PCI that includes a subintimal shift or the dissection flap that may extend, or an intramural hematoma that may compromise the other branch. Once this was done, now my focus shifted about the risk of side branch occlusion or dissection, because the maneuvering of wire toward the side branch was still difficult. So in any case, we had to prepare the bed in the proximal main branch. In CTO PCI, the repercussions of side branch occlusion are more limited than in conventional PCI because of a lot of ischemic preconditioning. Like in our case also, the diagonal was filling with collaterals, both from LCX as well as the RCA. But over the long term, and once I do PCI towards the LED, this intimal flap may hamper the side branch wiring and occlude it irreversibly. In any case, we proceeded. We did a proximal LED bed preparation with the 3 millimeters NC balloon. And at this point of time, if you see, there is a very poor flow towards diagonal, and there is a dissection which is still visible. But after pre-dilatation of the proximal LED, there is good improvement towards the diagonal as well. With the IVUS guided measurements, we deployed the first stent proximal to this whole place where this fiasco was happening, and it was landing proximal to the bifurcation. A Zeiss Sierra 3.5 into 33 was deployed right from the ostia. Thereafter, the bifurcation PCI started. Wiring did not give much trouble this time. Side branch bed was prepared, pre-dilated with a 2.5 mm NC balloon. I used a mini crush technique, DES 2.75 into 22 deployed into diagonal, crushed with a 3 into 12 mm NC balloon into the LED. Under prepared towards the diagonal ostia, so used slightly higher pressures. A DES 3 into 26 deployed into the LED. Followed by the first pot proximal to this, 3.5 mm balloon. Rewiring through the distal strut, the side branch strut's dilatation. 2 mm failed initially, started from 1.5 again, and 2 mm balloon. Sequential kissing balloon dilatation. There was slight under expansion towards the diagonal ostia, so did it with slightly higher pressures. And this is the final kissing balloon inflammation videos and the final pot. So thereafter we optimized the ostia with slightly higher pressures and higher segment balloon. This is the final result. There is some disease distal to the LED stent, but we've left it on medical follow-up as we'll be covering the subsequent lesions in the future. So in conclusion, bifurcation PCI may affect, in CTO cases may be encountered in approximately 50% of the cases. IVUS, especially in case of subintimal tracking, gives a good idea about the side branch wiring or the main branch wiring in this case. And in certain cases, dual lumen microcatheters may play a very important role. But if we do not know the site where, or if we know by the IVUS where the site is, we may use a judicious use of these microcatheters. And though provisional stenting may work in most of the cases, in such cases where there is a dissected segment, a two-stent strategy may be the way to go. Thank you very much.
Any comments from the discussants? Anyone is there from the discussion side? I just start off if a very good presentation and excellent result for such a complex case. You had a wire in the diagonal. You didn't think of a double lumen catheter there to go into the
yes,
LED.
Sir.
That would have simplified everything.
Yes, sir. Sir, I thought of a dual lumen microcatheter, but the first point was even a fine cross was not advancing very easily and comfortably through that dissected segment. And I was in a suspicion that just in case, if my dual lumen microcatheter is also going through a subintimal flap towards, then I might irreversibly occlude my main branch as well. So had this been about the story of for a diagonal through a LED, I would have preferred a dual lumen. Means that's my thought during the case. I thought if my wire was in the true lumen in the LED, then I would have played with the dual lumen towards the diagonal. But since it was the diagonal which was being wired, that's why I chose. And then once I saw the IVUS and that segment was only 3 millimeters, I thought in retrospect, I could have downgraded my wire just the moment I crossed the CTO. But since in usual cases, what we do is we reach the distal segment, place our microcatheter, and then we change our wire. So that was one learning point for me, that I, in such cases, appreciating that angulation a bit more earlier and use of downgrading my wire would have, de-escalation of my wire could have helped a bit earlier.
Nice case, small few 2 or 3 points. So whenever probably the wire has entered a subintimal place, rather than removing the wire, we can go for a parallel wire technique that makes the job more easier.
Yes.
And then if at all, if we don't have the availability of IVUS, etc., and the wire has passed into the diagonal, a deflection balloon technique can very well be used by occluding the ostium of the diagonal with a small balloon, and the wire tracks into the LED. And final, I think there is a short left main, and LM LED could have been equally option, or a wire in LCX probably nails the ostium more better, or you can we can very well use IVUS to appropriately see the ostia.
Yes, sir. So we saw the IVUS image of the ostial LED. The distal left main was not at all diseased. So that's why. And second point was use of a deflection balloon. I hesitated because there was a very strong angulation in the lesion itself. So fear of occluding the LED irreversibly because it was the main branch. That's why.
I think presented well, and ultimately we had a good result despite the technical problems initially. Because of time, I think we'll go to the next presenter.
Thank you.
Raghav Sharma, IVUS guided penetration of ostial LED CTO.
Very good evening to all of you, and well, it was one of a very interesting case where I was also stuck initially thinking it's just a simple 99% lesion of LED. So this was a 60-year-old gentleman, hypertension smoker, presenting with ST depression in V1 to V6 with ejection fraction of 40%. Other lab parameters were unremarkable. He was taken up for an elective coronary angiogram. So this was his angiography. There was a tight lesion in LCX, looks like acute, and looked like a 99% lesion in the ostial LED. So took another shot. Sorry for that view. So I just not going to go into details. I stunted the circ first and decided to proceed with LED in the same setting. His RCA was also diseased, so I decided to make it two vessels to be revascularized in one setting and proceed with the next after 2 months' time. So this was LED actually, when I saw, looked like very tortuous vessel, and I was totally confused what exactly I'm dealing with. If I see it in another view, so this was how the LED looked like, though it looks like a very small caliber vessel, and I was absolutely confused. Okay, so I tried with the filter and subsequently failed. I thought I could try with that, but that channel was very tortuous and I was not able to understand what exactly I'm dealing with. But looking at the anatomy and the way the channel was, I thought it doesn't look like a typical origin of an LAD. An LAD looks like 100% occluded because if you see, it is filling LAD just distal to a small bud there, we can see if you see retrogradely there. So considering it, I decided to proceed with IVUS and relocate whether I am exactly looking at the ostia of the LAD or is it something else. So I decided to keep a IVUS catheter in the LCX. This is a volcano catheter, and this is a IVUS pullback. And I took some small disease in the small branch of the circ, and so it'll take a little time. And as I pulled, it's a manual pullback, and as I was taking a pullback, and this is the circ which I can see, and slowly I was pulling it back. So this is, as I can see, the ostium of the LAD. So this was how it looked like. Now the IVUS is in left main, you can see LCX and you can see the LAD. So what exactly it was a collateral from the left main which was filling the LAD. Actually, that is what it was. So keeping it IVUS there, we decided to proceed. This is Miracle 6 now I'm using, and we decided to go ahead with this. And once I crossed the wire, I reconfirmed it with the IVUS, and you can see that dot there in the IVUS pullback. The wire is in the true lumen. It has penetrated the LAD beautifully. So after parking the wire distally, so this is the wire now I've parked distally. The balloon dilatations was done. Sorry. So this is now the LAD, we can see. So I placed 2 stents in LAD. One was 2.75 and second was 2.5, and post dilated with 3 at the overlap segment and distally with the 2.75. So this is the final result that I have got. So a little bit of slow flow was there. Patient was kept on NTG and Nicora, and because of poor ejection fraction and prolonged procedure, he was going in failure. So I did not take a pullback with IVUS. So this was the final result, what I have got in this patient. So far, this was a case I have done, I think 2-3 years back. He has been under regular follow-up and doing absolutely fine on regular medications, now on de-escalation therapy also. So I preferably feel that sometimes imaging does play a crucial role in identifying the correct anatomy, because otherwise I would have been kept on trying in that septal and ultimately ended up in perforation and patient could have collapsed. Thank you very much for your patience.
Very nice case, Dr. You managed very well. I just wanted to ask whether ostium of LAD is adequately covered, or should we come to left main for the stenting?
No, actually, that's what I'm saying. I have kept one strut in left main because of the angle of the LAD ostium, but then I should have done an IVUS. I could not do. Patient went into failure. Already EF was low. So I would have checked it. So far, he's doing fine, so I presumed it. But ideally, as you're saying, I should have done a IVUS run and could have confirmed it for sure. I could not do the final run of IVUS. Patient was unstable. Yeah, sorry.
Yeah, great case, Dr. Raghav Sharma. I think one thing which is beautifully demonstrated in your case is the elaeocranial, where you can see the bridging collateral. Almost all the other views, you might mistake it for the LAD, but the elaeocranial, you can see that it's not at all in line with the LAD and it's a bridging collateral. I think that suspicion helped in totally changing the strategy.
The way it was doesn't looks like an origin of.
It can be a disastrous consequence if you go through
Absolutely. You could have ruptured the entire thing.
Yes.
Sure.
Anyway, great case.
Thank you very much. Sure.
Collaterals from left main to LAD, I'm not sure. I have not seen many, but this collateral looks a little bigger, like a diagonal size, or almost 50% of the LAD size. Is it true in the practice that left main giving collaterals to LAD or circumflex? In other instances, we get bigger collaterals? Any?
Sir, to be honest, even actually the same thing came in my mind. I think Bali sir is also there. We haven't seen much left main supplying collaterals to LAD like this, to be very frank. Usually either it will be filling from the right injection or from the circ itself via the collateral. So pretty surprising thing. The only suspicion which came in our mind was the way it was tortuous. It is like a 360-degree turn and then it is filling the vessel. So that is why we decided to go imaging guided rather than venturing out in it and unnecessarily rupturing it and creating a problem. Because we haven't seen the origin of a LED going a turn like that. Sir, what is your experience in that?
I think the point is very well being made. Allocranial shows it so beautifully that there is no other alternative than it's a collateral. And they can arise from anywhere. So I think left main can give a collateral rare, but you do so see once in a while coming up. And the character is so beautifully demonstrated that I think it's a collateral.
Can I just one point? Actually, if you see the left main pullback which he's taking, you don't see a stump. It is basically a small opening. So that means there is a tapered tip present there, which we are not able to appreciate angiographically because of the angulation. So that's why he has entered that tapered tip, and that's why miracle went easily. So it was not an ostial flush stump. There was some tapered tip, and that he entered there.
Very important point again made, because when it is IVAS guided for a CTO with a complete flush occlusion, this is not how you see. Here you are able to see the vessel. It's not occlusion where you are trying to look at the true lumen.
You see a stump with a 3-layer structure. So it's like a tapered tip that most likely would
Then
happen.
that hyperlucency in the center, that's the place where you would want it.
Taking the same point, what is happening is probably the collateral is so large that although there is not a flush cutoff of LED, it's not filling. It's a functional occlusion. So that's what is probably happening.
That's why it went in very easily. Go on to the next case. Thanks, Dr. Raghav. We'll go on to the next case, Dr. Karthik Natarajan. Challenging case of image-guided tortuous RCA CTO PCR.
Good evening to all. I'd like to thank the organizers of ijcto. So I'll be presenting a case of a tortuous RCA CTO. So my patient is a 72-year-old female. She has hypertension, dyslipidemia, and hypothyroidism. She was diagnosed and treated as ischemic cardiomyopathy with moderate LV dysfunction for more than 5 years. Her current complaints are angina and dyspnea on exertion. ECG showed Q waves in late 2-3 AVF, which an echo showing an ejection fraction of 35%, hypokinesia with preserved wall thickness in the RCA territory, and a stress MPI showed a large reversible perfusion defect in the RCA territory. So this is the angiogram. So the you can see the ariocaudal view that there is some mild disease in the circumflex. There's an OM which is possibly occluded, but it's a very small caliber vessel. The LAD is normal. There's some disease in the diagonal, and you can see that there are good collaterals to the RCA. The RCA is totally occluded. And this view, you can also appreciate that there are septal collaterals, and the last septal is also giving collaterals, but there seems to be somewhat of an epicardial course in that septal collateral also. The aleocaudal view. And this was the view of the RCA. So there's a mid RCA total occlusion. So on the angiogram, you can appreciate that there is some calcification also on the mid RCA. When we took bilateral injection, which I'll show you, there was some bending or tortuosity which could appreciate within the CTO segment. So the target vessel is the RCA with a GCTO of 3. The lesion length was just more than 20 millimeters with calcification and tortuosity within the CTO segment, which is more apparent on the bilateral injections. The axis was a right radial 7 French EBU and a right femoral 7 French JR. The strategy was initial antegrade wire escalation and retrograde via septal collaterals and antegrade dissection and re-entry as the last resort. So these are the bilateral injections. So you can see that it's a very large RCA. We put a safety wire down the LAD. The LAO view. So there's definitely some bend or tortuosity within the CTO segment and calcification. So we started off with a Caravel microcatheter and a Pilot 50 wire. We tried negotiating the wire through the CTO segment. We were able to reach the distal part of the CTO, but the retrograde injection showed that we were somewhere in the extra plaque space. So now the RCA, the JR guiding, which was not probably a great choice, we were getting very poor support. So we put in a guide extension. and you can see that the wire is truly subintimal. It's subintimal. It's not. It's extra plaque. It's not there. So we decided to do parallel wiring. Now this is a pilot 200, and we attempted parallel wiring, but somehow we could not. The wire would not proceed further ahead. So now we tried, but the anti-grid attempts were not working. So we decided to switch to retrograde. Now you can see that there are collaterals, and we again used a Caravel microcatheter, and we could see that there are some collaterals which appear to connect. So we tried multiple guide wires, and we tried to enter all of these branches, but none of the branches actually truly connected, or we could not enter the distal RC with any of these branches. So our retrograde attempts were failing. So you can see that we have tried all the 3 branches, but none of the branches actually was connecting, or we could not enter the distal part of this. And this another septal was not connecting. So we again switched to anti-grade. Now we again used the pilot 200, and this time with microcatheter support, we were able to do parallel wiring and enter the distal RCA. I'll show you the Now we confirmed the position of the wire in the LAO. We felt that the wire was in a small branch. We just adjusted the wire, and we could now see that the wire has entered the PDA. Now we tried to pass a balloon down the RCA, but even with guide extension support, the smallest balloon which we had was a 1 millimeter balloon, would not cross the CTO segment. So we thought that we'll do an anchor balloon, but there was a very tortuous conal branch. We could not get a wire down the conal branch. So what we did was, we again went back to the guide extension and deep throated the guide. So this guide, as well as the guide extension, was almost close to the occlusion. And finally, we could get this 1 millimeter balloon down with the support of both the guide and the guide extension. We dilated with a 2 millimeter balloon and did an IVUS. So this was the IVUS findings. The distal reference was around 2.5. These are the images from the RCA. Actually, at the point where the occlusion had been there, there was a possible nodule. So we pre-dilated with a 3 millimeter cutting balloon, NC, and then a cutting balloon, and then placed stents. We confirmed the integrity of the left system. We placed a 3O stent from the mid to distal RCA and overlapped it with a 3.5 millimeter stent. And then if you see this injection, you can see that there's disease in the distal RCA, and there is some still collateral filling from the left side. So we decided to fix the distal lesion into the PDA also with a 2.5 to 38 millimeter stent. And then we did an IVUS, and then optimized it with the 3.5 and 4 millimeter balloon. And these are the images, the final images. We could get good areas. Opposite the nodule, the area was around 7 millimeters, and the mid RC was 9, and the proximal RC was around 12 millimeters square. This was the optimization, and this is the final view. So the take-home message is that familiarity with the hybrid CTO algorithm can increase the success of CTO PCI. Parallel wiring remains a time-tested strategy in anti-grid wire escalation success. Guide extension catheters are essential in balloon uncrossable lesions, and imaging helps in post-PCI optimization. Thank you.
Excellent case again, Dr. Karthik. A few comments from my side. One, I think once we have got the guide extension, most of the other techniques of anchoring and all, we have almost forgotten, because you had a guideliner in place.
So in this case, when I initially tried with the guide extension was just at the level of the occlusion. That also didn't work. So when it was not working, so I decided to remove it and try balloon anchor, which had worked in some other cases. But since it was a tortuous conus branch, so that would not go. And then what we decided was we deep throated the guide as well as the guide extension close to the occlusion, and that actually helped, because with the guide extension alone, initially the balloon could not be passed.
Almost like a power guide.
Yes, sir.
The other issue was, why do you think initially the parallel wire didn't work and the second time the parallel wire worked?
Actually, sir, the initial attempts, the wire got stuck. There was probably the reason was that in the first time the pilot T100 did not gauze, even the proximal cap did not seem to be progressing further. So at that time we felt that if there were retrograde options, we would explore it and then come back again to the parallel wiring if the retrograde options are not there. We felt that there were good septal collaterals. So we were a little, before trying parallel wiring for a long time, we thought that we'll explore the retrograde option, come back to the parallel wiring if there were retrograde options would have failed.
Okay, I'll give you my thought process. I'm not sure
sir.
if I'm right or wrong. Second time when you wired, you could see that there was a small knuckle when you went in. And initial injections, if you see, it looked like though there was a CTO, there were also some channels which were there.
Yes, sir.
So whether it was some spontaneous dissection or something initially to start with, which later got converted into a CTO.
Yes,
so most likely initially when you went in, you were not able to catch the proper channel.
Yes, sir.
But second time the knuckle might have just helped you in slipping into that place.
Yes, sir.
Because after that, when you straightened the wire and pushed, it just went in quite easily.
Yes, sir.
So most likely that might have been the mechanism by second time the parallel wire worked.
Just only one small thing. Why is JR guiding was chosen for a CTO initially, and you should have avoided, suppose if you take AL1, the guideline or extension, all those things could have been saved.
Yeah, that is one great, sir.
Yeah, great case. The distal caps, as rightly pointed, the wire passed very easily. Probably there might have been a micro channel. So filter XTY or XTA so would help probably a better way to track the channels. And rightly pointed out, AL1 definitely, AL guide will help us and make our job more easier. So even the balloon crosses more easily.
I just wanted to ask one. So when you planned this case, did you do it ad hoc or you planned it and did it?
No, we planned it and did it.
Did you see the collaterals from the left system?
No, we saw the collateral from the left
Do you think
system.
they were very tortuous and it is not easy to cross the wire? And I think anti-grade would have been still a better option. If you see
No,
those,
so we obviously had the anti-grade as an option. The anti-grade is always an option when the retrograde isn't
looking
working.
at those collaterals, I felt that was the only option you had.
So, the third septal collateral was very tortuous and definitely was having a part, there was an epicardial course to it. The first and second septal were having some collaterals, so we felt that if we could surf and reach the distal RC, retrograde would have been a possibility.
Because as he has rightly mentioned, there was a channel there, and if you see the retrograde filling, that channel was almost being filled retrogradely. So you had a path to cover that rather than creating a dissection. So that is what we were looking into. Actually.
Yeah, so see, anti-grade is always an option, and we always go back to it because that is the thing which we've been practicing for years. Retrograde was something where, in this case, we wanted to see whether retrograde was a possibility. The parallel wiring was always going to be an option it had to be done. Parallel wire could have been done
if
anytime.
Dr. Karthik didn't know how to do retrograde, probably he would have anyway crossed antigrade in some time.
Absolutely, I do agree. No, it's become a fashion nowadays.
Thank you, Dr.
Okay,
Karthik.
thank you, sir.
Wonderful case, yeah. We'll move on to Dr. Preeti Sharma. She'll be telling us about tackling LAD CTO rota cut with IVAS guidance.
Thank you, everyone. And in my disclosures, I did this case as for a fellowship program. So this was done at other center earlier, 42-year-old male who was hypertensive and presented at the primary center with a history of chest pain for 2 to 3 hours. And ECG that time showed ST depression in precordial leads and was diagnosed as posterior wall MI. EF showed EF of 50%. So this was his angiogram in the first go. LCX distal 100% thrombus containing lesion. Left main is fine and LAD proximal looks like a CTO, which we see in the other view. So at the primary, at the time, the primary PTCA to LCX was done, and the lesion in the LCX was fixed with a 3.5 23 millimeter DES. And then we took this patient for a CTO PCI, and this was the RCA. RCA was giving, there was septal collaterals from PDA and there were epicardial collaterals from conus branch. So the day one, we fixed his RCA with a 428 DES. And then the next day we took this patient, so this was the ECG post PTCA, and the next day we took him for LAD CTO PCI. So this is the LAD CTO as we can see. So this is a tapered segment, but looked like there is a calcification on fluoroscopy. And this is a long, approximately 20 millimeter occlusion, so a JCTO score of 2. We planned this procedure because it was a tapered segment as an antegrade approach. And because we could see some calcification there, we went ahead with a Corsair microcatheter with initially. So we had taken 2 axes, one radial, one femoral, 6F guide in the RCA with a wire cap there as a protection wire. EBU 3.5 didn't give much support, so we had kept a wire in the LCX, which was stented earlier. And this is the retrograde, this is the dual injection, we can see. Now we can see that there is some angulation in the CTO segment, as we can make out, and there is a diagonal branch which is coming from the distal cap. So we took a Corsair microcatheter with the Xion blue. We took this catheter to the proximal cap, and then we took a polymer jacketed soft tapered wire, fighter wire. And with the 5 to 6 minutes of surfing, we could actually cross this, the proximal cap. So we can see the wire, it moves now in the branch, and then we can see in this angulation, it moves forward. Then as a protocol, we checked from the retrograde approach, and then we could see that the wire is in the lumen, and then we progressed it further while we were taking retrograde injection. So at this point, my fighter wire was in the distal LAD, but we could not cross our Corsair catheter into the distal LADs. And now we are at the point where the microcatheter is not crossing. You have 2 options: either take help of guide extension, or you can increase support by using an anchor balloon. We had a stent in LCX, so we used anchor balloon. A 3O balloon was inflated. And as you can see, then the Corsair could cross into the distal LAD. Now, at this point, now the time we wanted to check with imaging, how is the LAD? So this is the IVUS. I asked them, so this, to my surprise, IVUS could not cross past the mid lesion, and we could see that there was a ring-like calcification in the mid LAD. As we come further, we could see that there is some fibrotic disease in the proximal segment, as we see now. And again, there is a calcified segment into the proximal LAD with a narrow lumen. So at this point where your microcatheter could cross, but your imaging catheter is not crossing, and with this 360-degree calcium in the proximal as well as in the mid segment, we thought now is the time that we should actually modify this plaque. So then we did, so we took a rota 1.5 burr, and then the rota ablation was done, and the proximal segment was easy, but it took some time to cross this mid lesion where we could see nearly 360-degree calcification. And after 4 or 5 passes, as you can see, there was some difficulty in the mid segment, and then it could cross. Post-rota ablation, now in my practice, I started looking at post-rota. Initially, I was happy dilating a balloon there and getting away. But now, after learning and seeing the complications you can create, so we normally check post-rota IVUS, and we can cross on the distal segment, and this is the segment where you see some disease. And obviously, you don't expect that 1.5 burr is going to cause much plaque preparation in this lesion, but you are happy when you see some nice cuts. And more important here is to see whether you have created any big dissection or any complication, so that you are in the next step, you can just take information for that IVUS. So there's a cut you can see in the proximal segment we could also see, but in the mid panel you see that still there is a lumen which is 2.7, and this is a calcification there. There is some slicing of the calcium. So to further modify this lesion, it's a good idea to use a cutting balloon. Now this is a Wolverine cutting balloon 310. We dilated it into the proximal and mid segments. And then we did stenting with a 27528 in the distal and a 3524 in the proximal LAD. Though we know that the reference in the proximal LAD was 4.0, so then this was a 3.5 stent. And then we post-dilated it with a 3.5 12 balloon at 18 atmosphere. In the distal LED, there was some spasm, so the flow was not that optimal. After some nitro and all, we could achieve a good flow in the distal segment. And now we checked our result with the IVUS, with the help of IVUS. So this is the IVUS, we can see the distal segment. And mind you, after doing so much of crack preparation, our distal LED stand, the MSA at the distal edge was 5.05. In the mid segment where the ring was, it was 5.85. The proximal LED, we had a good expansion of the stent with the MSA of 8.74, which needed actually for some further work. So we again went ahead and post-dilated with the 4O balloon. So this is the proximal LED IVUS. We can see a good expansion, but you can see that as you approach the proximal LED, there you think that at some point you might use a bigger balloon to oppose it better, keeping in mind that you are tackling the CTO. So my take-home message from this case is that procedure planning is the key to success. And in these kind of patients, once you are doing 2 procedures 24 hours apart, you really have to be careful about the radiation dose as well as the amount of contrast you are using in these patients. And while you are selecting a CTO PCI, you have to be mindful for the age of the patient, LV dysfunction, renal dysfunction, or contrast-induced nephropathy risk. And increasing support, as we have seen in this case with a balloon anchor or a guide extension, can provide support to facilitate microcatheter passage in these kind of situations. And mind you, in this procedure, we only use 35 ml of contrast. During ROTA, anywhere, there was no need to give dye because we were checking our results with the help of IVUS. So IVUS-guided PCI, it reduces the amount of contrast with favorable short and long-term outcomes because you can optimize your stents. And in a calcified lesion, ROTA cut is a noble strategy in severely calcified lesions. Thank you.
Thank you, Dr. Sharma. I think any comments from anyone? I think it's a very optimally done angioplasty. So, anyone has any comments or any issues?
Excellent case as always. One point, if you look at the retrograde filling of LED and the subsequent final result you have got and the IVUS finding, is the mid portion of the LED intramyocardial?
It looks like, sir, because initially there was, even we were worried after doing so much of good work, there was some slow flow in the distal segment. So looks like, or there was some disease in the mid segment also. Maybe it will grow, as we all know in CTO PCI, you see that they remodel better after a certain time. So that was the thinking, but we got a good flow.
It is a good point. It looks like a long segment intramyocardial bridge. So as you said, like initially you said maybe spasm or so that looks aggravated the stenotic area.
Great case, no great results, no option if at all. If there is a very uncrossable lesion other than ROTA, however, a microcatheter passed here. Reverberations may be an indication of plaque modification, and IVUS, some people may agree, some people will argue against it. Yeah, great results.
Thank you.
We'll move on to the next case. Dr. Sahil Mahajan. He'll be talking to us about IVUS-guided RCA CTO PCI with bifurcation at distal cap and balloon uncrossable lesion.
Good evening, everyone. I'll be presenting my case of IVUS-guided PCI of a CTO with bifurcation at distal cap and balloon uncrossable lesion. And I will briefly touch upon CTO with bifurcation at distal cap. So if we see at the incidence of bifurcation in CTOs, it's quite variable. And in this table, we can see from the different CTO series that it ranged from 26% to 47%. And overall, on an average, we can say that bifurcations with relevant side branches, they occupy about 1/3 of patients undergoing CTO PCI. So the region of side branch, it can be at the proximal cap, it can be at in the body of the CTO, it can be at the distal cap. Starting with my case, he was a 57-year-old male with a history of systemic hypertension and past history of PTCA2 LED and left circumflex turn. He presented to us with angina of 1 year duration. Physical exam was unremarkable. ECG showed Q waves in the inferior leads, and echo showed a regional wall motion abnormality with ejection fraction of 35%. This was the baseline angiogram of the patient with a dual injection, and we can see that it's a distal RCA is the CTO, and the length of the CTO is approximately 20 to 25 mm, and we can see there is some calcification present in the CTO segment. There was a bifurcation at the distal cap and with two important side branches, and there was no previous attempt on this CTO, and we could see a good septal collaterals here. So our plan was to attempt antegrade wire escalation first, and if we fail, to switch to retrograde via septal collaterals, and last resort was ADR in view of major side branches. So we took a 7 French femoral access and with a 7 French JR guiding catheter, and we've initially wired with a Fielder XTA wire with Caravel microcatheter support. And once we took a retrograde injection, we saw that we were not into the true lumen. So at this point, we thought we'll switch to a parallel wiring technique, and we took a Gaia second wire and with a Corsair microcatheter support. And this time we were lucky enough to enter into the true lumen. Our next attempts to take even a small 1 into 5 mm balloon across the CTO segments were not successful. So our JR guiding catheter was not giving us a good support. So we thought we'll take a guide extension support. But we saw that our RCA proximal to mid was diffusely diseased. So we thought we'll prepare the proximal bed first, and we dilated the proximal mid RCA. After that, we were able to deliver our guide extension catheter till the distal RCA. And after that, the crossing of the small balloon was easy, and we dilated with 1 into 5 mm followed by 1.5 into 15 mm balloon. After that, we took a IVUS run. This is a IVUS pullback from the RPDA to the distal RCA. And here we can see that our wire is in the true lumen in the posterior descending artery, and proximally we are coming towards the crux. Here we can see that our RPLB is from the true lumen and our wire is in the true lumen at the level of crux. But as we come more proximally, we could see a collapsed true lumen at around 4 o'clock position, which is pulsating. And more proximally, it's still in the extra plaque space. As we pull back further, we will come into the true lumen more proximally. So after confirming that we are at the level of crux, we are in the true lumen, we were happy enough, and we tried wiring. We didn't try a dual lumen microcatheter here, but we just passed a regular workhorse wire, and we were lucky enough that it went into the RPLB. After that, we stented the RPLB into distal RCA with a 2.75 into 38 mm everolimus eluting stent. Followed that, we stented the mid-distal RCA with everolimus 3 into 38 mm stent. Osteoproximally, we marked the osteo of the RCA with the help of IVUS, and after that, we stented the osteoproximal RCA with a 3 into 32 mm stent. We flared the stent with the same stent balloon. And after that, we took a IVUS, distal IVUS. Right now, it's not available in this, but this is a proximal, osteoproximal IVUS, which showed a good stent expansion. And we just wanted to show that whether we have nailed the ostium or not. And in this pullback, we'll see that we were able to cover the ostia of the RCA well with only 1 or 2 studs protruding into the aorta. So this was our final run. So how to approach CTOs with bifurcation at distal cap? According to the recent global CTO crossing algorithm, which includes 10 steps, the 4th step tells us the approach to poor distal vessel quality or bifurcation at distal cap. There are 3 points which it enumerates. The first is the retrograde approach may be a safer and more efficient for the operators who are experienced in this technique. The dual lumen microcatheter is recommended to advance a guide wire into the side branch. And if the CTO crossing of the guide wire is not clear, we should always take a IVUS, especially at the level of crux, before placing a stent. If we look at all the different CTO crossing algorithms, all say that we should try initially a retrograde in case of poor distal vessel or a bifurcation at distal cap. But suppose we don't have any good intervention collaterals, then what should we do? So if we have a bifurcation at distal cap and we don't have good interventional collaterals, then antegrade wire escalation should be the approach. And if it fails, we should go to a parallel wire technique. And if it also fails, then the last resort should be ADR. And after that, we can use a stingray-based re-entry or a wire-based re-entry. And if it fails, we should keep it as an investment procedure. How to avoid side branch occlusion? So we should look into the mechanisms of side branch occlusion in CTOs, which are plaque shift, carinal shift, subintimal shift, dissection flap, and IMH. And the key precautions which we can take is we should wire a major side branch, and we should always try to use dual lumen microcatheters. And IVUS is very essential, especially at the level of bifurcation anatomy, to fight the side branch as well as anticipate or detect a potential subintimal shift. And in case of successful antegrade wiring, but if you are not able to wire the other branch antegradely, we should always try wiring the other branch retrogradely. And how to approach the side branch stenting? We should keep it simple, and simple bifurcation rule applies here also. Provisional stenting is the way to go. And there are two scenarios in which we should go for upfront dual stent strategy, which one is the difficult side branch access, and the other is the severity and the length of the lesion is long in both the vessels. So take home message with the CTO at a distal cap, the IVUS is essential, especially at the level of bifurcation. We should use dual lumen microcatheters or angulated microcatheters for wiring the side branch, and we should keep it simple, and we should keep it a provisional stenting. Thank you.
Yeah, thank you, Dr. Sahil. Good case. I thought the first dual injection which you took, there was some evidence of microchannel from the antegrade to retrograde, probably, but the initial wire, it didn't go into that, it went somewhere else. And after that, the problem started. And as you mentioned again, you were lucky that the other wire went into the true lumen, but again, always safe that you use a dual lumen catheter. That would have, that is a like 100% guarantee that you are not going into the dissection plane. Any comments from the forum? Okay, thanks then. I think in the interest of time, we'll move on. The last case for today is Dr. Rupali Khanna, and she'll be talking to us about investment procedure.
So this will be a talk on investment procedure for CTO PCI, and I will discuss the steps and why this technique or etiology is needed. So we all know the challenges for CTO intervention. Most common reason for CTO failure is uncrossing of the wire. And the most common reason for uncrossing of the wire, either we are able to fail to address the proximal cap, or we are inevitably entering the subintimal passage. Like if you see the past 2-3 cases, it was the subintimal passage, you have to change to parallel wire technique or something. So different algorithms have been there, and if you see the recent Euro CTO Club algorithm, they mention that if your wire is a subintimal, or you are not able to go into the true lumen, go for the investment procedure. So what is investment procedure? We will just discuss, and what are the different terminology which has been proposed according to it. Similarly, hybrid algorithm in Brilakis came in 2019 that hybrid algorithm 2.0, that if you are able to not to cross, it's always better to, they say, subintimal plaque modification rather than saying the investment procedure, that is SPM. So if you are not able to cross, do an SPM, because that will increase the chances of revascularization the CTO in the second attempt. So basic thing is, if your antegrade wire is subintimal, there are no good retrograde collaterals, and you want to do something, either you can do a parallel wire or you can do an ADR. If both the things fails, then you can go ahead with, rather leaving the case like this, you can do an investment procedure, that is a POBA or a deferred stenting. But there is confusion, it's investment procedure or a subintimal plaque modification. The concept is, if the case is failed, you are not able to enter the distal lumen, and you have to do some subintimal plaque modification so that you restore the antegrade flow, so that in subsequent recanalization, your success rate increases. And in this, basically, you first prepare the vessel investment procedure, and once the dissection part heals, after 8 to 12 weeks, you can go ahead with the stenting in these cases. Different terminology, but in 2021, the ARC consensus documentation came that we should not call them investment procedure or SPM. It should be called as CTO modification procedure, because it was different terminology. They said it is basically intentionally we are modifying the CTO plaque by a balloon size more than 2 millimeter. That means it will help us in the second procedure, you can able to revascularize it. So it is known as a modification procedure rather saying the investment procedure. Different hypotheses have been made. Either you are proximally you are entering into the subintimal plaque, you can increase the channel, or in the distally you are entering the subintimal plaque, you can increase the channels, and thus puncturing and making different fenestration, you can come between intra-plaque and extra-plaque channels. So why this concept of investment procedures needed? If we see the subintimal tracking, it started with the STAR technique in 2005 by Antonio Colombio. But the problem was this technique was there was an increased risk of side branch loss and long lesions and increased restenosis. So different terminology came up with traditional STAR, mini STAR, contrast guided STAR, or a LAST. And these are the different methodology. I will not go into detail, but these are basically you have to decrease the subintimal track so that as early as you can able to distal lumen, you can have a small subintimal plaque modification. But if you see what are the outcomes of it, if you put a stent in these cases, the Colombo et al. Documented that 52% of these cases undergo restenosis at 6 months of follow-up. And similarly, the Cardano documented if you go to contrast-guided STAR technique, 45% gets occluded. So it's not a very good technique because of higher restenosis and poor loss of side branches. So it should be used only as a bailout strategy or as a last resort when we don't have any other options. So should we really do this technique? Mini-STAR came in by Dr. Glassi, and he said, okay, we can go for a small modification, but then the restenosis was again 25% in these cases. So like suppose this case example, one of my colleague, sorry, he's in the audience. So if we see this is a basically OMCTO, try to enter the subintimal plaque. It's a subintimal tracking, trying to use a stingray. With the help of it, entered into the true lumen, but put a stent. But if you see what's happened, it's a long stent for a small occlusion, and we miss the lower branch. So subintimal tracking, putting a stent, long stent, along with loss of the branch. So the restenosis rate and the limb maybe have increased. So the concept came in 2013, we should go for a deferred stenting rather than just putting a stent in these cases. So deferred stenting is what basically you have putting a shorter stent segments. There's lower rate of restenosis and better long-term outcomes. And repeat procedure should be done after 6 to 8 weeks of index procedures. So different studies were, not studies, but case reports were published, which showed that when you go for a deferred stenting, you take these patients after 8 weeks, you have a better patency rate when these cases. And this was a very good study in which about 35 cases were there. And they showed the patency rate post-deferred stenting was much higher than the post-STAR cases. So can we predict the success of reattempt CTO PCI? Mostly retrospective data are there. They said if you are able to go for a subintimal plaque modification and you can achieve the TIMI3 flow, the chances of reopening these CTOs increases drastically. And if you are able to put the guide wire in the distal lumen, we are able to predict this that have reattempt will have a recanalization much higher. If you see the reattempt success, if my subintimal plaque modification, guide wire crossing, and I put a balloon dilatation, the reattempt success will be 93%. If you see the JCTO score, the one of the parameter was if a CTO is reattempted. That means if we make it modify, we might increase it, but if you're not able to cross the wire, the success rate is only 55%. So how does it change the outcome of completion of the procedure? First, by doing the subintimal plaque modification, by dissecting the plane, you may be able to result in re-establishing the antegrade flow, maintain the fenestrations, and these fenestrations may decrease the risk of developing of extra plaque, and there will be less chances of branch loss. But this investment procedure is not free of complication. You have to be aware. If you are going for SPM, ensure the guide wire is in the vessel architecture. It should not be totally out of the way because you are going to dilate the vessel. So there will be a risk of perforation, and avoid knuckling in a very thin caliber vessel because you might come out of the vessel architecture. So two of the cases, mine cases, which I did, this was a proximal LED CTO, and it was filling retrogradely through RCA. I said, let us try with an antegrade technique because there was a tapered tip, and this was a Gaia 2 wire, which I changed to upgrade into Gaia 3 wire. And if you see, my Gaia 3 wire is subintimal. In RAO and LAO view, it was out in the extra plaque area. So I did a last technique. I advanced the microcatheter and tried to puncture it to Conquest Pro. But if you can see, my subintimal tract is very long from the proximal LED till the mid part of it. So I said it's better to change the strategy to the investment procedure. I dilated the CTO segment with 2 mm semi-compliant balloon, and this was the position I had left it, because if I have stented it, I have been able to lose the large diagonal which was present in the mid LAD. So I kept it like that, called the patient after 8 weeks, and to my surprise, this was the angio after 8 weeks. So you can clearly see all the dissection planes have been healed in the proximal part, the distal LAD has been flowing, and the diagonal branch is healed up. So there's a good healing of the dissection planes, good TIMI3 flow, and now I can put a small stent with preservation of the diagonal. Second case, this was the investment procedure, what we had, what we left, and after 8 weeks, which I got in this case. Second case, post-cabbage patient, tried to cross it, advance the knuckled wire, left it, not stented, after 4 weeks, stented, unable to preserve the diagonals. So can we predict by anatomy which procedure to be there? Go for investment procedure, we don't know. Recently in 2023, they are going to do an invest CTO study in which basically they are going to prospectively, 200 patients will be evaluated, and the aim is to basically to evaluate the safety and efficacy of the investment procedures. And the anatomically high-risk CTO procedure, these are the categories which they have labeled, which maybe in coming future of 2 to 3 years, we might be able to get, okay, these procedures should be referred for investment rather than putting a stent in the same sitting. So take home message, investment procedure can be used as a primer step in successfully treating challenging CTOs. It is important to consider the benefit of investment procedure before classifying the intervention as failed attempt. And when investment procedure accompanied by adequate time for vessel healing, it is more safer, greater success rate, and probably shorter length, and we are able to save the side branches. And maybe invest CTO trial will give us more insights into this technique. So investment procedure, in case of procedure failure, it is facilitating the future success rather than going for a not calling off the patient again. Thank you.
Excellent talk, madam. Anyone has any comments?
Actually, investment procedure is actually a deliberate inflation of the vessel and dissection of the vessel. If you actually fail the attempt, it is a totally different one. So that are two things. That is what actually the Margaret was telling. She was the person behind these investment procedures. So Japanese, when they fail by dilating and dissecting, they will tell, I failed the angioplasty. But Americans, they'll tell, they made a new terminology called investment procedure. But she was telling that initial 20 cases, whatever she did, deliberately, she was telling, she claims that I deliberately dilated the vessel. And those patients, 100% she is telling, they came back with an excellent flow. I think that does not make us to think that all the patients just do a balloon dilatation and then send the patient away. We actually should have a clear anatomical understanding and should be in the vessel architecture. These are the two important points without damaging the vessels. And I think the message should not carry that I can just put a wire down and dilate and all. You should not. And it should be in the vessel architecture. And I still have a reservation. All the Japanese colleagues still think that they are actually blah blah and all. But it is, since it is an Indo-Japanese CTO club, I am telling this point.
Yeah, I agree, sir, because I told also that it's not free of complication. You should be very clear. It should be orthogonal view. It's in the vessel architecture before dilating it. And maybe which lesion to leave and which to continue. Invest CTO trial will might give an idea.
So Rupali, thank you for a nice talk. So there are two kinds of situations. One is that you are subintimal for a long segment of the vessel, but then finally in the apical LAD or RCA, you are intraluminal, in the true lumen. Then the investment procedure can help you to preserve the side branches when the patient comes in the future. But if you are subintimal all the way, you are not outside the vessel architecture, so you do an investment procedure all in the subintima. Will that also be successful in the future?
Like I showed this predictor also, 93% and 55%. Yeah. If you are able to come into true lumen, the success rate is 93%. Yeah. If you are not able to true lumen and going subintimal from the proximal till the apex, then the reach success would be very less, hardly 50%.
Hardly that they will connect.
We really don't.
Actually, we are actually not aware that we are in the subintimal or intimal here. We are not doing an IVUS and all. Actually, even the Rupalis, the first case, what you was seen, there was no flow there. Actually, when the patient came back, it was an excellent flow. Actually,
it was true lumen,
But we really don't know. But actually, the true lumen, we expect that the vessel is, when you are in the true lumen, definitely we will be tempted to stent. Actually, when in Belgrade in 2008, I'm saying, there was a case done by Samin Sharma earlier, and he did a balloon dilatation and the vessel was totally dissected. And they took the case for a repeat CTO procedure exactly after 1 year. And that was a live case. When he was taken, he was really shocked. The vessels were all normal. Everybody was shocked. He could not do the case. Oh, that is why. I think that message actually, some of the time, we are lucky to escape like this, but that does not be the situation all the time.
Actually, we have the retrospective data, whatever we have, and if you are able to enter the distal lumen contralaterally, you can document it, you can leave it. But if you're not there, there is definitely no answer to it.
Even if you are not there, you dilate the vessel, dissect the vessel, you just have to leave it. What you can do?
But if you don't dilate it, then when you take it for after 6 to 8 weeks, the anatomy is same. They don't have an antegrade flow then. Like we have few cases which we...
Actually, that is what I've done.
Yes, sir.
Deliberate dilatation is called as the investment procedure.
Yes.
Actually, unknowingly or you just dilate, it is not called investment procedure.
Yes.
That's a
Yeah, when you come back and it is open, then you say that I did investment procedure.
Yeah. Agreed.
Thank you, madam. Wonderful talk. I think we'll close the session and hand over to the moderators.
Thank you very much, and we thank all participants. And thank you, Suryaprakash sir, Raju Menon sir, Indrajit sir, and Pradhan sir for your successful guidance for all our participants. Next session, we are going to CD session 4, unsuccessful CTO PCI, why I stopped. We may not be unsuccessful. Every time the patient safety plays a role, we should always respect the coronary architecture. We may not be successful on that day. Next time we will be successful. Next, the chairpersons we will be calling D.K. Baruha sir, Srikanth Erram, Louis sir, Isaac sir, Sarita Rao ma'am. Discussions will be Dr. Vinod Kumar, Deepthi ma'am, Jitender Jain, Barun Kumar sir. I request please come on to the dais. Even Pratap Kumar sir, we request active discussion please, because the rules of the game remain the same. It's an 8-minute talk followed by 2-minute discussion. At the 7th minute, 1 bell rings. At the 8th minute, 2 bell rings. Because the judges are required, 3 exciting prizes are waiting for the winners. The judges are required to give the marks depending on their presentation. You will be handing over to the... yes, sir. Always. And at the end, just sign on the judge format. It depends on, most important thing is the participant time, sir. You need to, already we are running 30 minutes short of time. We request for presenter to come on to the dais. A case of failed LED CTO, Karthik Natarajan. Dais is yours. Sir, timer is automatically rings there and the bell rings there. Timer start from the 0. Please give him a chance. Don't waste his 2 minutes. Karthik.
Good evening. I'd like to thank Pratap sir and all the organizers of ijcto. So I'll be presenting a case of failed LED CTO PCI. So my patient is a 55-year-old male. He has history of anterior wall MI 1 year back, non-hypertensive with impaired glucose tolerance. Current complaints are dyspnea and angina on exertion. ECG showed Q waves in V2 to V6 with an ejection fraction of 35%, hypokinesia in the LED territory with mild mitral regurgitation. Stress MPI shows a large reversible perfusion defect in the LED territory. This is the angiogram. The ariocaudal view showing a normal circumflex. There is a large high obtuse marginal branch. The LED is totally occluded. And you can see that the LED is totally occluded. The proximal cap is not very clear. It's ambiguous. And this is the RCA, and you can see that there are good collaterals from the RCA, which collateralize the LED. So the plan was the target vessel was LED with a JCTO of 2. We took a right femoral axis, 7 French EBU guiding catheter, and a 7 French GR via the right radial axis. The strategy was antegrade wire escalation. The first strategy was to go for an IVUS guided puncture, and then if that failed, then retrograde via septal collaterals from the RCA. So we initially put in a workhorse wire in the RC, and we also had to put a wire in the conal in the aorta, a floating wire, because there was some ventricularization of pressure in the posterior RCA. And then we took these bilateral injections Sorry, there was spanning on this particular during this. Ideally, should not be done, but this is the other view. Bilateral injection. So you can see that the cap, proximal cap, is ambiguous. So we put a wire in the OM branch and we did an IVUS pullback. So I'll plate the IVUS. So as we come proximal, so we can see that this, and you can see that right at this from, I'll just freeze this. I'll just go back, then you can see that this appears to be the proximal, the cap of the LED, and if we co-register this with the LED, with the manual pullback also we took, we felt that this part was the part which was the proximal cap, or the ambiguous cap, which we co-registered with the manual pullback of the IVUS. Now this was 7 French guiding, so we could not do a live IVUS puncture, but you can see we identified the proximal cap, and then we tried to use various guide wires. We started off with a pilot 50 wire, we switched to a Whisper MS, we even tried the filter wire, but we could not actually engage the ostium. We identified, but because of probably the angulation of the ostium of the LED, it was very difficult to engage the proximal cap, and the wire could not be progressed further. So after many attempts, we decided to give up and try retrograde. We even tried to give the bend and tried to engage, but could not pass the wire. So now the right guide and the ostium of the RCA was giving us a lot of trouble. So we decided to fix the RCA, ostial RCA, with a stent. This is a 3x18mm stent. And it's placed aorto-ostially. And what happened was that after inflating the stent, there was some protrusion in the aorta. The stent balloon, it got stuck to the guide wire of the RCA. And we could not pull the stent balloon back. And while trying to pull it back, the whole system came out. And now we had this aorto-ostial stent in the RCA, and it was very difficult to wire this aorto-ostial stent. Finally, we were able to get a wire down, but it went through one of the struts, and it was very difficult to get a balloon down. And then finally, a 2mm balloon was used to dilate, and then we dilated the struts, crushing the part of the ostial, the parts which were protruding in the ostium with this balloon. And then now we decided to go retrograde. Now this is a Caravelle microcatheter. And then we used a Sion wire. And we were able to make the way into the LED. The Caravelle microcatheter was pushed and it was able to enter the LED, the distal part of the CTO. Now at this point of time, we switched to a pilot 150 wire and we tried retrograde wire escalation, but again we could not enter the You can see that here also we have gone with the wire extra plug. So we switched to we tried a UB3 wire also. We put an IVUS catheter over the antegrade wire which was in the OM branch and tried to locate the wire position. But by this time the patient, it had been more than 2.5 hours, the patient complained of dyspnea, he had bilateral crackles. And if you see the IVUS over this antegrade wire, I'll just show you the IVUS. We could actually not identify the wire anywhere in the close to the proximal cap. So by this time, the patient was in heart failure. So it was more than 200 ml of contrast and more than 5 grays, and we had to abandon the procedure. We immediately checked for the integrity of the collateral, which looked okay. We post-dilated the RCA. We did quickly an IVUS of the RCA. I'll just play out this IVUS. You can see that in the ostium, there was some under-expansion. There were these struts which were hanging out because we had gone through one of the struts. We went to high pressures, optimized the ostium, and then this was the final result. So the take-home message, the patient's been almost 6 months since we attempted this procedure, and the patient is on medical management, continues to have some angina. So the take-home message, IVUS may be helpful in resolving proximal cap ambiguity. Tortuosity within the CTO segment can be a reason, or the proximal cap can be a reason for failure. Donor vessel injury can be catastrophic, and reverse cart is the final stepping stone to success in retrograde CTO PCI. Thank you. And for the final, I'd like to add that I'm waiting for Pratap sir to come to our institute. Probably he'll do this case again because we're waiting for that CTO camp.
I could not understand why that RCA balloon system came out, because
Sir,
it was almost
actually-
a simple angioplasty.
Yeah, sir. Actually, the stent balloon, somehow it got stuck to the wire. The wire, we tried to pull it back, but it probably got stuck to the underlying guide wire and it wouldn't come out. So
Did not deflate.
No, it deflated, sir. The stent balloon deflated, but the stent system somehow, I don't know what the reason was, that it got stuck to the underlying guide wire, it couldn't come out. So when we tried to pull, the whole system came out. And since it was an aortosteal stent, it was very difficult to engage the stent again. And that took a lot of time actually and hard work. So we felt that we should have fixed the RCA upfront before even attempting the LAD, because whenever you want to do the LAD CTO, it is better to fix the donor vessel first, because there was some ventriculization and disease at the RCA, but that was fixed later on when we were planning to go retrograde.
One more question. Where do you think the retrograde wire tip in the left main, what was the actual, what was your concern?
I don't know, so whether it was in the vessel or outside the vessel, because it did not show up on the IVUS, but probably it was within the, not very sure whether it was in the architecture. It looked in one view to be in the vessel, inside the vessel, but extra black. But when we tried to do an IVUS, we actually couldn't visualize the wire anywhere.
Yeah, congrats, Dr. Karthik. It takes a lot of courage to present failures. My only suggestions were probably here retrograde would have been difficult. You mentioned about the donor vessel and the issue about the osteal stenosis. You didn't think about an angled microcatheter, because even in non-CTO situations, it would have been extremely difficult to wire this vessel. Angled microcatheter, especially the 90-degree one, would have made your life easy. And second, if you could not do a live IVUS, one of the good things is if you could have just marked on the fluoroscopy where exactly your IVUS was, then take an angled microcatheter and try to use a slightly higher penetrating power wire. Probably you would have succeeded anti-greatly.
Yes. Actually, I just wanted only one question. Which step you did not do? You have, actually it's a failed case. Failed case means you attempted everything and failed. Okay, your retrograde wire is not coming. Which step you did not do? He told angle microcatheter, but I don't believe that because it will be so difficult.
We did not
there.
do reverse cart, sir.
I think you did not use a dual lumen catheter. That is actually, I was missing in that. Whatever the steps you did, you tried one wire, then dual lumen catheter was not used. IVUS guided puncture you tried. Whether you failed or successful is point. All the points. Dual lumen catheter was not used. And rest of the things, actually as Sibi told, that was a mistake or the procedure actually, that your balloon was not there. But your catheter should have been as deep as possible to get into the wire. And your wire gone nicely. That is all okay.
Was a CT done before or after, just to address the curiosity of the osteo?
Sir, CT was not done, sir.
I think we can go ahead with the next case.
Thank you.
Thank you,
Case
Karthik.
Case 2, failed
Dhananjay
antigrade and retrograde RCS CTO, Dhananjay Kumar.
I have a doubt. The timing has no mark here.
Sir, it's all the judges, so you need to decide, keep timings in the sense and give marks, sir.
Okay, so we keep timing also one mark, but timing has no mark here. But even then, you don't exceed time, please.
Good evening, chairpersons, august audience. Myself, Dr. Dhananjay Kumar from Medka Hospital, Ranchi. This is again a failed case. I tried anterograde and later on retrograde, but yeah, this was about a 58 years male presented with NSTEMI. His vital was stable. He was non-diabetic, non-smoker, had hypertension, dyslipidemia, and he was obese. His ejection fraction was about 50%. So I did this case in my earlier attachment, and I only got this image from there. So this was the left system, and RCA I will show you later. It was a total cutoff, and it was a short segment RCA CTO. So I fixed the left system first with left main bifurcation, and now this was the about 3 to 4 months later, I started this RCA CTO PCI. I tried anterograde with workhorse ward placed at the proximal tip, and with my microcatheter, I exchanged the. Unfortunately, these videos are not running. So I exchanged it with sequentially with Fielder XT, later on with Gaia 2, and finally with Conquest Pro 12. Somehow I was in true lumen for some extent, but later on I missed the lumen and I went extravascular. So ultimately this was the final the staining outside the vessel. So I abandoned the procedure and decided to go with retrograde after 1 to 2 months later on. So I started retrograde with fine cross microcatheter and Sion black with through the stent struts. This was I reached the true lumen of sorry, this running. So my wire reached to the distal tip, and my microcatheter also reached there. So I exchanged the wire with Gaia 2. Again, I was in true lumen for some extent, but to take a guide, I took anteriorly anterograde GR catheter and a workhorse wire to the tip of the proximal cap. I was able to enter the initially I thought I have entered the true lumen, but the wire was not entering the guide catheter, GR catheter. So it was it must be in the false lumen. My plan was to do an anterograde entry into the CTO, and I plan to do one ballooning there and then re-entry through the retrograde Gaia. But the guide catheter JR was not supporting that, and it was backing out. So I exchanged that guide catheter with L2, and I was planning to do that, but somehow at what step I did this, but in the final this was the staining in the autoosteum. So I abandoned that procedure at this stage. My patient was almost asymptomatic. I was just like any operator, as I was operating a CTO. So I opted to abandon this procedure, and my patient is absolutely all right now after about 10 months or like. He is asymptomatic and he is doing good on medicines. Thank you.
Dhananjay, actually you presented, I think you ended with a complication. That is a different thing.
Sir.
What are the steps you missed? Actually, when you just failed CTO means you should have done the steps in the proper way. Which are the steps you missed? That is what the question asked for the last operator also. I will ask only this question. I don't want you created what.
Sir, Initially, when I was doing interrograde PCI, I must have used, there was one branch, so I must have used dual lumen microcatheter.
Where,
and went
where?
to the, so first, the second
No,
I
where? In antegrade or retrograde attempt?
interrograde attempt.
Antegrade
Initially, in interrograde attempt, I must have used a dual lumen, and the second.
Where? I could not see that.
Sir, one branch was there at the tip of the proximal
CTO.
cap. Yeah, CTO.
No,
proximal
that
cap.
was a small branch. I don't think you can enter there with that.
Yeah,
That
and
is
the
number
sec-
one.
the-
Number one. You just
the-
tell the
yeah,
numbers.
yeah.
One.
The second, I could have used one IVAS, sir, in interrograde approach. I could have seen because the branch was at acute angle, and it must have given some image to the true lumen of the RCA interrograde.
Number
CTO.
two. Number three.
Number three, I could have used another IVAS while using the retrograde reentry. So
Where?
from the interrograde, IVAS.
How do you
image-
see, man? The antegrade wire is not crossed. Your retrograde wire is actually where?
So whether it is in true lumen or false lumen, and I could have seen, I can reentry through the
Number three. I accept all our points. Number four. Anything more? I just wanted to tell 3 points.
No, sorry, you can add this.
Number one, actually, when you just take the retrograde wire up, you did not do a reverse cut, and you should have created a reverse cut for entry into the subintimal to intimal or intimal to entry. That is number one.
Sir.
Number two, you could have taken a guideliner that into the proximal part, there your wire, if it is in the true lumen in the distal part, proximal part of the RCA, definitely it would have entered. And number three, you should never ever do this much to create a dissection in the RCA part. These are the 3 mistakes I have seen. Okay, this failure of CTU. And number 4, if you take the channel, retrograde channel, if you have taken a channel which is the smallest channel possible. There was an excellent channel just distal to that. That was actually, I was seeing. Any other questions?
Actually, the AL produced the
Sir.
dissection.
Sir.
Usually, this kind of case, when you do, you will be interested in doing the CTO. Means your nerves might be in, so the catheter might be wedged. So better to take a side wall catheter. Sometimes it can prevent it.
Yeah,
And
yeah.
second thing, it was a second time procedure. So you would have initially itself taken a good
Support.
good support
Yeah,
catheter,
yeah.
because second time you should be more prepared.
Sir, I avoided using the AL1, sir. Initially, I took JR first, but it was not giving good support. That's why I opted for the AL.
And I thought you said it was AL1, right?
Yeah, I used
no,
AL2.
that was too aggressive. Maybe an XBRCA, which is as
Yeah, I
equivalent
accept
as
that. I accept that,
0.75.
sir. I accept that. Thank you.
I think the same thing, only you need to have a good guide support first time.
Sir.
This is very important.
Sir.
This is what we took here.
Yes, sir.
At an extension catheter or maybe good.
And the first attempt you did not try that is a parallel wire technique also there.
Yes, sir. I could have tried, sir, parallel wire.
These are
Yes, sir.
actually the,
Yeah.
once you present a failed CTO for everybody, I'm just telling that you should try everything and nothing is successful and then send the patient for a second procedure. That is okay. But you should try all the steps. Actually, what I was mentioning, the steps only. Thank you, Dhananjay.
Thank you, sir.
We will go to the next question. Shravan Kumar.
Shravan Kumar, failed CTO PCI, case number 3.
Whatever I am telling you, actually, just for the academic interest, nothing else.
No, sir, it's always welcome, sir. Your suggestions are always taken into good account.
Respected Chair and good evening, colleagues. This is actually a complication which made me to stop the case. It's a case of 16-year-old male who is hypertensive diabetic and dyslipidemic, and also patient had NSTEMI and LV function was 46%. He had a mild tremor and trough was elevating. So there was T inversions in V5, V6 and inferior leads. So this is angiogram. There was RCI is normal. We can see there is a stump in the ramus or early OM. LAD, there was mild to moderate tubular lesion in the proximal part. So I thought this the culprit could be that ramus or the early OM. So though the LAD lesion was borderline, we thought we'll go ahead and fix that completely occluded ramus, and we can see that it was filling through the collaterals from the homocollaterals. There was a difficulty in engaging the LM. If I push the guide furthermore, it was creating aortic regurgitation. If I pull the guide, then it was deeply engaging. So I tried to engage. I could see the stump there. So I thought I will take a field RFC wire and probe that. I did not take microcatheter. That was a mistake. I could have used a microcatheter with a field RFC, but I directly used a field RFC wire. It was going, and later I could not negotiate it. But after trying for some time, patient complained of chest pain, and there was a diffuse spasm in the LAD. And after giving NTG, that spasm improved. But once we took an orthogonal views, we can see clearly there was an LMCA dissection. Clearly we can observe that probably that guide has gone inside and caused the dissection. So first we took care of that LMCA dissection. We stented that LAD part with 3.5 into 18 and the LMCA with 4 into 22. And we stopped the procedure there, and we did an IVUS pullback, and the MLA was adequate, and proximally and distal MLAs were okay. So this was the final. So to conclude, there was this LMCA dissection is quite rare. It occurs in 0.1 cases of PCI and less in CAG. And there are types. Either it could extend, stay there within the LMCA, or it can extend distally, or it can extend to the aorta, as we've seen in the previous case. So the 2-3 mistakes evident to first, I did not use a microcatheter in the initial step, and there was a difficulty in holding that guide. That's all. Thank you.
So in a situation like this, suppose you're not holding the guide because you have a very short segment for the support. What are the things you should do?
One supple wire can I place in the LMCA into the aorta so that that will not deeply go into the LM. That is one thing.
Okay. But your problem is in the left main. You're not able to get a support.
Support was there, but probably support was not a problem. Only sometime it was either if I push it deeply, it was creating aortic regurgitation. I would keep it into that, it was deeply intubating. Meanwhile, all this, somewhere it caused that LMCA dissection.
Yeah, in that case, I think that maybe, because it is a very short, you have a very short segment, your operation, area operation very short. Just you have to go to the ramus. The left main is very short and you don't get a support. In that case, probably you can put another one because there is a disease in the LAD. So you can better to put a wire into the LAD or other branch, suppose, circumference. You can get a better support in that case.
Yeah.
Because you don't have good support. That's why the guide was moving here and there. That probably that's the reason why I don't think there was any support. Your catheter was moving out and in and out. But actually, you took a filter FC wire without a microcatheter. Do you think filter FC is the wire of choice here?
I thought it was an NSTEMI case, so it was not a CTO. Probably I thought.
Why don't you take a normal wire? If it is an NSTEMI carrier, you should have taken a BMW wire.
I thought some channel it will be better cross.
That means you actually thought you require a polymer jacketed wire for actually better trackability of the vessel. Yeah. That is what you thought. That probably is the reason you have taken. But as Baruwa told, probably the LED has actually a disease of nearly 50% minimum. So that probably the vessel can create any problem for the patient is actually you put a wire to LM to LED wire. Then you can attempt that. That is actually, I think, because there is only 2 or 3 millimeters maximum from the LMCA for any working. So your microcatheter will be always, if at all you take a microcatheter, that will be in the LMCA to work. I think that wire choice was definitely wrong. And then next question is, you put a stent from LM to just at the ostial part of the LAD, then another stent. Do you think that this stent can create a problem in the long run for opening the ramus again? So because you should actually give another chance to another operator. That also you actually screwed up. You actually did not give because you have a overlapping segment there. So that I think, that is what is my tension. You did save the patient, but you did not allow the other operator also to do anything tomorrow.
Distal vessels, they're filling, sir. We can see the OM filling. We can quietly see the distal segment, so that's why we attempted. It was long only, sir. It was 30 only. It was 30.
More than 20, 30
it's
millimeters.
30
Actually, distal vessel is very well seen
It's
in the
very
first
well
angiogram.
Clearly seen. The
First
distal
angiogram.
vessels. That is why we tried. Because
Trying was not actually, as you told, it is an STEMI. Probably wire would have jumped
I
and
thought it would pass.
thrown. But once your wire is not going, keep the microcatheter there. Take a try, a minimum XT like wire, and then try. At the same time, your injection, you should look at the angiogram. Your catheter was actually focusing on the that is wall of the vessel that was created the dissection. Actually, that is not the way to inject. Basically, that injection part, I was actually unhappy about two things. One, your injection, that was not good. Second, you did not allow the second operator to do the case for them.
Second LMCA.
Second operator means tomorrow somebody else or Sibi or I will get a chance to do that
LMCA
case.
was dissection is there in the LMCA, so we have to stent the LMCA.
No, that is true, but you could have stented LMC to LED, single stent. Why I'm telling there is an overlapping segment that actually taken your next procedure is in trouble. You have two stents cut across to pass the wire down.
In LMCA, single stent. It's
No. I'm telling you about the Ramus intervention tomorrow.
Then, okay.
That is to be done by somebody, you know.
Your left main is up, so you have to keep on pushing that. Have you seen that? Denting this roof of the left main.
That's what when I pushing actually that it was touching there. If I pull back,
any support. Suppose you put a wire into the LED, that would not happen.
Yeah, in retrospective, I feel I could have put a wire in LED on this pull wire into the.
Push a wire into the LED and push this guide little bit up, so it will be more coherent rather than.
It's a failed case you presented nicely, and it is actually, I'm just telling, these are the observations you should make tomorrow for giving opportunity to the other guys. Thank you.
Thank you. EBU3.
Actually, he wanted to use a 3.5, you know. Next presenter.
Next case 4, a retrograde sneak peek into RCA CTO through LED CT. Daya.
Good evening, one and all. So this guy was a 66 years old gentleman, known case of diabetes, hypertension, and PVD. Status was CABG in 2005, had repeated admissions for heart failure in 2022, 2 admissions in 6 months. Now this time he presented with NSTEMI, severe LV dysfunction, decompensated heart failure. So after initial stabilization, we did an angio to him. So this is the angiogram of this patient. There's a proximal LED CTO is there, and the distal vessel was filling retrograde from Lima to LED and SVG to diagonal graft. There's a small lesion here in LCX also, but it's a flowing vessel. This is RCA, mid RCA, there is a long segment CTO and there's an ambiguous cap. There are twigs coming, but there is no clear proximal cap here. And this is an injection from the left system showing the retrofill to distal vessel. PDA is filling nicely from the septal collaterals, and PL is mainly filling from the LCX through epicardial collaterals. SVG to PDA graft was occluded. So Lima to LED was patent. And distal vessel was giving good collaterals to PDA and PLVB. PDA and PLVB, they look like pretty good branches. SVG to diagonal graft has 2 lesions, one in the mid-focal tight stenosis and one at the ostium. So to circumvent the crisis, initially we decided to stent the SVG to diagonal. One stent was kept at the ostial SVG to diagonal and another stent at the mid parts. 2 small focal stenting was done, and we got good result as per IVA's findings. Post-PCI, patient improved symptomatically. LV function gradually improved to 45%, and we left the patient here. 3 months later, this is the SVG to diagonal, and the stents are nicely patent. Stress thallium was done, which was suggestive of viable myocardium in RCA territory. So now we had planned to revascularize the RCA CTO. So at this stage, this is the anatomogram of this patient. This is the SVG graft. The stents are patent here. This is LED CTO. But whatever collaterals that are going to PDA, they are mainly coming from the part of the LED which is distal to the CTO, all these septals. And Lima to LED is attached here and giving good supply. SVG to diagonal is giving good supply. And then we have a long segment RCA CTO. And as per the CT findings, there's a SVG to PDA graft which is just attached pre-crux here. So this is the main portion. And here in the proximal part of the LED also, there was some disease. So as per the JCTO score, proximal cap is ambiguous, length of the lesion is long. We are expecting some angulation at the distal cap where there is a bifurcation, and some calcium was present as per CT as well as on angiogram. It's a retry lesion, not a retry lesion. So as per the algorithm, we don't have a good proximal cap. IVUS guided cap entry is not possible because we don't have a good size side branch. So these were the challenges. First thing is go retrograde. Second, interventional collaterals are coming beyond the LAD CTO. So open the LAD CTO before going retrograde. And there might be a need of triple injection. But here, what we decided is to take stepwise dual injection of left system and SVG to diagonal, followed by left system and RCA. Plan of action, antegrade LAD CTO, PCI with antegrade via escalation, with guidance of retrograde injections through SVG to diagonal graft, followed by retrograde RCA CTO through recanalized LAD CTO via septal collaterals with retrograde wire escalation. If it fails, retrograde knuckle wiring. So the same guide can be used for SVG for guiding the LAD CTO, and the same guide can then be shifted to RCA. So antegrade we started with Gaia 2 wire with Corsair support, and retrograde injections were taken through the microcatheter which was parked in SVG to diagonal. So initially Gaia could not puncture, so it was escalated to Hornet 14. And then through the retrograde injection, we confirmed the true intraluminal position of the Hornet, and then which was later changed to Gaia. And after crossing, we dilated the LAD CTO with 2 mm balloon, and space was created for retrograde. Then after creating the space, we placed a caravel and took injection. By this time, procedure time was 80 minutes, contrast volume was 60 ml. So when we started going retrograde, this is the end of the crux where we parked our microcatheter, and we could notice that the septal collateral entry to distal cap distance is too short, and we might have a problem maneuvering the retrograde wire here. So first we went with Fielder XTR wire, then exchanged to Gaia 2 wire, and then the Gaia 2 wire passed. But antegradely we had parked one microcatheter here, and both the wires, both the things, they looked in different plane. So we took 2 orthogonal views, and here we could make out that actually both the antegrade and retrograde gear, they are moving out of sync, and probably the retrograde gear is in the SVG graft and not into the true distal vessel. So after that, we came back, and this is the Fielder XTR wire, and we tried knuckling. And after knuckling, where the point the knuckle went, we parked the microcatheter till that point, and again took 2 orthogonal views. Again, the knuckle also went into the SVG graft and not into the native vessel. So the problem here is because the SVG to PDA graft was just attached pre-crux, and sometimes if the graft length is shorter, the distal vessel, it gets more aligned to the graft rather than to the true vessel, and the true vessel might have some angulation and kink after the graft placement. So this angle was the main problem in negotiating the retrograde wire here. So after realizing this problem, we decided to switch the strategy, antegrade wiring with support enhancement. So antegradely, we took a Corsair microcatheter with Gladius Mongo wire, and to enhance the support, we placed a 3 × 10 mm balloon here to trap the microcatheter and enhance the support. And this retrograde gear was kept in place as a marker so that we can decide the plane of our antegrade wire. But because of the same problem, there is an angle in between the antegrade wire, and the retrograde wire is directly filling the graft, not to the distal true vessel. The reverse card was difficult. We tried multiple attempts, antegrade wire marking techniques, retrograde wire marking techniques, but exceeding contrast limit and procedure time and radiation limit, we decided to stop the procedure here with investment for future attempt. So as a part of the preparation of the future attempt, till whatever part we have crossed the antegrade wire, we decided to modify this subintimal space by dilating into the subintimal space with a 2 mm balloon. And at the same time, in the next attempt, if we require a retrograde gear, we need to protect this opened up LAD CTO that we have opened up. So whatever hard work we have done for it. So we dilated this part, and we sent it from LM to LAD to keep the retrograde option open for the future attempt. So this is the dilatation with 2 mm balloon. And at the same time, we made it sure that we did the LM to LAD stent from Austrian LMCA under IVUS guidance. Because if there are too many studs hanging into the aorta, the future guide engagement will be a problem for us. So this is an IVUS showing appropriate ostial landing of the LMCA stent, and we could achieve good areas. So this is the point where we stopped. LED has a good result. We can see the distal vessels of PD and PLVB are filling nicely, and this is the RCA after dilating into the subintimal space. So post CABG CTO is challenging. SVG anastomose to pre-cux RCA can fail connection of antegrade and retrograde wires. RO and LAO views can help us differentiating the wiring position in SVG versus RCA. In case of procedure failure, whatever limiting steps were there, preparation can be done for it to make the next attempt easier and faster. As my final slide, I want to show that 3 months later, we attempted the same case. This was the initial injection, and this was after the success.
Can you present a success case here? It's actually a failed CTO program. You cannot. You are actually not justified in presenting a successful case.
So that was later attempt.
But then you cannot. What are you doing? Actually, we are actually disqualified in presenting this. Okay. Since I am sitting here, I cannot allow this case to be accepted at all, because you are actually this is actually for learning from our mistakes, and this program is we plan for failed cases only for not to show the successful cases. You could have shown the failed part and the success part in the next year, but you are actually done a big mistake. That is actually, I think there is no question to be asked, but one question I have to ask. Lima is patent. How can you open the LED? That is actually unjustified if you are unsuccessful. This is actually unjustified way of intervention.
Okay, you have done this open the LED. Can you explain what will be the hemodynamics of the LED right now? Can you explain it?
Competitive flow will be there.
Because of competitive flow, Lima will get occluded.
What will happen? Can you explain me? I'm not able to understand it.
Because of competitive flow, Lima might get occluded.
Yes.
And actually, I'm just telling you, this is a good case to present, but not in the failed CTO program. We are actually just wanted to learn out of it.
I apologize for my mistake.
Anyway, good case is skill-wise. Skill-wise, it's a good case.
No. Basically, there are two things, very important things. One, in a Lima patent, you are not supposed to open the LED. That is actually not acceptable. See, when we are actually doing whatever it is not acceptable, number one. That is the most important thing here. And when you are doing something and you are telling that your wire actually, marker wire, I did not understand. Your marker wire was never in the vessel. How can you have an antegrade wire as taken as the marker wire for your taking the antegrade wire? And your wire was in the graft. How can you have that wire as the marker wire for the native RCA?
No, sir. Retrograde wire was.
Where retrograde wire? Retrograde
Sir,
wire went into the RCA graft,
Sir, after that we took it out and.
But you did not show that step. See, actually, I am a minimum decent person to understand what is intervention. So I think these are the major mistakes in this case. Case was well done, but I will not be able to accept a patient with a Lima, patent Lima, to opening an LED CTO and putting a stent from LM to LED. Thank you very much. They are wonderfully presented, but a successful case. And we will go with the next case.
Thank you,
Dr.
Dayan.
Manu.
It was an excellent presentation. Thank you, Pratap sir. And next case number 5, a calcific RCA CTO, the rock that failed me. Mr. Manu.
Good evening, all. Our case is a 74-year-old male. He presented with effort angina. He's hypertensive and echo showed good LV function. Angiogram showed the 3-vessel disease. Can you see that the RCA is diffusely diseased and calcified vessel with a short segment of CT at the level of mid RCA. And proximal LED also calcific disease. First, we address the proximal LED lesion with aorta assisted stenting, followed by So first we tried anti-grade wire escalation initially with the field XTR with the microcatheter. It failed, then GAD second and GAD third, followed by a Congress protocol, but we could not penetrate the proximal cap. Then we tried retrograde approach. Septal collaterals closed with a fine closed catheter with a SO3 wire. SO3 wire reached the PDA and fine closed catheter advanced up to the distal cap. And fine closed catheter taken to distal cap and then retrograde wire escalation done with a Gladys wire. As you all know, Gladys has the longest polymer jack according almost 40 centimeters. So ability to navigate through the calcified, long calcified segment is higher. And true lumen to lumen cross can be achieved with the Gladys wire. And Gladys wire entered, the retrograde Gladys wire entered into the antegrade gating catheter. But again, the retrograde gating catheter could not be advanced across the lesion. So once the retrograde wire entered the antegrade gating catheter, and if we could not advance the retrograde gating microcatheter through the lesion, then the only option left is tip in. So we tried a tip in technique. The antegrade, you can see here, an antegrade turnpike microcatheter was used to intubate into the retrograde that Gladys wire, and we could successfully intubate the retrograde microcatheter into the antegrade wire. But again, this antegrade microcatheter could not be tracked through the CTO lesion, probably because of calcification. Then we removed the retrograde wire, and we did an intra-plaque rendezvous with the field ref C wire. And field ref C wire could navigate through the initial path created by that retrograde wire into the distal microcatheter. You can see the distal microcatheter. So the intra-lesional rendezvous done with the field of C wire. And again, after passing the field of C wire and parked in the PDA, antegrade turnpike spiral could not cross the lesion. So we then tried low profile balloons, gate extension catheter, direct OTA wiring, but all failed. And finally we had to stop the procedure. So the rating point is the calcific CT is a real challenge for an operator. If laser was available, it would have helped this case because laser requires only a gate wire to perform the further. And another advantage is the rota wire, the traditional rota wire is not a trackable wire, but if the now rota wire drive is available with enhanced torque transmission, which could be used for direct wiring, then good gate cut support is necessary in this case. We didn't use an ambulance catheter because initially the JR catheter offered good support, but we tried all other methods like anchor wire, gate extension, etc. because all flagged. And final option left is an extra plaque crossing. Thank you.
Because good case, because initially itself it's a heavily calcified RCA. Heavily calcified, you could see all the calcium. So Gaia wire could be the best wire usually, but Gaia also you could not
all
cross.
All antegrade wires failed, including Congress Pro.
I think your RCA guide was JR guide.
JR guide.
Why ambulance was or supportive?
Yeah, usually
because this kind of calcium,
we
could have planned a good. Then pushing the microcatheter into the calcium and tried the rota wiring was not possible.
Not possible because the conventional rota wire is not trackable. But you can see that it is just stopped at the level of the lesion. Both catheters, both
any very small 1 mm balloon.
That also failed to cross.
Okay.
Both the microcatheters failed to cross the lesion. Just stopped at the level of that calcific lesion CTU. But the antegrade wire, the field of C wire, could track through the initial the path created by the initial that retrograde wire. So if a rota gate wire was available, then that could have been tracked.
Next is the lecture presentation by Prof. Ishiro Hamanaka. We kindly welcome you, sir. This is only the expert lecture presentation.
I was thinking that why you are presenting So thank you very much.
No, it's the only on every CD session we kept in one lecture presentation just to make sure that there make time.
I can talk about the success case, right? Okay. Okay. So today my topic is the overview of contemporary reverse cut. Okay. So let's brush up. Okay. So we have the classical concept. That means the conventional reverse cut. And Also, that now the time we have the concept of the contemporary reverse cut. Okay, so classical concept with at that time we have not have the well controllable wire such as Geyer wire were not available. So you should remind that. And nowadays we can use the well controllable retrograde wire such as Geyer can be used. So this is a classical concept of the reverse cut. So if you do the retrograde wiring like this, and then the wiring, then finally you make the big, subintermount space or this kind of space. So after that, even using the antigrade balloon wiring, so now you cannot control the retrograde wire well because inside a big space. So after the trying the ballooning antigradely, so still it has not much space that you can create. So that means you need a more bigger balloon to make a creation between the antigrade space and the retrograde space. And then finally you can do that. So this is the concept of classical reverse cut. I will show one case, success case. And it has the retrograde channel to the RCA. And also this is the proximal part of the RV branch is very ambiguous. So firstly we check the IBUS from the RV branch and insert the antigrade wire with a miracle nail 3 wire. And the retrogradely, because of maybe there's some stiff calcium here, so the knuckle wire worked from the proximal to the distal lumen. However, we used the 2.5 balloon, and also the retro wire was the Sion black. So Sion black was, by accidentally passed through the lumens created by the proximal balloon. So this is the final. And this concept is that the antigrade balloon size should be large enough so that the antigrade balloon can create the connection where the retrograde wire can slip into the proximal lumen. The retrograde wire usually should have be low penetration wire so that the floppy wire has more chance to slip into the connected channel compared to the stiff wire. However, in some cases, stiff wire should be used if the floppy wire cannot slip into the connection, or more large size balloon should be used. So this is a limitation of the conventional reverse curve. So large size balloon inflation can cause massive vessel injury, occasionally perforation in CTA lesion. The passing of the retrograde wire may be of limited certainty, and that's by chance. And using the high penetration wire as a retrograde wire, it may have higher chance of wire perforation. And because of the uncertainty of the retrograde wire passing, the procedure time could be prolonged. Okay, so for more simplifying the retrograde procedure, and then we can now use the controllable guide wire, so that now the contemporary reverse cut. Okay, so in this situation, we don't need to use the retrograde wire direct crossing, kissing wire technique or so. We can just use the contemporary reverse cut. Why retrograde direct crossing is not recommended? So as I mentioned earlier, so doing the wiring for the retrograde, trying to pass through, but finally, you make the big dissection, and it has no chance to go pathway. So this is the concept of contemporary reverse cut. That means we say directed reverse cut. So that means the minimized balloon size to reduce vessel injury, and the passing of the retrograde wire might have higher possibility. So reduce the risk of retrograde wire perforation, and procedure time can be reduced. So, okay, this is a scheme. I will show that. So firstly, proceed the antigrade wire, then proceed the retrograde wire towards the balloon direction, and dilate the balloon, and make a hole, then it automatically pass through. So here's the case, and another case, and this is a RCA CTO, and also quite same, but there's some chance to the small channel maybe. Okay, anyway, so after the anti-grade lead, then retrograde wire, and okay, this case has one time failed case with after ballooning make such dissections. So there's so much dissections here from the retrograde, but antigrade we strip into the balloon, and then the balloon is here, and the retrograde wire towards the balloon side, and it automatically pass through. So this is the final. And so setting procedure for the contemporary reverse card is first setting of an antigrade platform, and two, the setting of a retrograde platform, and bring wires in both directions closer together in the region. And for the antigrade ballooning with small balloon, so set the retrograde wire tip towards the balloon, and retrograde wire penetration during the deflation of antigrade balloon. So, okay, again, I will show the theme. But, okay, this is the tips of the contemporary reverse cast. So, again and again, I said that do not stick around the retrograde direct crossing. So, it has just making the large, subintimal space. So, okay, so, and also this is the tip of the contemporary, the position of reverse cut is very, very important inside the CTO. So in case this is the thing that this kind of, bend here, and if you try to do the reverse cut here, now the antigrade balloons and the retrograde wire has a coaxiality, the same coaxial. That means it's quite easy to do the penetration, And also, in that situation, in the distal part of CTO, in this case, so now you can do this, the coaxiality is same coaxial. So now you can do the kind of this kind of thing. But think that in this situation, the balloon, the axial of the balloon and the axial of the lateral wire has, has a difference. So it is quite hard to do the retrograde. Okay, and the last tip of the contemporary reverse CAD in the so-called the end balloon wiring technique. So imagine that we puncture this balloon from the side, and in many cases we have to do it, but if we do that, so sometimes we're using the Gaia 2 or 3, and it penetrates the inside the lumen, but after that it goes out to the subintimal space. So, and we have much more chance to penetrate from this end of the balloon, and it already make the balloons, and the wire wants to go through the straight, so it has the highly chance, I think. Okay, the unsuitable lesion for contemporary reverse CAR is, of course, the short CTO and severe tochesty lesion and heavily calcified lesion. And the final one is what caused contemporary reverse CAR failure from the IVAS concept. So we have known that both antigrade and retrograde wire is in the position of the retrograde and antigrade wire by using IVAS. You know this mass scheme. And so one is that the large hematoma has already created, and from the retrograde or antigrade. So in that situation, we cannot use the small balloon, that cannot work. And also there's a severe calcification, of course, between the intima and the subintima, and we cannot make the connection well with the small balloon. So this is the final slide. Before starting the retrograde wire manipulation into CTO lesion, antigrade setting should be done, and bring both antigrade and retrograde wire close enough to each other, and using small balloon for the antigrade target, and using trackable wire such as Gaia Next 2 for reverse card. Position of reverse card is important, and if it doesn't work, check the IVAS. Thank you very much for your kind access.
Thank you very much, Pope. That was an excellent session.
One question. Actually, you do even now, for every case, you do a contemporary reverse cut or not?
Sorry?
For every case, you do a contemporary reverse cut, or in some of the cases, you don't do contemporary and you just do a normal.
Actually, if
That
the
means-
integrated approach is not work, so maybe.
But the size of the balloon, what the size? 1:1?
No, actually 2.0, yeah.
I think. Thank you, Hamanaka. I was actually thinking that you are also presenting. Otherwise, we would have called you to make and sit here to evaluate the case, you know. Thank
Excellent,
you.
Professor Lu. Thank you. I request all to just give a great round of applause for him. Thank you very much for educating us. Next, last two sessions are remain. Case 6, Anil Kumar, retrograde CTO PCI.
Is this actually a failed case or a discussion?
Sir, what? It's a case 6. Even if failed or not failed, just stick in. There are some mix because of CDs.
Only to be considered.
No, anything you consider and check it vitality and presentations.
I don't understand.
Even if it is the fail case, if they are not showing any fail case also, please consider them and just give marks according to them, sir.
Oh, why?
Some because of we are not getting number of cases in that part, just we have mixed it 1 or 2.
Okay. That's fine.
I request next presenter, Mr. Anil Kumar.
No Anil Kumar here.
Okay. Next, 7th case, banana left main, Mr. Somendra. Dias is yours, ma'am.
Thank you. Good evening, everyone. This is a case of flush LED ostial CTO.
6 is not there, sir. 7th case.
Last case.
Last case.
Good evening, everyone. This is a case of flush LED ostial CTO with a subtotal LCX ostial lesion, through which we would like to highlight the thought process behind the approach, which might seem to be very simple, but actually it was the safest approach, considering and anticipating the challenges and complications that may ensue in such a case scenario. So our patient was a 65-year-old diabetic lady who presented to us with class 3 anginal symptoms which were medically refractory over the last 6 months. Her TMT was strongly positive. She had a normal ejection fraction with normal valves, was physically very active, and had a normal BMI. This is the diagnostic angiogram which shows a distal left main disease, a stumpless LED ostial CTO, and a subtotal LCX ostial lesion with no antegrade filling of the LED. She had good collaterals from the RCA up to the mid-LED. Considering the long length of the lesion, probably more than 20 millimeters, and an ambiguous proximal ostial LED stump, her JCTO score was 2. We discussed CABG with the patient and relatives, but they opted for PCI. And with all humility and meekness, considering the skills and clinical acumen of my mentor, Dr. Himanshu Gupta sir, who was actually the primary operator of this case, I think they made the right choice. I would also like to point out that this is a successful PCI case. I'm not sure why it has been put in this session. Coming back to the case, PCI was definitely a difficult option in this case scenario. And despite having an ambiguous LED ostial stump, we did not consider retrograde approach because we had no support from the left system and we could not afford to mess up with the right. So after hard team discussion, we went ahead with PCI. We took bilateral femoral access for dual angiography, engaged the left system with a 7F XP 3.5 and right with 6F JR 3.6. We secured the LCX with a safety wire, which was Sean blue in this case. We were lucky enough to cross the proximal cap quite early with the support of fine cross microcatheter over fielder XTA wire. And as we can see, the wire is in the septal, which was also confirmed from the contralateral injections. We were quite assured at this point of time that we are in the true lumen. The subsequent path seemed to be calcified and we were not able to negotiate it with a fielder XTA wire. So we escalated the wire to Gaia 2 and we were successfully able to wire up to the distal LED. And this was confirmed with a contralateral injection which showed that we were in the true lumen. We exchanged the hard wire with a workhorse wire and we went ahead with the left main bifurcation PCI, which was the only option in this case. And our approach was mini crush. We pre-dilated LCX, stented it with a 3 into 20 mm drug-eluting stent, crushed the LCX stent, stented left main to LED with a drug-eluting stent of size 3.5 into 28 mm, did a port with a 4.5 NC balloon, recrossed LCX, performed final kissing balloon inflation, and then did the final report. This was the final angiographic result, which was quite satisfactory. We regret that we could not perform intravascular imaging in this case because this was done quite long back, probably 5 years back, and we did not have that facility at that time. But we were happy with the final results. There was TIMI-3 flow with no peri-procedural complications. So my take-home messages and what I would like to convey through this case is that osteal LED CTO is a difficult and indeed a very different problem which requires very careful attention to avoid on-table catastrophe. Additional subtotal LCX lesion makes the options very limited. Retrograde procedure in such situation is a very high-risk option, and antegrade 2-2 wiring followed by bifurcation treatment is the safest approach. One must anticipate problems and consider safety, patient safety in these procedures. Imaging is, if available, definitely should be used. We ourselves are avid users of intravascular imaging, but unfortunately it was not done in this case. Finally, a disclaimer that banana left main is actually not a textbook term. I also searched for it in the internet for quite a long time when I was going through the case. My mentor felt that the left main looked like a banana angiographically, and as a fraternity is very well known to draw parallelism between food items and the angiographic or histological appearances, so that's how it was named. Thank you.
So actually banana was only for the left main. Huh? Circumflex has what? And banana with?
Branch.
With a branch of banana. I don't know what the branch.
Which is about to fall.
Small questions. I just, because he told I can ask questions, but I will not put mark for this failed in this, whatever is that. First point is actually, the circosteum. If you are unsuccessful, what are the options you will do? LED CTO is not opened up. What are the options will you do?
If this case was done now, we would have...
No. Your case was done 5 years back. That time you are not even a resident there. So you told you are a resident now. Actually, that means 3 years plus 1 year, 4 years. So you are not a resident that time. But I'm just telling that, what are the LED ostium is not possible to be done. You told the patient is not willing for cabbage. Your option is to just do something to the patient. In that situation, if LED cannot cross, what are the options?
We could have just entered left main to LCX.
Or will you try retrograde?
We could have tried retrograde, but it has got its own share of complications. Yes, retrograde would have been an option. But
will you do only to LMC to circumflex stenting?
Yes, that is a feasible option.
But actually, I was telling that when you put a wire into the circumflex, even if LED ostium is not opened up, you should have opened the circ ostium. Then you should get some flow to the circumflex, and your working on the LED will be much easier. You're actually damaging once you put a wire into the LED. If it is actually that flow is also your wire is not going to circumflex. Circ could have dilated. What is the problem in dilating circ? I think you understood.
Yes, I got the point, sir. Yes.
That is what actually. The second option is actually naturally the retrograde option. Even if the patient is definitely not willing, there is only one option left out is LM to osteal circ intervention. In that situation, circ opening is not a bad choice. It is very well done actually. Even if the imaging is not done, the vessel size, whatever is created by without imaging, is looked like an imaging intervention.
It's a good case. This is done about 5 years back.
Yes.
Do you have any follow-up of this?
Yes, sir. The patient is in our follow-up, is doing very well.
So clinical follow-up.
Yes.
Good case. How did you get into the ostium? Was it by probing at the probable area?
Yes, sir. That was what we thought about. We just probed it, and we were lucky enough to cross it within 30 minutes.
What is the percentage for the case?
No, chronic stable angina. She was symptomatic for the last 6 months, and she was on optimal medical treatment. Her TMT was also strongly positive, as I had already told.
But the chronic stable angina patient coming to you with 6 months of angina?
No, we were on the follow-up. We were escalating her therapy.
With unstable angina. Boss, there is enough time. And just 1 or 2 questions.
She presented with stable angina to the OPD. She was not having any rest pain. She was having class 3 angina for last 6 months. So the first time she presented to us, we got her a TMT. We were not sure how much angina she's having.
Stable angina is progress to the class 2 unstable angina because class 3 angina for the 6 months.
Yeah, so she's a
Ostium actually the occlusion of the lady was actually probably
chronic.
a long time we don't know.
And
But
circ was the new.
disease what are
Yeah.
a culprit lesion now. That is what I just
Yeah.
wanted to understand.
Circ was the new lesion. Yeah.
Patient symptom progression was probably due to the
LCX.
LCX.
Yes.
That is what is actually I just wanted to tell you.
So you did the TAT in your institute or it's done outside?
The TMT
it
was
was
done
done
in our institute.
TMT was strongly positive.
Was strongly
So
positive.
there is a chance of patient would have been collapsed on the TMT.
Definitely. There was a chance I also collapsed when I did the angiogram.
These are all actually questions which is coming to my mind. My knowledge is very limited, so I to understand from the people I'm just asking questions.
I think
Never think that I am actually
it's not
looking
recommended
into
when the
it.
patient has rest
It's the way I
angina,
ask
but
questions.
in class 3 symptoms we can perform a TMT. She did not
So
have
without
rest
seeing a
angina.
patient, you would actually you are presenting a case here. Wonderful. It's actually for the organizers, you know. I'm actually part of the organizing committee, you know. Thank you very much. It was a wonderful case and nicely done. The result is very good. Actually, accidental entry, you know. I did not
No,
put them
no.
on.
It was very wonderful session. I request all, sir, Pratap sir, 1 minute. I request all the participants who have you have presented the CD sessions to get a group photo here. It's for remembers. I even request Prof. Hamakata, please join the photo session. The presenters, the CD presenters, please come on to the dais. Those who have presented, it will be remembrance for your life.
I can stand with Hamalaka. It's a good chance, you know.
In hall B2, the sessions were planned as if like when you are in a hall B2.
Actually, he is the Kyoto hero. There you please come. I like you like anything. But
Presenters,
at the same time,
come.
you know, I criticize you.
So that you will be getting enough knowledge on the CTO counterpart. The sessions are planned like.
Actually, whenever I'm sitting here, you know, usually people mentally prepare for critic analysis.
No, it's always, sir, your suggestions are always welcome. It's how the junior faculty learns from you. It's always welcome, sir. We have learned from.
One thing I want to tell you that Kyoto is actually 50% of the Kyoto belonging to this Hamanaka.
Oh, no.
He's the richest man. You know? Richest man. Next time I'm going to Kyoto and only to see Hamanaka.
Yeah.
Here is the temple city.
Temple city. Big man. You are actually standing with the richest.
Yeah.
Boss, he is the richest cardiologist in Japan.
Congress.
Boss, you take a good photograph. We are standing with the richest cardiologist.
Thank you.
Thank you very much.
Great session. Thank you very much.
Great. Questions are good. My questions are good.
Yeah. Perfect.
No, just.
Narendra Modi is swearing tomorrow.
Singapore.
Swearing with one minister from.
Okay, yeah. Nice to hear.
No, I have to go into the main stage with 17. I have to prepare mentally what to talk. 3 minutes only the time for speech. 3 minutes.
Thank you.
Thank you all. Please join for inaugural session. Please join for inaugural session. Thank you very much.